and give us a signal.
Yes, we have already started.
Yeah.
We can go ahead.
Okay. Thank you. Good morning, everyone. On the behalf of the organizing team of this wonderful Diabetes India 2021, let me first welcome you all who have joined here and on the other platforms, also streaming platform. So thank you for joining. And we are having a wonderful third day ahead today. And we have plethora of knowledge sharing presentations and debates and discussions are coming up. So I hope you all will be joining here and throughout the day. And I thank you again for joining here. And we are starting with this Sunday morning with wonderful debates. Whenever we are starting with debate, there should be lots and lots of discussion going on, and there will be rebuttal also. So we are having the first session today, and to start the session, I would like to invite our today's rapporteur, Dr. Ajay Prajapati sir. Sir is consultant physician, diabetologist and metabolics physician from the city of Ahmedabad. So I would invite Dr. Ajay Prajapati to invite our chairpersons and start the proceeding of this debate.
Thank you, Doctor. Am I audible?
Yes, perfect.
Thank you, Doctor, for kind introduction. Today we have a wonderful debate that will going on and on for next couple of hours, and that will be debated by great doctors who are in practice. And we have chairperson Dr. R.R. Singh, who is from uh, uh, I think Jhansi, and Dr. Abhijit Jadhav, who is from Mumbai, and he will chair the session. He will go ahead for a further flow of debate, and I will hand over the session to our chairperson. R.R. Singh, Dr. Jadhav, are you here?
Yeah, I'm here.
Okay, sir.
Okay. I'll introduce a very good friend of mine from Mumbai, Dr. Altama Sheikh, a very young and eminent endocrinologist. He's practicing in Saifi, Masina, Raheja, Prince Ali Khan. He's running infertility clinics also, and he has postgraduated from Mumbai and DNB from Mumbai itself, and he's a fellow of IIT, FASI, and PGDIC. He is a co-author of India and Abroad various peer-reviewed articles and journals, and he is in the scientific committee of many journals. And he's basically again he won the first RSSD award for excellence in diabetes care in 2018 Maharashtra, and he got many awards as a state ranker, distinction holder. Quite well, he's a rising star of 2020 and section editor of Diabetes Monitoring 2017, Diabetes India, Sadikot, and speaker for various national as well as international conferences. And it's my pleasure to invite same time Dr. Suresh Damodaran sir. He is a consultant endocrinologist, and he's from Sri Ramakrishna Hospital, Coimbatore. He's honorary consultant at Derryford Hospital, Plymouth. He's MBBS, MRCP, CCST, and again he has done basics postgraduate studies from major studies in England. He conducts annual conferences, international conferences, Decon, Paradecon every year. He is awarded with Donald Etzler International Scholar presented by International Diabetes Center, Minneapolis, Minnesota, US. He is currently elected as the Executive Council member of Endocrine Society of India. He's currently Vice President in Tamil Nadu Endocrine Society. He's awarded by International Symposium on Diabetes on India Academy Diabetes Award for Outstanding Contribution to Diabetes Education Award on January 2019. He has presented many very publications, abstracts, international journals, meetings, and he research is mainly on advanced glycated end products and arterial stiffness in type 2 diabetes. These are our first speaker for today's session in the morning. And they're going to debate on GLP receptor versus SGLT2 primary prevention of cardiorenal events. Over to you guys.
Thank you so much, Dr. Abhijit Jadhav. And thank you, Diabetes India, for inviting us for this particular debate. Is the slide visible now, Dr. Abhijit?
Yes, boss.
Perfect.
Okay, thank you so much. So as I understand, I have to speak for 10 minutes, and will I be given a bell of at around 8 minutes or so? Some indication or somebody will just pop up in between that 8 minutes are over. I have to speak for 10 minutes, right? Okay, so we fix up this time. If okay with Dr. Suresh Damodaran, 8 plus 10, 8 plus 2.
Yeah, well,
yes.
whatever our, yeah,
Yes,
no problem.
Okay. So here I go with the permission of chairpersons. So we're going to talk about GLP-1RA versus SGLT2I inhibitors in primary prevention of CVD. Now, there is no conflict of interest for this particular talk. However, the agenda is here. See what CVD and its risk, primary prevention, what do we need to do? What are the various GLP-1RA molecules? Which aspect of CVD, which molecule does affect over there? A special category of metadata of primary prevention, which is not yet there in the articles published, but which we have dissected specially for this particular debate. I think that was one of the mottos to understand this particular science. What exactly happens with GLP-1RA versus SGLT2I guidelines from 2016 till 2021. And again, to show you with evidences that GLP-1RAs are stronger, robust, durable, better, and longer. Diabetes with chronic complications and implications, and we need to just not treat the diabetes as a value of a number of glucose. We need to get the complications under control, and there are various relationship between a lot of factors. So let me tell you at the outset that it is the kidney which also needs to be protected to also protect the heart. Number two, that the high risk, the moderate risk, as well as the mild risk, all people, those who are into this kind of risk category needs to be taken into consideration. And I'm sure that Dr. Suresh will show you some slides which he will say that the study did not have this kind of criteria. So I will show you the studies which had a very strict criteria also for primary prevention and broader range. So here I show one slide which talks about various GLP-1RA, and to state that Rewind was the trial which had approximately 68 to 69% of participants which were having broad range of risk factors for primary prevention. This is one of the important study. Also, leader and sustain, as you move ahead, I'll show you what was the percentage of primary prevention in them and how much they fared better than their particular comparisons with placebo versus others. So these are some evidences where SGLT2 also has been shown to have comparison with primary prevention. And importantly, as we look over here, there were female participants which were more in the dulaglutide arm in Rewind trial here, which is not there with SGLT2. So a broader range of sex, broader range of age, a worsening HbA1c and pre-existing cardiovascular disease, which was out for many, but we have a lot of data, around 69% of population from Rewind and various other populations from oral SEMA, injectable SEMA, and liraglutide. So this is what the parameters have an effect on A1C and on weight compared to others. It's a very simple graph showing, and I think this was one from the 70% of dulaglutide study that the 3P MACE was relatively reduced risk of 12% despite the majority of patients not having established CVD, meaning that most of them had a CV risk factor and they were treated. And as the data goes ahead, this shows that all the components of 3P MACE had reduction, and this study came out very positively for primary prevention. Apart from that, there are studies which I will show you now about. If you look at this graph, it looks like SGLT2 are the best in the MACE, but it's not like that. Let me show you the data on MACE, the primary risk factor prevention on MACE, and look at the enormity and robustness of the data when you add just one study. Here, this blue mark shows only the data from Rewind compared to all other GLP. So if we add the primary prevention data from Sustain 6 of 20%, from a leader of around 20%, and from oral semaglutide studies, this arrow grows much bigger and bigger. And this data, my dear friend, is not really there for SGLT2. And if it is there, you look at the arrow, how small it is for just one particular thing of heart failure. But for MACE, there is no data of SGLT2. And if at all the data is upcoming, if Dr. Suresh shows you, it is not going to be as robust as the GLP-1RA. And I think this is first part of my talk where I show actually how there is an anti-atherosclerotic, anti-inflammatory, and the endothelial modulation which helps in protection of CVD with MACE. Now, he will talk about a lot of heart failure. Let me tell you when heart failure will happen in a diabetic cardiomyopathy. These are the risk factors. We are talking about primary prevention. So look at the dyslipidemia, hypertension, diabetes, obesity, and others. This is where we need to protect the patient first. LV remodeling may happen quite late. Symptomatic heart failure will happen quite late. In at least 90% of the patient, it is going to be just the control of myocardial infarction, the atherothrombosis, the ischemia, and the atherosclerosis. And this is what Ralph DeFronzo and similar co-authors have talked about, that this is what we need to harp upon in the initial years. Now I'll show you data which has not been published in all these studies, but we've dissected for this particular debate. The primary composite for leader, as shown here, is actually in favor, which is in favor of liraglutide. The particular lines in the gray that you see, we've dissected for only primary prevention data, only primary prevention population to show in this, and it does show that there is a benefit in occurrence of CV death, there is a benefit in non-fatal MI, and there is also benefit in non-fatal stroke, which talks about the primary prevention. Even in SUSTAIN 6, although it did take 60-70% of secondary established CVD, this data is about the primary prevention that we've dissected again, and it showed quite good amount of significance for protection of 17% of SUSTAIN 6 population over here. And in subject with CV risk factor, if you see here again the line how semaglutide protects the MACE, and it also protects to various other risk factors. And this is how is the modification of the risk in atherosclerosis, which is a direct effect of GLP-1 RA, and not a single SGLT2 has this kind of action, and that is what makes GLP-1 RA more robust and more good data. So data on all the four, as you see in the four blue arrows, is there. Effects on BP weight and A1C, and importantly, the lipid data that GLP-1 has is not seen with SGLT2. They do not have a favorable lipid profile, and that is what again makes it more a better molecule for primary prevention of CVD risk factors in diabetes patients. And that's the reason even ADA 2021, just not a first thing which has happened now, it has been there past around 5 years that this molecule has been up. Now we will talk to you only about that this criteria was very broad in CVD. So let me tell you, the SUSTAIN, LEADER, and PIONEER studies, and the SOUL study, which is coming with oral semaglutide, has got very strict criteria about renal impairment, about the lower extremities and vascular stenosis, which also talks about a very broad range of primary risk factors. This is what we were alluding to, that it has been now around more than half a decade that these molecules are shown to be beneficial in primary prevention with various bodies like ADA, EASD, RSSDI, and Diabetes India, wherein when you look at the data on atherosclerosis, these are completely better molecules. These are molecules to be used with additional risk factors who require glucose lowering therapy, initial lifestyle modification, and metformin, and it is completely reasonable to initiate these molecules. So there might be a tussle about oral versus injectable. So let me tell you, oral completely semaglutide is on the way, and we have studies, and we have there is a PIONEER study and SOUL study also comparing oral semaglutide with empagliflozin, wherein oral semaglutide was better. And there is also oral SEMA with a liraglutide trial, wherein again oral SEMA was better. So there is nothing like these are only injectable. That point is completely well taken. And this is how I think I would want to rest the case, and I want to finish well in time, that for primary prevention, what you need is reduction of risk factor. And there is a complete, robust, and stronger data for atherosclerosis, anti-inflammatory, and modulation of endothelium with GLP-1 RAs. They decrease all the traditional risk factors of reduction in weight, better than SGLT2, reduction in HbA1c, 1.3 versus 0.8, better than SGLT2, reduction in systolic and diastolic blood pressure, and reduction and a favorable lipid profile, which the lipid profile effect is not there with SGLT2 at all. There are treatment options available which can be given just once a week. There is oral option available, and which is better than in recent studies compared to EMPA and LIRA. There are narrow as well as broad definition of CVD in primary prevention, and data with GLP-1 RA is available. The longest study was 5.5 years long data we have, and these studies of GLP-1 RA, one study has taken up to 45 to 50% of women. So we are sure that generally in CVD prevention, women participants are not there. So here we know that there's a strong data there. There is an expanding indication for prevention and managing CVD with GLP-1 RA. in non-diabetics, in rheumatoid arthritis, in HIV, in other autoimmune diseases, including type 1 diabetes. And this is how these drugs are going to really take care in future once the oral series includes and comes completely into market. And if when we count heart failure as one of the issues for primary CVD risk prevention, then there are many options to treat heart failure, including there are a lot of options for diuretics. I think if we look at the primary prevention risk factors, the risk factor and primary prevention that goes in favor of GLP-1 RA. And with this particular line, I think I hand it over to chairpersons. Thank you so much.
Can you stop sharing the screen?
Yes, doctor.
Is it visible?
Yes, you can start, sir.
Yeah. Good morning, everyone. Thank you very much for the wonderful opportunity, Diabetes India, and we had a wonderful evening last night as well. And it's nice to debate with my good friend Altamash. So I think in next 8 minutes or so, I have a responsibility to drive home the message that SGLT2 for primary prevention of cardiorenal events. See, the point is the main point that we need to discuss is the topic is SGLT2 or GLP-1 for primary prevention. It's not only for cardiovascular disease or for 3-point MACE or anything like that. We are talking about a broader term, and we are talking about a primary prevention of cardiorenal events. So that is the topic. So just to remind you, so this is my agenda. So just introduce the SGLT2 and then why there is a need of primary cardiorenal protection. And I'll put you some practical case, because after all, the debates has to end up with some practical points. And SGLT2, what are the things available and cardiorenal data that is available with SGLT2, and I summarize that. So if you look at the last half of the decade, there is more of a major complications like stroke, lower extremities, amputation, and end stage renal. That has been substantial increase in that. And the future is being darkened with the resurgence of vascular complications and also evidence of heart failure, which has been missing in the previous talk. So if you look at the life expectancy, that has been almost declined since 2014, primarily because of cardiometabolic risk factors, and also the older people, especially the type 2s, are vulnerable for CVDs, and it is remaining a leading cause death globally. So that is the thing that we are talking about, and needs a major policy challenge for most of the countries. And a good friend was talking about MACE, but I think if you look at the estimated MACE, only 9% of the risk of estimated MACE is eliminated after achieving the best glycemic control. So if you do even a best glucocentric glycemic control in type 2, and the risk of heart failure is not influenced at all. And the evidence of concepts like the risk of vascular events is definitely persisted in spite of intensive. That's why we see deaths even after the intensive glycemic control. So we know that type 2 diabetes is like a heart disease. We know that that is historic, but I think the definition of secondary prevention usually refers to patient who suffers from previous acute ischemic event, where all the other categorized as a primary prevention. So this is the risk stratification. So very high risks or previous cerebrovascular event, on the high is clinical or instrumental evidence of CVD, and moderate high is multiple risk factors, and mild one is the five major variables. I think my friend has touched based upon this. So I'll put you in the practical case scenario that we face up in our clinic. So this is a 52-year-old man with metformin, glycoside, and a gliptin, 8.2 A1C, and 66 of body weight. And there is no other comorbidities, whether family history of CVD, whether we should go for SGLT2 or GLP-1. I let the crowd decide. So the second case scenario is a 58-year-old type 2 being followed up as a master health checkup. She's currently on metformin and a sulfonylurea, and A1C is 8 with a body weight of 60 kilograms. Would you start on a GLP-1? And that is the thing. So it's nice to see the data, but when it comes to practice, how you handle it. So again, a 47-year-old type 2 sales professional metformin, sulfonylurea, and a gliptin, 8.7, and the body weight is 72 kilograms. Vildagliptin was stopped and liraglutide was initiated. There is GI symptoms. What would you do? So whether you continue with GLP-1 or switch to SGLT2. So just coming to SGLT2, this is the latest drug that is being talked about, and it's a the drugs available. Most of you would know, and there are few drugs waiting to be approved. And India, remogliflozin has been approved as well. So there is growing indication of SGLT2. Where are we doing is like more of uncontrolled type 2. My friend was showing all the guidelines. If you see the first drug that is mentioned even before GLP-1 is SGLT2. So it has been widely used nowadays, and uncontrolled type 2, despite metformin, you can add on the indication of SGLT2 is growing. So why it is very important drug now with the current scenario with growing cardiovascular disease and the challenges what we face, because it's a mechanism, the cardioprotective mechanism. This drug is being taken up by even cardiologists nowadays, and it's being used as a drug as the whole approach to the vascular organ as a whole. So it decreases arrhythmia as an anti-inflammation, and also high EPO with oxygen delivery, interstitial fluid, this thing. And then from diabetes point of view, increase insulin sensitivity and adipokine regulation. And overall, there is a good response, a direct and indirect effect, as Dr. Altamash was mentioning. So there are good indirect effects with these drugs, along with the weight loss, which is obvious with these drugs. So, and how about the kidney? The kidney, there is renoprotective, there is a direct and indirect effect again. So directly the improves the GFR and it reduces the renal oxygen consumption, and then inflammation in kidneys also being reduced. Therefore, there is a good improvement in the blood sugar and blood glucose, and then uric acid level. You see it in the practical usage when you have a metabolic syndrome sort of patient coming in, and then with high uric acid and probably everything going out of the roof with BP and blood sugar, you will see the huge difference just primarily because of the action in the kidneys. So these are the broader terms that Dr. Altamash was showing about the GLP-1. But if you look at the broader term, this is the mechanism. There is specific effect for SGLT2, which makes completely different from GLP-1s, or the diuretic effect, natriuresis effect, and also the interstitial edema, EPO, erythropoiesis formation, and ketogenesis, which is good for the heart. And but if you look at the specific effect of GLP-1, he went through antioxidative, anti-inflammatory, anti-atherosclerotic, and albuminuria. So those are all there. But I think if you look at the common effects, these are all the common effects. But I think the specific effects is targeting kidney and heart will be there in SGLT2 inhibitors. So, and now I've spoke about the practical approach, how you approach, and then coming to the cardio-renal outcomes of the evidence what is available. So if you look at the RCTs and CVOTs has been done across cardiac and renal continuum, huge amount of data come in with all the group of drugs. Even ertogliflozin has come out with Vertis CV. So Canvas is there, Declare-TIMI, Emperor was there, which changed our practice. It's a and then Emperor and DAPA HF has come out. So, and then the Credence and DAPA CKD was published in last ADA. So the data is huge. So it touch based on mostly atherosclerosis, subacute MI, heart failure, albuminuria, microalbuminuria, end-stage kidney disease. Whole lot of things has been covered with SGLT2s. So if you look at the Dr. Altamash was showing about the primary prevention, which is there with dulaglutide, completely agreed. But I think if you look at the numbers, the SGLT2 numbers for primary prevention, that is included, especially the Declare-TIMI, so a huge number of patients has been included as a primary prevention. That is the patients that you and me see in the daily clinic. So if you look at the overall benefit for okay, hospitalization, I'll finish off in a couple of slides. So overall benefit seen in hospitalization, it's been huge improvement in all the studies that has been done with with SGLT2. So he mentioned about MACE. You can see the data that has been in front of you, and you can see the heart failure data. There is almost nothing for GLP-1, and then the DKD almost nothing for GLP-1. So with that, I think you can easily say that the MACE, he showed this picture, but I think SGLT2 is better poised than GLP-1 for primary cardiac and renal protection. So with that, I stop by saying the management of type 2 has moved from a glucocentric approach, and we should look at the long-term benefit. That is the topic. You go for primary prevention, a non-glycemic benefit, and you have to get buy one, get five free. And that happens with SGLT2 with extremely good data. It is not like without the data. We are talking about drugs that is going to come in the pipeline, but I think we need to understand for practically now, it is only the oral oral GLP is not available. SGLT2 is available, and the GLP-1 has got definitely a terrible GI side effect, which everyone will agree who uses in our practical testing. So I stop by saying for primary prevention, for cardiac and renal, SGLT2 are the best evidence available now and best practical experience we got now. Thank you.
Dr. Altamas, you are on mute. You need to unmute.
Please
Click
allow
one.
me to share my slide, the rebuttal slide, with the permission of the chair.
You can share, sir.
So I think very elegantly he did talk about the cardiorenal, and I did show you first 3 slides of my talk about the kidney, wherein the data was shown and how important it is to get both cardio as well as renal factors down. Number 1. I think very importantly, he also misguided everybody by showing 3 cases, and the third case was completely misguiding. The patient will come back with nausea, vomiting after 2 weeks. I think the education of the patient is very important over here. We need to start with low dose, stay low, and only when the patient is tolerating, we increase the doses of GLP-1 RA. And also, patients do come back within 2 weeks or 3 weeks. In fact, some patients call in 2 days also with SGLT2 eyes. I think that was a start note of it. So I'm just trying to give that as the first rebuttal, that GLP patients on SGLT2 also do talk about side effects. They come with nocturia. Some people call and say that we got redness of our genitals. So I think this point is to be taken, and with a simple patient education, it does not matter that how much nausea you would get. In fact, it is the effect of the drug that you will get nausea, and you will not be allowed to eat automatically when you have that much amount of food. The second thing was my friend showed very glaringly that 58% of dapagliflozin. I again want to emphasize it to the audience and the esteemed chairpersons that Rewind trial dulaglutide was 69.5%. Now, if he has to show that dapagliflozin 59, I would definitely talk about 70% of Rewind, which is a more robust data, a broader and simpler important risk factors taken, 17% from leader and 20% from sustain, which actually had data. So if you look at only percentages, Canvas had 27% and DAPA had 59, but here we have 17, 20 and 70%, 70% from GLP-1 RA. So that is again important data in terms of numbers if you are believing that slide of his. Number 3, cardiologists are comfortable. They started writing GLP-1 RAs faster and better than even when the SGLT2 inhibitors came. So I think comfort-wise, we do not have an issue over there. Again, longer data. He did talk about only atherosclerosis, but endothelial modulation was completely missed out somewhere. And I think that is something very important to understand, that what effect this drug can give for cardio and renal protection combined. All SGLT2 together cannot give, because there is one meta-analysis which has compared all GLP-1 with all SGLT2, and there also the primary risk reduction of risk factor was stronger, better and durable compared to all SGLT2. I think these 3 are very important. And the last graph, what he showed, I'm done. I have covered the secondary prevention graph, but to mislead the audience, he again showed primary as well as secondary, wherein there were a lot of blue arrows for SGLT2. So the first slide of that main blue big arrow was only for the primary risk prevention for cardiac and renal. Over to chairpersons. Thank you.
Okay.
You can
Can I?
stop
Oh,
sharing
thank you.
the slide.
Yeah.
Sure. No, I don't have a slide to just share unless I want to share the last two slides, but I'll just be very quick in just mentioning that the topic or the debate is about uh, primary prevention for cardiac and renal. If you look at both the data, the cardiac and renal wise, definitely SGLT2 got a much better. And I showed the practical experience. That's the second one about a patient coming back with the GI symptoms. Even if you do in a better way, just even a small dose going up in a big way, they do have a GI side effects, and that's a practical thing. And I agree there is SGLT2 has got its own effect, but I'm just putting as a case scenario. And the third one in India or anywhere in the world is the cost. And the cost, which we never discussed about for getting a primary prevention done, how long you're going to be on the injectable for a very long time. Yes, we are talking about semaglutide going to come in, but that's not going to be cheap either. It's going to be expensive, and it's going to be just putting on for primary prevention patients like India for a very long duration. Now in India, the new gliflozins are all launched, and then it's out of patent and everything, so it's cheaper, much better, with a lot of evidence coming in for cardiac and renal both. So that is one of the practical thing which we derived from the science and practical experience. And for India, I conclude the debate by saying, for primary prevention and cardiac protection wise, best evidence lies with SGLT2, and for practically the usage will be much better with the oral tablet and cost-effective way. Thank you.
Dr. Abhijit, a quick comment, and we can proceed to the next.
Thank you both, Dr. Damodaran sir, Dr. Altama sir. Now we'll move to the second session by Dr. Sunil Kota versus Dr. Tejas Shah. And can we have the introductory PPT for Dr. Sunil Kota sir? Yeah. Dr. Sunil Kota, he is DNB Endocrinology, MD Medicine, and MBBS from Vijayawada, and he has helped numerous patients for last 13 years of his clinical practice as an endocrinologist. He's an awardee of AACE, that is International Travel Grant, ESP, and ISPAT travel grants, and he's a member of AACE, ISPE, and Endocrine Society of India, American Thyroid Society, that is ATA. Dr. Sunil Kota from Behrampur gonna talk on talk with Dr. Tejas Shah, and that topic going to be, should HbA1c still the main target for treating type 2 diabetes? I'll introduce now Dr. Tejas Shah, good friend of mine from Mumbai. Tejas slide. Yeah. Dr. Tejas Shah is honorary diabetologist at SL Raja Hospital, Fortis, Mumbai, Mahim. He is a director of IVA Diabetes Care from Mumbai. He runs a diabetes center in Malad and Andheri. He is visiting teacher, faculty of fellowship diabetology in Dr. E.Y. Patil Medical College, Navi Mumbai. He's a founder, treasurer of United Diabetes Forum, organizer, scientific committee, faculty of CID 2014 onward till date. He's a faculty to teach CPS diabetology students, speaker at various national conferences like CID, RSSD, IDCON, Diabetes India, DIACON, and IDIACON. He's practiced in the last 22 years. Don't go by his age. He looks much younger than his pictures given in the CT. And let's start the debate now. Over to you.
Thank you so much, sir, for those very kind words of introduction. Just let me know once it is visible so that I can start it.
Yes, sir. Yes, sir. Perfect.
Yeah, thanks to the organizers for inviting me over here and asking me to talk in favor of HbA1c as the main target for diabetes treatment. So as I was stumbling upon the literature, I could come across a lot of those markers, standard and non-traditional markers. But then HbA1c, as we all know, is the non-enzymatic glycation of hemoglobin, which reflects the blood sugar control over last 8 to 12 weeks, not perturbed by daily fluctuation, measured by HPLC based on charge and based on structure. It is measured by immunoassay. So it is a one versus many fight where I'm going to talk in favor of HbA1c. But then the slides that I'm going to take you through are the ones we displayed in front of you. First of all, the advantages as a marker. So as a marker, we want it to be independent, multifaceted, and targeted. And how that it does it fare as far as this particular aspect is concerned? Greater convenience, the patient did not fast, it can be drawn at any point of the time. The patient did not wait 2 hours after taking food. It is stable after collection because it is stated if the fasting blood glucose sample is not having adequate sodium fluoride, which is the antiglycolytic agent, it is going to reduce by 5 to 7% per hour, and it is also going to reduce with increasing temperature. It has got less day-to-day perturbation during stress, illness, diet, exercise, and smoking, etc. It has greater pre-analytic stability. You can see the variability is 5 to 10% for fasting blood glucose versus almost 0 for A1C. Non-inferior analytic variability both at 2%. The biological variability of A1C is lower, less than 1% for A1C versus 4% for FBS. The coefficient of variation, which again is very important if you look at the values, it is 3.6, 5.7, and 16.6 for A1C, fasting, and the post-glucose. And again, standardization of A1C, which is done by the NGSP and the IFCC, is not inferior to blood glucose assay. It is also stated that it also gives us an idea as to how does one individual person has the capacity to glycosylate. That is the GI glycosylation index, and the DCCT has told us patients having high HGI are more prone to develop microvascular complications in spite of normal blood sugars. What about for diagnosis? 1997, there was an expert committee which stated the HbA1c cannot be standardized, so it cannot be used for diagnosis. But then based on a review article in 2007, 2008, there was a recommendation from ADA and ESD that yes, it should be included in the diagnosis, based on which ADA has included it as a diagnostic cutoff marker for diabetes from 2010. And this is the DETECT-2 study, staggering 19,000 subjects. Here you can see beyond 6.5, there is a significant jump in the occurrence of retinopathy. Not only DETECT-2 study, others like NANES study, the UKPDS, DCCT, all have pointed to a threshold of 6.5. So what do we get? ADA 2021, 6.5 is the cutoff. Similar is the sentiment echoed by ASCE, World Health Organization, and the recent guidelines by RSSDI ESI in 2020, of course, in addition to the fasting and post-glucose test. This is a study on 1,011 subjects published in Biomarker Insights in 2016. Here, what I'm going to tell you is that there is a significant correlation between HbA1c and fasting blood glucose, and it goes on to say that HbA1c should be done in all subjects. But if the patient is pregnant and if there are conditions which give rise to alteration in the value of HbA1c, then only you need to go for fasting post-glucose. And it also shows on your right half of the slide that's beyond 6.5, there is a significant increase in microvascular complications. What about prediction of complications? DCCT, 1% reduction of A1C gives us a significant reduction of 30% microvascular risk reduction, 40 to 50% risk reduction of retinopathy. If you look at the UKPDS 35, it says 1% A1C reduction gives us 34% relative risk reduction of microvascular risk, 21% reduction in diabetes-related endpoint and diabetes-related death, and a 14% reduction in MI. And if you sum up all the major trials, either in de novo diabetes or the ones having advanced duration of diabetes, acquired advanced VADD, all of them have actually used the HbA1c as a marker to show reduction in microvascular, cardiovascular complication, and some have also gone on to show reduction in mortality. This is a study from 11,140 individuals, and it states that above 7% with incremental A1C, there is a significant increase in risk of macrovascular events. And there is a prognostic potential of A1C. In this study, it is found that HbA1c exhibits direct correlation with cholesterol, triglyceride, and LDL cholesterol, and an inverse correlation with HDL cholesterol. And what about coronary artery disease? In diabetic adults, yes, as per this study in 2014, even it predicts coronary artery disease in non-diabetic adults. This is a study in 2019, followed by 2020, one more in American Heart Association journal, which says above A1C of 5.6, there is a 17 times higher chances of cardiac stenosis. What about heart failure? With 1% increase in A1C, there is 8% increase in heart failure. Another study says compared to A1C7, where there is a 5% increase chance of heart failure, it goes up to 72% when HbA1c is greater than 10. And the recent paradigm heart failure study is also suggesting that HbA1c is a predictor for heart failure. EPIC Norfolk study suggests it is associated with cardiovascular disease mortality. And this study again is a staggering one, 11,092 patients. It is the 1% increase in A1C is associated with 30% increase in all-cause mortality, 40% increase in cardiovascular mortality. Also, it is associated with recurrence of atrial tachyarrhythmia. So if I point to any single marker which is associated with majority of complications of diabetes, my presumption, yes, the answer would be a big no. As a marker of treatment initiation, Look at the AACE, gives importance to A1C. ADA-ESD gives importance to A1C for oral and also for initiation of injectable drugs. And if you look at the targets also, they have pointed to A1C. It can be 7.7%, 6.5%, ADA, ESD, AACE, NICE, or IDF, all of them, including our very own RSSDI, ESI. And if you look at the efficacy of the drugs also, it is measured in terms of A1C reduction that they offer to a particular patient. Lastly, where does it stand vis-a-vis other markers? If you look at the routine blood glucose measurement, it is less accurate and precise than most clinicians realize. And 41% of instruments have significant bias from the reference method that would result in potential misclassification of 12% of patients. Pre-analytic error in terms of sample handling, if there is no proper addition of the anti-glycolytic agent, if there is high temperature, liability of glucose in the collection
1 minute
tube
left.
at room temperature.
1 minute.
Yes. Fasting blood glucose, A1C is a better reflector than the fasting blood glucose, more better associated with chronic complication, cardiovascular disease, microangiopathic complications, and 2-hour post-glucose has poor reproducibility. And if you look at the colorimetric is a challenging one, and it does alter with the serum protein concentration. Similar is the case with glycated albumin. Patients having altered protein level would also be affected adversely. There are no good studies which tells us that 1,5-anhydroglycerol is a good indicator. Again, it also gets altered in patients having altered protein levels. TIR, yes, 70 to 180, 70% should be the target, but then patient needs to be on, it is a complex method, patient needs to be put on a device, cannot be afforded by all, cannot be used by all patients, and different sets of targets for different class of patients. CGMS, invasive and costly, it puts additional educational practice burdens, and it doesn't give us real blood glucose values. It is the operation is limited after for a period of 2 to 7 days, so it will not be giving you a long-term reflection of the patient. Development of alarm fatigue, interfering substances, and high rate of discontinuation. What about SMBG? It only gives you real-time measure, but doesn't give you direction or rate of change of blood glucose level. Long-term glycemic control is not talked about. No action on nocturnal or asymptomatic hypoglycemia. Yes, that is the last slide. It is an accurate and easy to administer test, unperturbed by many factors. It is now standardized and less variability and pre-analytic stability than the glucose measures. It can be used for diagnosis, initiation of treatment, prediction of complication, and prediction of risk stratification as well. So yes, this is not the sole target for diabetes treatment. There are additional targets as well, but I would definitely try to say this is the main target which we need to look at. Thank you all for the patient listening. Over to Tejas, sir.
Can I share my slides?
Yes, sir. Yes, sir. Sir, you need to make it full screen.
Yeah. Visible?
Yes, sir. Yes, sir.
Yeah.
You can start.
Thank you. Thank you to the organizing team and Dr. For Diabetes India. Wonderful job, Sunil. I thought there was some confusion related to the topic with Sunil, because we are talking today about whether HbA1c should still be the main target. We are not comparing it with fasting sugar, postprandial sugar, diagnostic aspects, etc. We have moved beyond this. We are not going to talk about this HbA1c, which was discovered way back in 1968, because we have moved on in terms of our pathophysiology and in all way. So let me take you through whether it should still be the main target, and my answer is definitely no. There are certain important reasons. First of all, as he said, it has been used as a diagnostic tool for diabetes. But remember, there has been a lot of studies which have shown that it is not the ideal marker to diagnose diabetes. There have been variations, and fasting and postprandial sugars are a better predictor for diagnosis. The sensitivity is more than 50% with fasting sugar, more than 78% with postprandial sugar. A1C represents more or less the glycation of proteins, while the diabetes is a disease of hyperglycemia, following which there is glycation which occurs, and therefore we should be detecting it more with with glycemic parameters and not by glycation. The EDEC study clearly showed that there is a lot of variation when you talk about HbA1c and its correlation to mean glucose. At A1c of 6, it could be anything between 100 to 152, and at an A1c of 7, it could be anything from 120 to 185. And therefore, what happens is when we use such criteria, there could be an underdiagnosis or overdiagnosis that could be resulting in hypoglycemia or more risk of complications when we use these parameters to treat. Coming on to certain important trials, when he spoke about the accord and advance and VADT, let me be very clear that none of the trials showed a benefit by reducing HbA1c to 6.5. These trials, accord, advance, and VADT, clearly showed that when you bring down the A1c to 6.5 or below the intensive management, there was an increased risk of infarction, there was an increased risk of mortality, weight gain, more hypoglycemia, while at the same time, no major reduction in terms of cardiovascular events, fatal stroke or non-fatal MI or in any parameters. So clearly what it tells us is that it is not the A1C which brought or the target of A1C which helped in reducing the events further. When you talk about A1C, as it is a poor marker for to detect pathophysiologic abnormalities. Clearly, it has been shown that OGTT and 2 hours postprandial glucose levels are more sensitive when it comes to detect the pancreatic beta cell function. A1C is a poor indication of postprandial state, and we Indians, Asians, as well as all over the world, more or less spend more than 12 hours or 14 hours of time in the postprandial state. Poor standardization of A1C is known all over. Even in cities or metro cities, we still get laboratories who do not standardize A1C well and sometimes give erroneous results. And global standardization of A1C is still a long way to go. Abnormal hemoglobin traits are there, which really gives wrong results with A1C. There are several clinical conditions like malaria, chronic anemia, blood loss, hemolytic anemia, pregnancy, which all give different A1C results or may be giving a false high or false low results. Various clinical conditions like iron deficiency, B12, alcoholism, drugs, uremia will result in a falsely high A1C, while conditions the others like chronic liver disease and renal failure or pregnancy give a falsely low A1C disease. Biological variability is known with A1C. Things like mental activity, sleep, etc., all have an impact on our blood sugars. And postprandial and 2 hours postprandial blood sugars vary more than the fasting blood sugar. And in that way, A1C does not detect these biological variations that we have. So we have to look at number of factors and not A1C alone. The interday and intraday glycemic excursions, we need to recognize the hypoglycemia. We have ethnic and racial differences. So we have to look factors at beyond A1C, which we have to use in moving forward to target or to control our patients better. From the traditional triad of HbA1c, fasting, and postprandial, we have moved ahead. Now we are looking at the glycemic hexad, where we have the glycemic variability, the hypoglycemia, and the nocturnal hypoglycemia as the important markers which we have to look at when we are managing a patient with type 2 diabetes or type 1 diabetes. Glycemic variability is an important aspect. Again, overall, it tells us the variations in blood sugars that happen in a person interday and intraday. Clearly, it has been shown that two persons with the same A1C F8 may have a different glycemic variations on 2 different days also. And clearly, glycemic variability has shown a clear impact on cardiovascular mortality and morbidity. TIR has become the new standard talk of the town. There has been clinical consensus in various conferences, and in 2021, also the consensus has come out that we need at least 70 to 80% of our time should be in the time in range, which is considered to be between 70 to 180, 50 less than 25% in time above range, and less than 4% in time below range. And that has clearly shown a correlation to a good blood sugar control. And even trials like landmark DCCT trial, which Dr. Sunil also spoke about, when they have correlated the time in range with the DCCT, they have shown a clear correlation between retinopathy and albuminuria. They looked at the SMBG profiles of patients which were done 7-point SMBG every 3 months in the DCCT trial, and they showed that there was a 64% direct correlation or with better time in range in patients with in both the trials, and a 40% correlation for patients with microalbuminuria. There have been various clinical studies which have shown a direct correlation of TIR with chronic complications. These are various data where they have shown a correlation with retinopathy and microalbuminuria with every 10% decrease in time in range. There is a study with 2000 patients which showed a correlation for hazard ratio of carotid intima thickness with time in range, and showed every 10% increase in time in range improves the chances of or reduces the chances of developing intima thickness. Direct correlation with peripheral neuropathy, direct correlation with albuminuria. Indian paper also published by Dr. Bansi and Dr. Jyoti clearly showed a time in range of more than 70% relates to an A1C level of less than 7.5 in Asian population, and we are more or less closing and talking more about the time in range profile. SMBG, yes, there is no longer correlation. It is a misjumbled thing. Lot of data.
Sir, 1 minute. Sir, one.
Yes. We have three important trials done with CGMS, the gold, silver, and diamond, which have clearly shown that the correlation of CGM is clearly there in the gold study. It showed a better reduction of reduced time in hypoglycemia, improved hypoglycemia related confidence, and improved well-being and quality of life. The silver study correlated clearly patients again of type 1 and showed that significant A1C reduction of 0.35%, but reduction in time spent in hypoglycemia and hypoglycemic fear overall improved. The consensus or the ACE guidelines also tells us that CGM should be considered in patients who have not reached the glycemic target after 3 months of initial anti-hyperglycemic therapy, and we need to improve this the time in range overall over a period of time. So to conclude, the results of clinical trials really question the validity of A1C as a therapeutic target for type 2 diabetes. In the ACCORD Advanced and VADT, the failure of intensive glycemic control to reduce the CV risk again brought into question the usefulness of A1C as a therapeutic target. To determine the effect of inter-individual variation in A1C or its use as a therapeutic target, the use of individual A1C estimated using mean glucose determined by CGM should be validated. A1C only provides the measure of glycemic status over a period of 2 to 3 months, but it does not address the glycemic variability, the hypoglycemia, or the hyperglycemic peaks. CGM detects the day-to-day variability and is a target which we are going to see in the near future. We have to look beyond A1C over a period of time, and we should be moving ahead over this. And I don't think Sunil can argue against this man also when he approves this. Thank you very much.
Good one, Tejas.
Can I just rebut? I don't have any slide to present. Can I just?
Yes, sir. Yes, sir.
Yeah, actually, Tejas sir is too sweet to rebut against, but then I have to do my duty. नहीं तो बंसी सर फिर गुस्सा हो जाएंगे. Okay, first of all, I don't say other parameters are not good. They have to be used in addition to the HbA1c, but then whatever trials he has talked about, they are trying to portray other measures as supplement to HbA1c. If you look at HbA1c, it is the single marker which is helpful throughout the scenario, whether it is in diagnosis, whether it is in prediction of complication, whether it is a efficacy of the drug, whether it is the target for any particular therapy. But having said that, TIR is very good. But again, hailing from Barampur, place in Odisha, I don't have that much of opportunity to use CGMS or this TIR. But again, as I've already stated, this is the Brahmastra, the A1C, and Indrastra, Varunastra may be attributed to CGM and TIR. I think they all should be acting in unison to give the patient a better goal. But this is the major target that I would say, which is predictive of all the factors taken into consideration.
Thank you.
As I said.
Yes, nothing much to add to this. Only one or two points. What the studies that Sunil also showed in his data. If you talk about the UKPDS trial also, where it showed the benefits of A1C reduction, but remember when we dissect the UKPDS two parts, it had the 33, 34 UKPDS data. So both the trials, UKPDS 33 and 34, UKPDS 33 was done with insulin and SUs, where the reduction in A1C did not show a benefit in terms of macrovascular complications or in terms of all-cause mortality. And only the UKPDS 34, which was done with the metformin, showed an improvement or reduction in the all-cause mortality, in spite of having an A1C value which was similar in both the studies. So again, though the study was done so many years back and now we are retrospectively seeing, I feel it again showed that it was not the A1C level, but maybe the individual drugs which helped in that sense also. So our talk is again the same way, that maybe we have to go beyond looking at only A1C Only we have to maybe look at other markers along with A1C, as you said, and that's where I think we'll be able to target better. Thank you.
Jimmy sir, shall we start a third one?
Yes, yes, yes.
Yeah. This is our third.
You can conclude the debate. Your final comments on the debate, and then we can proceed.
Obviously we are using all the latest technology from Mumbai, but again, as Dr. Sunil Kota nailed it, no, from Behrampur, no, HbA1c remains to be the Brahmastra. Still, it is remained at all corners of the country as well. And and Tejas is a good friend of mine as a brother. I definitely agree with all his points. Same time, thank you for all those inputs. Now we'll move to the third one, shall we?
Yes, yes.
Yeah. Can we have the introductory slides? Yeah. Dr. Sunil Kota sir. Dr. Sunil Kota sir is from Noida. He is a consultant diabetologist and he runs Center for Diabetes Care at Noida. He's MBBS,
Hello.
DNB, FSCE, FRCP from Glasgow,
He is
Edinburgh.
Dr. Amit Gupta.
Sorry. Dr. Amit Gupta. I mean, Dr. Amit Gupta is a senior consultant diabetologist from Noida. He runs a diabetes care there. He is graduated and he's DNP, FSC, FRCP, FICP. He's a communicator director, ADA, Diabetes in Primary Care Interest Group, 2018 and 20. He's a committee member of AACE, Diabetes Disease State Network. He's a fellow of RCP Edinburgh, Glasgow, American College of Physicians. In his name, many awards are there. Few names too. National Health Awardee 2016, Diabetes Awareness Initiative Award, Investigators of Year 2018, and many more. And he's a speaker in many national as well as international conferences. And the next speaker who gonna debate with him is my good friend Ashish Dengra sir from Jabalpur. He is he running a Mahi Diabetes Thyroid Care at Jabalpur MP, and he has done a diploma in diabetes at Cardiff University. He's CPS diabetology. He has done many postgraduate courses in diabetes, and basically he is a president of Jabalpur Endocrine Society, organizing secretary for RCCI chapter 2020. He is vice president RCCI chapter. He's honorary secretary and founder of Mahi Diabetes Center, as I said, and he received various awards. He's been there on various dais, and as a presenter, he has had many papers on his publication, various national as well as international journals. So they're going to talk about, discuss two things here, whether to go for a flash drive or fight for it. So over to you guys.
Thank you very much, Abhijit, and nice to see you and on this Sunday morning. So over to Amit. Amit?
Guptaji.
I think Sir has lost connectivity. He has joined again. Yes.
I'm extremely sorry. I lost the connection at the wrong time. And,
You can start sharing, sir.
Yes, just let me allow share my screen. Just give me a moment. I hope the slides are visible to all of you. And the topic of the debate for today is, do we need BGM in the era of CGM or FGM? So let me begin with the debate. And so let me just introduce the topic. So it is very important to maintain a good glycemic control, as we all know that it is crucial in the management of the diabetes, and it is associated with the reduction in both macro as well as microvascular complications. And SMBG or the BGM, it provides the day-to-day blood glucose level, and it is a simple and practical tool for maintaining a good glycemic control. Although SMBG is widely practiced in other countries, its use is very limited in India. And this slide will show you that this is a data from our own publication from the RSSDI, that is Consensus on Self-Monitoring of Blood Glucose. And it says that the use of blood glucose monitoring is as low as 11%, and the data is old, and we are waiting for the new data, but it is again very, very low in comparison to what the Canada and the Australia and the US people are doing. My dear friend Dr. Ashish is supporting the call of the June 2021 as Diabetes Control Month, and this call has been made by our respected sir Dr. V. Mohan. And what Dr. Ashish is saying that everyone with diabetes should be encouraged to monitor their blood glucose sugar level before and after food. He said that they should also be encouraged to regularly exercise and eat a healthy diet with less carbohydrate. He is not mentioning that, he is not saying that we should be using CGMS as a tool for Diabetes Control Month. So what is the role of blood glucose monitoring in diabetes management? Role of blood glucose monitoring in diabetes management is that in the 1970s, in the late 1970s, when the glucometer became available, they have revolutionized the self-care in people living with diabetes. And the glucometers, they have become smaller, more accurate, and more widely available. They require now less blood, they provide reading more rapidly, and the lancets, which are used to perform finger sticks, they cause less discomfort than ever before. And BGM has provided valuable data that have helped many patients reach their glycemic targets. So BGM not only does this, it plays an important role in monitoring the plasma glucose on a day-to-day basis. It complements HbA1c testing in evaluation and monitoring of glycemic control. It allows us to monitor the day-to-day fluctuations, and measurement of 2-hour glucose level is a stronger predictor of cardiovascular disease as compared to the HbA1c. Studies have shown that. And crucial in the management of the insulin treated patient, especially, it is very important tool. And only a glucometer can detect acute hyperglycemia or hypoglycemia events, so that a patient can take appropriate action in coordination with their clinician. So let me just tell you what are the limitations of the CGM or the FGP. First of all, there is a lag between glucose levels in the interstitial space and levels in the capillary blood, so that the levels recorded by the CGM may differ from a finger stick glucose reading. Secondly, the patient may overtreat hyperglycemia simply because there is a repeatedly given insulin, because the glucose levels do not fall rapidly enough, which is known as a phenomena as a stacking. And the patient may also end up overtreating their low glucose levels because the glucose levels rise slowly with ingestion of the carbohydrate. So this is, if you use only CGM as a tool, then these are the risk factors that you may end up overtreating hyperglycemia, or you may overtreat hypoglycemia as well. Another important limitation of CGM is that most of the data on CGM or FGP is available in patients with type 1 diabetes. And there is much less research which is available in the patients with type 2 diabetes. And we all know that 95% of our patients have type 2 diabetes. If my dear Dr. Ashish friend recommends CGMS to all the type 1 diabetic patients, I will be happy to know that. But still 95% of our patients will require SMBG. No long-term studies have been performed to determine whether continuous CGM improves patient-oriented outcomes in type 2 diabetes. And even if there are certain researches, the findings are not consistent. They are either positive as well as both negative findings are available in the data. And there is a very limited evidence that it offers similar benefit in patients with type 2 diabetes. So these are the few limitations of the CGM. Another important thing is that there are few studies I would like to quote. In one study, the finger stick monitoring was compared with CGM, and it found that the HbA1c level, there was no significant improvement at 6 months in both the arms. In a randomized study, no difference was seen in overall or diabetic specific quality of life at 6 months. And while so what I would like to say is that more data is simply not equal to better care, and that has to be yet to be realized. Another important thing is that CGM would not be suitable for individuals who are dehydrated, who are in hypotension, in shock, or in a hyperglycemic hyperosmolar state with or without ketosis. It cannot be used for neonates or for diagnosis or screening of diabetes. And in many of these instances, interstitial glucose measurement may not be reliable because of the body fluid shifts. Another, for example, I just like to say that if you apply a CGMS like Freestyle Libre, it is not recommended for patients with hypoglycemic unawareness because it does not have real-time high or low glucose alarms. The Freestyle Libre requires user to scan it at a minimum of every 8 hours to capture all the data, because the on-body sensor only stores 8 hours of glucose data at a time. And this is a very important study which was published in 2018, and it gives us the reason why the patient who were put on CGM, they stopped using it, or why the people they were avoiding the CGM. And the list is very long. They believe that CGM is not as accurate as SMBG. It was not covered. It's still not covered by insurance. Uncomfortable to wear. Too many false alarms. Too expensive. Skin can be irritated by adhesive. Need for SMBG before treatment. Adhesive did not hold. Sensor came off. Frequency of sensor change, again alarm too frequently. Sensor application is painful. Too frequent calibrations are required. Not enough advice on use. Difficulty applying sensor. It is too invasive. Interfered with activities. How sensor looked on body. It was also a concern for some people. Too complicated to use, and concerns about infection, and it is not approved for dosing. And there are certain people who did not use it at all because they found it too expensive, not covered by insurance, likely uncomfortable, device attached to body, satisfied with SMBG, found it not as accurate as SMBG, too painful to wear, possibility of infection, not familiar with the CGM, and FDA says adjunctive use only. So continuous glucose monitoring in type 2 diabetes is not ready for widespread adoption. And as the question asked in the debate is whether CGM or FGP is going to replace BGM, I strictly say that it is not going to happen in the near future, because even those who will wear CGM, they will require BGM, and these are certain instances where people with CGM, they will require blood glucose monitoring. For example, if the data is not available during CGM system during the warm-up periods, so it is only the BGM which can help. There will be instances in which CGM systems may malfunction. Most of the CGM systems, sometimes they require calibration, and this calibration has to be done with a blood glucose monitoring. Patient living with diabetes also need to be able to verify their glucose. Many times the sensor comes off and is not giving the right readings. So when in doubt, what to do? So if they are symptomatic, they have to use a blood glucose monitoring system. And until we have research supporting CGM for the patient with type 2 diabetes, especially those not receiving regular insulin injections, there are no patient-oriented benefit to justify its great expense and additional hassles for patients and physicians. I would just like to say that there is ABPM is available for a very long time, but it simply does not replace the routine blood pressure checkup. It is as important as anything else. We have Holter monitoring and we have ECG also, but a Holter monitoring gives totally different information. It cannot be a replacement for ECG. We have X-rays and CT scan. We always know that CT scan is superior in technology, can give you more detailed information, but every patient doesn't require CT scan of the chest. This is me and Dr. Ashish. We are, though in debate, we are standing on the opposite side, but in real life, I am supporting a CGM device, and Dr. Ashish is monitoring the sugar of a patient with a finger stick device. So, do we need blood glucose monitoring in the era of CGM and FGM? I would strongly say.
Sir,
so, this is my last slide, and I would hand it over to the chairpersons.
Dr. Ashish, sir, we can start.
Yeah, Jimit. So thanks a lot to chairpersons, and hi, Amit.
Hello, Ashish.
Good morning on this Sunday morning, and it was a great show, the Diabetes India. And without wasting much time, we will be now listening about do we need blood glucose monitoring in the era of CGM or FGM after the Amit's nice pictures, and he is sharing my pictures also. So thanks a lot, Amit. And I will be saying that do we need blood glucose monitoring through glucometers in this present era? So I will be talking about no. So while we move on, do we really need to look behind the Purani Yade? Do you require Maruti 800 in the era of Mercedes or BMW, that is CGM or FGM? So why prick when you can scan? So what are the drawbacks of SMBG? It gives only a snapshot, no information on what glucose level have been or will be, or direction or change of glucose is not given by the SMBG. It is only a snapshot. Today, many patients do not achieve glycemic target despite focused efforts. And SMBG does not give you the trends. It gives only a single point, do not give you the whole picture. So the disadvantages are the finger prick is required, which is very painful, limited frequency of use, and hence it does not provide. My dear friend has already told that the limited use is there only 11% in India, and it does not provide optimal information to examine the glucose variability, which is very much important nowadays. We require time in range to prevent the future complications. The periods of hypo and hyperglycemic risk or overnight glycemic control is not shown by the SMBG glucose monitoring systems. Accuracy of blood glucose monitors depends on many factors like the strip enzyme, manufacturing consistency, temperature, humidity, altitude, interfering substances, and the hematocrit levels. We have seen in our clinics that patients are coming with the sugar reports of 400 with the glucometer, and in the lab it is coming 100. So there are many differences in the readings with the glucometers still in the Indian scenario because of the temperature, humidity of the test strips. And without additional trend information, patients are prone to increased glucose excursions and increased hypoglycemia. So, my dear friends, where the ball is going, we can't see with the SMBG alone. So, CGMS will help take off the blindfold off. So, monitoring your glucose is now easy. You can do it anytime, anywhere. And I would say the very good saying by Professor Satish Garg sir, if not within 5 years, definitely in the next 10 years, sensor will take over for the glucometers and meters will be a thing of past, like we are not using Maruti 800. And this is the comfort, convenience and cost effectiveness is increasing by generations of newer gadgets available. Now third generation CGMs are available, FGM is available, and the future will be more non-invasive. So what is the difference between basically CGM and blood glucose monitoring? The blood glucose monitoring is a single moment in time figure, and continuous glucose monitoring will give you the sugar levels throughout the day. And the BGM are capable of generating only single glucose reading, while CGM uses gathered data over course of day and night. And CGM provides dynamic information, and it tells about the direction of glucose levels and rate of change. And this level of proactivity is not possible with blood glucose monitors. Why CGM will replace BGM in the coming future or in the near era? The improvement in technology, patient and human factors, CGM helps understand data beyond HbA1c, and CGM and FGM will replace BGM, we all know, and it provides up to 288 readings per day with no pain, glucose trends with arrows and systems, alarms for low and high, and remote monitoring can be done by the parents, by doctors and teachers in patients who are young. So what about the mard? It is not the Amitabh Bachchan's mard. It is the mean absolute relative difference, which is the most popular characteristics of the measurement of CGM and glucometers. That is, the accuracy of the meters or CGM is detected by mard, and the lower the value, better is the device. So the mard of the various glucometers, you can see it is ranging from 5 to 20%, and more than 50% of glucometers have mard value of more than 10%. So my dear friend, the accuracy is not so much, and the mard value of CGM range from 8.5 to 9%. And the FDA does not allow the adjustment of insulin doses. This was also a myth previously, but now it has been removed, and now the FDA has expanded the indication that now you can modify the dose with the CGM. And now the patient factors, how frequently do your patient check capillary blood glucose? My dear friends, Amit has already told that only 11% of population is doing the pricks for the control of sugar. So it is very less. Survey done in the US population in type 1 diabetic patients, more than 5 times, only 40% patients were doing the SMBG, and in the type 2 diabetic patient, only 3%. So more than 5 times is only done by 3%, but you want the trend in type 1 and type 2 diabetics to prevent the complications. This is the impact trial after the FGM. The monitoring increased 3 times, and the patient was able to scan easily his sugar reports through the monitor 15 times, and in type 2 diabetic in the replace trial it increased from 3 to 8.3 scans. So they are having easy scanning or getting the sugars very easily through the CGM or FGM. And why it is important? Because it decreases the hospital admission, it decreases the cost and decreases the work absenteeism, improves the quality of life, what we need in our management of diabetes. The quality of life is also very important aspect. Decrease in HbA1c was seen, and it reduces the hypoglycemic episodes and increases the time in range. What we are talking today, TIR in every conferences and every studies. So TIR will improve with the FGM or CGM. My dear friend Amit have told that there are no studies, but the RCTs support use of FGM over SMBG. The impact and replace trials are the large scale RCTs that compared the effect of FGM and SMBG on glycemic control in type 1 and type 2 diabetic patient treated with insulin. But though they have not shown the significant difference in HbA1c levels, but the incidence of hypoglycemia was less in the FGM group, and there was significantly improved mean glucose levels, glucose variability indices, time in hyperglycemia, and treatment satisfaction was improved. So quality of life was improved. My dear friend have told that it doesn't improve with the CGM, and patients providing an opportunity to use FGM in patients in non-insulin treated type 2 diabetic patients also to provide a sustained improvement in glycemic control. They have seen that after discontinuation of use, they come to know that how much exercise is helping, what food is bad for them. So it has shown sustained improvement despite the discontinuation of the use of this. And the freestyle is approved for type 1, type 2 pregnant females, children 4 to 17 years, teenagers and young adults. So benefits are definitely more. It improves the quality of life. It decreases the HbA1c. Acute events are reduced. All cause hospitalizations are reduced. Hospitalized ketoacidosis episodes are decreased. Significant improvement in time spent in hypoglycemia was reduced. Time spent in hyperglycemia was reduced, and time in range was improved. So improved well-being, decreased disease burden, greater treatment satisfaction, what we need. In the current era of COVID-19 also, a study published in Journal of Diabetes Investigations, they have shown the effectiveness of intermittently scanned CGM system. It was significantly associated with better outcomes of COVID-19 with pre-existing diabetes if they were using IS-CGM. So the indications are broad. As my friend was saying, that it can't be used in all the patients. Definitely it can be used about 2 years, and CGM can be considered for daily use in type 1 diabetics with frequent hypoglycemic episodes, unawareness, hypoglycemic in youngs. Nocturnal hypoglycemia cannot be detected by SMBG and white glucose excursions. So it helps to control the blood glucose levels with painless device. So to summarize, it is difficult to achieve glycemic goals with finger stick alone. The use of CGM substantially improves glycemic control without increasing the hypoglycemia. The fear of hypoglycemia and lack of understanding about glycemic excursions keep the patients from adjusting insulin dose inappropriately in many instances. The CGM helps reduce A1C without increasing hypoglycemia. The consistency of use on a daily basis is most important factor for success with CGM, and patients with both high and low A1C value obtain clinical benefit from use of CGM. So to finish, to summarize, that in the real world, you need Pal Pal Ki Khabar through your news channels. Similarly, the Pal Pal Ki Khabar of your sugars can be given by CGM, and it is the need of our. Over to the chairperson. Thanks a lot. Thank you.
Thank you, Dr. Ashish. Thank you, Dr. Amit Gupta. Very wonderful session by both of you, and really batted well for your selection, the CGMS versus SMBG. And yes, we are both using, CGMS versus CGM flash drive. Over to Jimit sir.
I think I need to give some rebuttal also.
Yeah, please.
Yes. Dear Ashish, I would just like to emphasize on the fact that the debate was not which technology is superior to what. The debate was simply, can we totally write off blood glucose monitoring, or have we reached an era where the CGM or FGM is the only thing which is going to be available for our patients? And I still say it is not going to happen, and it is not going to happen for many years to come. Simply because, just try to, what is the point in that is that blood glucose monitoring is going to stay because it can be used at the community level. It is very cheap. It can give you can simply check and find out acute hyperglycemia, acute hypoglycemia. There are limitations of the technology, as you have said, pal pal ki khabar, lekin kai baar wo pal pal ki khabar ke baad we need to stop the TV channel because we are information overload ke karan se we get disturbed, stressed out. So there are reports when people wear devices regularly, the information overload can cause diabetes distress to them, and they can be very concerned, and it can be very difficult for them to manage. And then there are failures of the technology also. For example, during the wearing time, warm out time, the patient has no clue what is happening to the blood sugar levels. Matronic sensor, if you use as a CGMS, it says that you need to calibrate it at least 3 to 4 times a day. You have to calibrate it before you rely on the CGM readings. So even the use of CGM is depending on the use of the blood glucose monitoring. So to say completely that it is going to be an era of CGM or FGM only, I totally disagree. And there are many facts to support that. At the most, I can say that rather than looking at the competitiveness of these two technology, we should look at the complementarity of these two things. So these two things can complement well, but they are not any way around the competition because they are not going to replace each other. This is what I say. Thank you.
Amit, you have told that calibration. Now the newer ones like Dexcom G6 and the FGM like by LibrePro, they do not require the calibration now. And we need indefinitely, like the mobiles were not used in the community levels in the villages. Previously, we got the Reliance man. Similarly, we can get some money and he can bring the cheaper one, and we can win over through the CGM and FGM will be available all over India. Definitely, we will have the vision like that, and I hope that all the patients of diabetes will get this opportunity through our Bansi Sabu sir. He's Ambani of diabetes India and diabetes field, and definitely we will propagate this thing for proper control of diabetes, and especially in type 1, because we are very much worried about the type 1 patients, you and me and everyone, that they should get the good quality of life.
You take 1% of the patient, I will take 99% of the patient for CGM, right?
Yeah. So over to chairpersons and Jimit.
Jimit sir, over to you.
We have still time remaining. If you can comment, and you can comment on 2-3 debates. We have 5 minutes still left.
Yeah, Abhijit, over to you.
Yeah, I mean, I'm a frequent user of CGMS's last 5 years, and I still, back the Dr. Amit Gupta's topic. The technology comes with the errors. Specifically, in this last 2 years of lockdown, the technology has served a purpose. Also, same time, it is kind of a punishment also, and where we are totally dependent on a virtual kind of a consultation, and CGMS is a limitation here. So again, I see SMBG remains to be the integral code of conduct here, and specifically post-COVID recovery phase, where SMBG is because you can't rely on the flash drive, specifically post-COVID steroid-induced hyperglycemia. So I totally give, definitely here the points were totally covered by Dr. Abhijit Gupta. What do you say?
Scientific points are both in favor and against, but I would just like to ask one thing, that when we recommend CGM to our patient, for how long do we can recommend? If we talk about our clinical practice, if I put a CGM in one patient today, at the most he will put it once,
maybe maximum 28,
maybe twice. But what after that? What after 14 days? Many of those, they are not going to wear it again, because they said, डॉक्टर साहब आपने देख लिया डेटा जो देखना था, अब आप इसमें अब तो घर पे ही चेक कर लूंगा. This is the reality of life. So SMBG, blood glucose monitoring, is this something, if you are diagnosed with diabetes, the patient knows I need to check. But if you tell today a patient that this is the device you need to wear for rest of your life to monitor your blood glucose levels and to keep the glycemic variability and time in range under check, I don't think anybody is going to agree, unless and until they are type 1 patients, they are on multiple daily doses of insulin and they have marked fluctuations. So I don't think, and there are reports, for example, in JAMA in 2017, there was a study which was published, and they totally refuted SMBG. They said the SMBG is of no use for type 2 diabetic patients. It doesn't add any value to that. So even there are questions on SMBG, particularly when we are talking about type 2 diabetic patients. So this is what I wanted to convey.
So we are still in dilemma after so many years, that what things are better. So non-invasive monitoring is also coming in near future. Like we monitor the SpO2, we can monitor the blood glucose through ear lobes, and many new innovations.
That can be a game changer, because it will ward off the need for any kind of even CGMS is not required. Anytime you put your finger stick and you see you just put the pulse oximeter like thing device and you see your blood sugar levels. So that is everybody is waiting.
Yeah, that will be a boon to our diabetic patients.
Dr. Bharat, any comments, please? You are also there. I can
sir,
see
I was very keenly listening to both of you. Hi, sir. Actually, in one line, sir, what we are anticipating is actually what Dr. Ashish sir has said, but the practicality is what you are saying. So we always hope for something which is very good. Yesterday, I was having a talk with Dr. Viral Shah. He was saying that in US, 80% of patient on or CGM because they are insured. Once the insurance is gone, they will not be on CGM even there. So if a rich country like US is having a state like that, because till the time it was not on insurance, the acceptance was not that high. So we are living in India. We are a highly cost centric country.
We are also getting many patients, those who are on the IT field, they say that sir हमको तो लगाते रहिए, हमारे को तो reimburse हो जाता है. So there are many people in our Indian
population. They are the ones, sir, but there are some practical issues also with CGM, like the warm up period. One day it takes time up. Sometime Metronics में तो अपना issue है, रोज का 3 बार करना पड़ता है. So these are the all practical points which are there. But yes, we are hoping technology will improve itself. We know it and we are seeing it. Amit sir, we are using it and we are seeing it. It will improve. And one day, Ashish sir would be very correct, I think, that we may no longer need.
We
But
have
right now, I think
we have Bansi sir as Ambani of diabetes, so he will
that is
provide
what, that is what.
all the,
Maybe
all
he will
the
come up with
villagers.
something like Geo. So
Answer your comment.
Bansi sir, there is a new idea.
Good morning, sir.
Good morning, sir. Sir, you
Sir,
have
please
to,
allow.
That is probably in different session.
yeah.
Right.
Bansi
No,
sir,
no, no, no. I am there. But what is the new idea? Because I have to chair the next
there was
session.
a debate that the CGM is not available widely for the villagers and the community level. So I told like Geo Ambani has given mobile to everyone. The Bansi sir is our Ambani and he will provide the CGM and in the near future to every
See,
diabetes.
Ashish, this will remain debate for maybe another 5 years.
Right.
The similar way when in 2000 we started doing A1C, there was always a question why A1C should be done, why we can get with the fasting and postprandial and patients are getting treated. Before 20 years, this used to be a debate. And then, every 5 years, things were changing. When we started doing more for our patients, the A1C cost is decreased. And now it is widely available even in rural most area. At the district level, I can tell you at many of the places, even HPLC machine is available. So I remember that in Ahmedabad, when first HPLC had come, and now we have hundreds of HPLC, including my clinic on, we have a dedicated D10 machine also for doing A1C. So it's like when we started talking as the CME is one of the way by which we can increasing the awareness about the therapy, about the monitoring part. And over a period of time, I'm sure when we all will start using, now we know that almost all urban area across the country, people have started using the continuous glucose monitoring because of the cost, because of the use and the benefit which we are having. Now the time in brains, the concept is building up. And I'm sure in another 5 years, things will improve. We are, because of this, on a digital platform. Now, you are listened by more than 10,000 people who are listening you, and probably this recorded lecture will be there and people will again listen it multiple times in next 1 year. So the things will change and thousands of doctors will continuously listen and they will try to use this modality of management or a modality of monitoring in their day-to-day clinical practice. And I'm sure maybe after 5 years we may discuss that, oh, that's obsolete now, no more to do a self-monitoring. But in other whole, I am going to talk about the monitoring is very important. So we are not missing anything. It's always a debate. So I always say that for each thing, whatever which we are discussing today, it has got a place in management of diabetes. Somebody may not say that sulfonylurea is now obsolete. Somebody cannot say that self-monitoring is no more required. A1C is no more required. Everything is required. And what we are going to do in another 5 years, 10 years, I am sure. That is what we are doing.
या जैसे दाल बनाने के लिए सब चीजों की जरूरत है, नमक चाहिए,
हर चीज चाहिए भैया, गोभी भी चाहिए,
diabetes
दाल
वाले
भी चाहिए, खाने में सब कुछ चाहिए. It's not like that कि everyday pizza had come, so now you are going to throw away your roti. No, you can't. So you will have roti also, you will have pizza also, you will have the new variety also, which is going to be served in your thali. So I think it was a fantastic discussion and these debates, 3 debates which we have kept. So Jimit, now you can take over because I think it's 11 o'clock. Already Dr. Anup Mishra had joined and we have very interesting session. First time in any conference or any meeting, we are going to have our official journal. The top 4 articles are selected by Dr. Anup Mishra, who is our editor-in-chief of the journal. And we are going to have, and we invited all those 4 original article people to speak about their paper. Over to Dr. Jimit first, and then we will invite the chairperson. Please.
Thank you, sir. You already introduced this session. So let me invite our rapporteur for this session. Can we have the slides? I would like to invite rapporteur Dr. Sushil Patel. Dr. Sushil Patel is a consultant diabetologist from the city of Vadodara and very good friend of mine. I would like to invite him to introduce the chairperson and then we start the proceedings of this wonderful session. Over to you, Dr. Sushil Patel.
Thank you, Jimit bhai. And thank you, Dr. Bansi sir and the entire team for giving me this opportunity. So, as rightly mentioned by Dr. Bansi Sabu sir, this is the first time we are doing such session in Diabetes India. That is editor's choice, based articles from the diabetes and metabolic syndromes, clinical research and reviews. And we have the 4 speakers for this, those who are the original author of these articles. And to chair the session, we have the 2 eminent persons, Dr. Bansi Sabu himself and the editor himself, Dr. Anup Mishra sir. So that will be the wonderful session because we are going to hear 4 best articles for the entire year, and the reviewer himself and the researcher, the great researcher, Dr. Bansi sir. So over to you, sir, Dr. Bansi sir and Dr. Anup Mishra sir for carrying out this session further.
So over to Dr. Anup Mishra sir to introduce the topics as well as about the session. Dr. Anup Mishra sir.
Thank you, Banshi. I really thank you for giving this opportunity to me to showcase some of our very good papers. The choice of paper was not easy because we have had approximately 50 papers with more than 50 citations, and there were 10 papers with more than 200 citations. As I said yesterday, day before yesterday in the inauguration, that our journal attracted second highest citations as far as COVID-19 and diabetes, next to Lancet and ahead of New England Journal of Medicine, JAMA, British Medical Journal. So that was a tremendous achievement for our journal. We saw the things up and running. We saw the things first. In fact, our article, myself and Dr. Ritesh Gupta, was one of the first, actually, not one of the first, the first on the clinical management of diabetes in COVID-19, right in March of 2020, and has now been cited 350 times. And similarly, Dr. Avdesh's article on hydroxychloroquine, and there were so many other articles which have been highly cited. To the point that people from UK, Dr. Kunti and Dr. Naveed Sattar, and from USA started sending the articles, and their articles were also highly cited in our journal versus what they published in British Medical Journal and other places. So with that sort of a winning track, we thought that we'll select some of the articles which are very good scientifically. I specifically avoided any article of the person who's closely related to me or was in editorial board. So that was the exclusion criteria for any article selection for her. So we have selected 4 very good articles. Each article will be presented by the lead author. And Dr. Banshi, are you there?
I am there, sir.
One question can be allowed, Dr. Banshi?
Yes, sir. We can have more question also because we want to make it real interactive. And I will be requesting all the speakers if they can talk less about their article, and we can have more questions. Individual article can be discussed simultaneously.
So
I
please,
think that will be better.
Yeah, that's excellent suggestion. 8 minutes per article and 2 minutes we will have, or maybe more, for discussion. Now
I think 15 minutes, sir. It's a total duration which we had given 15 minutes per person. So 12 minutes for the articles and 3 minutes for the discussion will be better.
All right. Okay. We have Dr. Sanyal, I can see. We have Dr. Mondal, I can see. Dr. Arun is there?
Sir, Dr. Arun will be joining, and Dr. Ramchandran article, I think Dr. Nandita is going to join, or she joined, I think, already.
Yeah, and Dr. Piyush Ranjan? Okay.
So they will be joining.
Yeah.
I am trying from my office to get them connected.
All right. That's fine. Then we start with Dr. Sanyal. Are you ready, Dr. Sanyal?
Yes. Good morning. Good morning, sir, and good morning to Dr. Bansi Sabu as well.
Yeah, please go ahead and start your presentation.
Thank you. Hope it's visible.
Yeah, now it's visible.
Thank you, and thank you for the kind invitation, and also would like to thank Dr. Anup Mishra and Dr. Bansi Sabu sir as well for the selection. Especially we have been working for quite some time in transplant and diabetes,
and we have quite a few papers. And now we have had this long-term efficacy and safety of anti-hyperglycemic agents in new onset diabetes after transplant, mainly after kidney transplant. And this is a result which we have presented with regards to outpatient based 1 year follow-up. So as we are all aware, new onset diabetes after transplant occurs in about 20 to 40%, and after solid transplant, organ transplant, and about 20% of kidney transplant. And it is associated with increased risk of rejection, infection, cardiovascular morbidity, and mortality and hospitalization. Problem is compounded by fluctuating renal function, alteration in immunosuppression doses, as well as episodes of rejection. What was previously thought to be more of an insulin resistance because of use of steroids, now there is a different opinion that probably beta cell function may be more affected, and so there have been studies suggesting that early insulin can be preventive in terms of its development. But the recommendations are we need to choose the most effective immunosuppressants irrespective of their capacity to cause NODAT, and that is basically on the basis of graft survival. So there is some difference with regards to type 2 diabetes and new onset after diabetes after transplant, because there is a more rapid onset and also more rapid progression requiring early intensification of pharmacotherapy. Along with that, there is increased risk of hypoglycemia because there is still a persistent decrease in renal function, CKD stage 3, and that's why the KDIGO recommends a HbA1c goal between 7 to 7.5%. But there is inadequate evidence with regards to hierarchy of use of anti-hyperglycemic agents as well as long-term anti-hyperglycemic therapy in this population. So what we intended was to look at long-term outpatient department follow-up data on glycemic control in this population, which is inadequate, and especially in patients who have been referred to the endocrinology OPD with reasonably stable renal functions in the kidney transplant recipients. We had this 1 year efficacy and safety follow-up in the OPD. So we included, this was basically a retrospective data collection in patients who were diagnosed with new onset diabetes after transplant with a 2-hour OGTT. They were followed up for at least 1 year. They were very importantly on the standard stable immunosuppressive, triple immunosuppressive with tacrolimus, prednisolone, and mycophenolate. And the population included stable kidney transplant recipients who were receiving anti-hyperglycemic therapy for at least 3 months post-transplant and were followed up for 1 year. We excluded transient post-transplant hyperglycemia. We excluded undiagnosed pre-transplant diabetes, separating from post-transplant PTDM nomenclature. And also we did not include patients who did not provide consent. We evaluated fasting, PP, HbA1c, weight, hypoglycemia, renal function, and the tacrolimus level. Out of 118 kidney transplant recipients with NODAT, 23 did not follow up or had incomplete data. So we included 95 patients, 65 were males. So the mean age was 45 years. The mean fasting glucose was 185, postprandial was 293, and HbA1c was 8.48. The mean GFR was 53.95, again CKD stage 3, and the mean tacrolimus level at baseline was about 12.79. So we started linagliptin as first line therapy because that can be started without any dose adjustment and in all stages of CKD. Metformin we included as second line only when the GFR was permissible and there were no other contraindications and there was no GI intolerance or hospitalization or radio contrast use. Secretagogues were generally preferred as third line. Gliclazide or ripaglinide, we preferred gliclazide initially because of they are permissible in CKD as well as have good cardiovascular outcome data as well. Ripaglinide was also preferred as third line if the PPG was raised with a normal fasting glucose below 130 and a raised HbA1c. Now we used insulin as fourth line, or whenever the HbA1c was uncontrolled with oral antihyperglycemic agents. So as you can see in this data, 25% were on monotherapy within 1 year, 75% required additional therapy. Out of them, about 20% required insulin-based regime. 40% were on dual therapy without insulin, and about 15% were on triple oral agents. So signifying that about 55% required combination therapy within 1 year. This is in contrast with type 2 diabetes, as well as 20% required insulin-based regime for control of hyperglycemia. So if you can see, linagliptin was used in majority of patients, 100%, followed by metformin in about 41%, then ripaglinide in 22%, gliclazide in 18%, basal insulin in 12%, and premixed insulin in 7%. Only in one patient we had quadruple therapy. Now, with regards to HbA1c at follow-up, about 6% had HbA1c less than 6.5, 40% HbA1c below 7, 50% HbA1c below 7.5. So nearly 96% had an HbA1c below 7 as recommended by KDIGO, and 4% had HbA1c more than 7.5%. So the mean HbA1c was 7.08, fasting 117, and a postprandial 167. 96% had HbA1c less than 7.5 and 46% less than 7. The mean decrease in fasting glucose was 67, postprandial 126 milligrams per DL, and HbA1c 1.4. 55%, as I have said, were on combination therapy, 20% received insulin-based regime, and only 25% were on monotherapy. About 30% had one episode of hypoglycemia, at least one episode. 15%, 15 out of these 15 were, out of these 30 patients, 15 were on insulin, 10 were on gliclazide, 4 were on ripaglinide-based regime. And 4 patients had more than one episode. 50 patients had a weight gain of about 1.63 kg at about 1 year. The creatinine and GFR improved from baseline, especially the GFR improved from a baseline of 53 to about 15.77, and also there was a significant improvement in the tacrolimus level. This is probably mainly because of graft survival. So as you can see, the mean HbA1c reduction with linagliptin monotherapy was 0.8%, dual OHA were 1%, triple anti-hyperglycemic agent was 1.7, and insulin-based regime was 1.78. With regards to weight gain, the significant weight gain of about 1.95 kg was only seen with insulin-based regime. There was an improvement in GFR between 15 to 20 ml per minute in all regimes which were used. There were about 15 episodes of hypoglycemia in the insulin-based regime, and 8 in dual anti-hyperglycemic agents, and 7 with triple agents. So insulin is generally preferred with fluctuating glucocorticoid use, especially early on, decreased GFR and acute illness, and it may decrease NODA development. 20%, as we have said, of our patients were on insulin, 12 on basal, and 7 patients were on premixed. Obviously, metformin is beneficial in terms of metabolic and anti-neoplastic property, but it requires stable graft function and high compliance. We had started about 50% of our patients with a GFR more than 45 on insulin, but if there was worsening of GFR, we had to discontinue 8 patients, 5 because of GI intolerance, 1 because of low GFR, and 2 patients because of UTI with low GFR. So most patients with NODAT, including our population, had CKD stage 3, and infection and contrast use and hospitalization are the additional risk factors for metformin use. And 40% of patients actually has been seen are using metformin with the beyond the recommended cutoff, and there is also a high discontinuation rate in this population compared to the garden variety of type 2 diabetes. DPP-4 inhibitors, the advantage is that it can be used at all CKD with dose adjustment. Linagliptin doesn't require dose adjustment, that's why we preferred it. And also they affect the predominantly the beta cell function in postprandial glucose, which is a concern in this population, and they are associated with low hypoglycemia and weight neutrality. And that's why we preferred linagliptin as first line. We have also prior published data with use of linagliptin as monotherapy in a small publication. It published in IJEM. And in this population, we had 25% as monotherapy with significant HbA1c, no hypo and weight gain. Gliclazide was chosen, especially if because it's permissible in CKD as well as it has good safety data, but there were 2 episodes of hypoglycemia and 11 patients had weight gain. That is nearly 20%. And about 22%, that is 21 patients were on ripaglinide, 5 reported hypoglycemia and 12 had weight gain. So with regards to limitation in our study, it was retrospective, observational with a limited number of subjects. We require large-scale prospective randomized control trials to address the issue of long-term control, as well as better understanding of the pathophysiology and progression. And this may assist our choice of agents. So in conclusion, at 1 year of follow-up of these patients of NODAT, HbA1c of 7.5% was achieved in 96% of patients, and 46% had HbA1c less than 7%. Linagliptin as monotherapy first line was safe and effective in patients with reduced and fluctuating renal function early on. Majority, however, 55% required combination anti-hyperglycemic agents, oral agents for optimal glycemic control. Metformin and linagliptin was the most preferred combination, and especially with regards to suitable adverse effect profile, but we need to be careful with regards to contraindications, especially the GFR worsening, hospitalization, and contrast use. Metformin is effective provided GFR is permissible, but we require close monitoring as well. Ripaglinide again is safe and effective and can be effective in terms of controlling postprandial glucose, postprandial hyperglycemia, which is aggravated by use of steroids. Gliclazide, especially as third line agent after linagliptin and metformin, is acceptable and is associated with acceptable hypoglycemia and weight gain. Ripaglinide is also quite.
Dr. Sanyal, please conclude.
Yes, 20% required insulin, mainly with basal insulin in 63%. Majority patients had improvement in renal function because of improved graft survival. However, we require long-term randomized control trials and with regards to glycemic control and its impact on outcomes. Thank you very much.
Thank you, Dr. Sanyal. I must congratulate you for bringing out the therapeutic options in this very difficult situation. I want to ask you one quick question. You have not mentioned about either the GLP-1 receptor agonist or SGLT2 inhibitor in your therapeutic regimen. Why?
Yes, yes, sir. And as we have seen, even the recommendations, though there are studies with regards to GLP-1 and SGLT2, but problem with SGLT2 with regards to the use in this population is that there is increased risk of infection, which is quite common in this population, as well as because of fluctuating glycemic control, there is an increased risk of diabetic ketoacidosis as well. Though there are few published data coming up with regards to long-term, with regards to their safe use, especially with empagliflozin and canagliflozin. But even the KDIGO has issued, we need to be careful with regards to use of SGLT2 inhibitors in this population. Again, with GLP-1, the problem is high chances of GI intolerance, especially and also drug interactions as well. And there can be also interactions with regards to issues with regards to absorption of medications with use of GLP-1 as well.
Thank you. I think that's very well said, because there is only one kidney, and if there is any infection, the kidney function will go down and the patient will be in greater problem with SGLT2 inhibitors, and rightly so about GLP-1 and log. Dr. Sanyal, you are doing good study. My suggestion to you will be that you get 1 or 2 more like-minded people in Calcutta or elsewhere, design a collaborative trial. Now, that is what is missing from Indian scenario in general, and I think that is the need of the hour. So 3-4 people who are thinking similar to you, are interested in the same area, please design a protocol, do a collaborative trial of a larger number of patients in a prospective manner, and we'll know better than what you have presented. So thank you again. Please keep on going, doing such type of studies or similar studies, and keep on publishing. Thank you.
Thank you, sir. Thank you for the opportunity and thank you for the suggestions. Thank you.
Dr. Piyush Ranjan is here. Dr. Piyush Ranjan? Okay. Then we'll go on to the third presentation. Dr. Nandita. Dr. Nandita is here. Yeah. Dr. Nandita, thank you for coming. Your paper, Trend in Clinical Profile of Type 2 Diabetes in India, study from Diabetes Care Center in South India, has been selected. It seems to be a very good paper. Please start your presentation.
Thank you, sir. Very good morning to everyone. I bring greetings from Dr. A. Ramchandran's Diabetes Hospitals, Chennai. I hope everyone is doing well and safe at this point of time. And I, of course, thank the organizers for accepting this paper of ours and giving us the opportunity to present it here today. So this is a study in which we wanted to look at analyze the trend of clinical profile in patients with type 2 diabetes presenting to the clinic in southern India over a period of time. So I'll move on. This was a publication that we recently published, and this was a research methodology. This was a retrospective study in which the aim, as I mentioned, was to study the change in profile of patients presenting to the clinic with type 2 diabetes over a period of 10 years. So this was conducted in our center in Chennai, and this was over a period of almost a year, 10 years, from 2009 to 2018. And retrospectively, data was collected from our electronic health records and the EMR that we have access to. So I'm going to move straight to the results. These are the characteristics in terms of age profile of the patients ranging right from 2009 to 2018. And as we can see, we have the bars from in different tables. Each table has each year 2009, 2012, 15, and up to 18. And as we can see, what was quite alarming that we have the age group of less than 30 and from 30 to 49 is significantly increasing in numbers as the years progress in from 2009 to 18. So this is it's a point of concern and something to make note of, because what this tells us is that younger people are being diagnosed with type 2 diabetes. And as we know, this is the productive years of life, the prime of life, less than 30 and 30 to 40, 50 years of age. And we have younger people living with diabetes. And the second point to note from here is that these people, because they are diagnosed at such a young age, they're going to be living for that many years exposed to the ill effects of hyperglycemia. And we have to effectively treat these young people to reduce the risk of complications. The next point that we noted is from the data is that as we compared the rates of BMI, the BMI also was significantly increased. As we can see in categories of less than 18 ranging up to more than 30, the rates of obesity, so more than 30, which is the BMI as we can see in the bottom bar, is significantly increased over the years from 2009 to 2018. So this is another big burden that we are dealing with. Moving on, we're looking at a bar diagram over here where we're comparing the trend in drug therapy. So as we can see, with regard to monotherapy, the percentage of patients being put on just a single drug has actually significantly come down from 13%. It has drastically come down to around 6% in 2018. Dual therapy also has significantly come down. And interestingly, triple or multiple therapy has actually increased from almost 60% to significantly around to almost 70%, a 10% rise in triple therapy or combination therapy. And this is an indication that we are, what we can conclude from this data is that we are probably more aggressive in our approach to patients with type 2 diabetes, which is good news, which means that we as clinicians are probably waking up to the fact that we have a huge burden of type 2 diabetes to deal with, and are more intensely hitting hard with our with the therapy in our patients with type 2 diabetes. Now, this is a slide in which we're looking at the trend in the glycemic status, so the HbA1c values from 2009 to 2018. And as we can see, the percentage of patients with a HbA1c of less than 7% has remained almost static. There has not been much of a change over the years from 2009 to 18. However, from 7 to 7.9, which is fairly okay, I'd say, within less than 8%, there is a significant increase from 25% to 29%. And another good point to note is that, which is reassuring, is that the number of patients with a HbA1c of more than 9 has also significantly come down from 2009, which was 35%, to 29%. However, although this is giving us some hope that we can do better, we still definitely do have to put in more effort to more effectively treat our patients to target better HbA1c values. The use of statin therapy over the years from 2009 to 2018 has significantly increased. As we can see, this is the number of the percentage of patients from 36% to 55% of patients, significant increase in patients on statin therapy. So I think many of us are convinced that statins are in fact very, very effective agents to reduce cardiovascular risk. And in turn, the cholesterol levels, this is the total cholesterol and the mean LDL levels, have also significantly come down from 2009 to 2018. When we look at hypertension, the use of ARBs is what has significantly increased from 2009 to 18, from 24% to 31%. And there's similarly a drop in the use of the ACE inhibitors. So this proportionate drop of increase in ARBs and a reduction in the prescription of ACE inhibitors is probably something that is not surprising, which is something which is expected. And there is a significant drop also in the use of thiazides, and an increase in the prescription of calcium channel blockers. Now, when we look at the blood pressure, the patients with the target blood pressure of less than 130 by 180 had actually come down. So from 55% that it was in 2009, the number of patients, the percentage of patients with a blood pressure of less than 130 by 80 had dropped to 48%. And the mean blood pressure of 140 by 90 had actually increased. So although we are prescribing more of ARBs and CCBs, now the rates of patients with good blood pressure control was actually coming down. So in summary, this is a trend of the clinical profile of patients presenting to a tertiary care center in Chennai, southern India, over a period of 10 years. And this was analyzed over a period of 2009 to 2018. The overall data showed us that there is in fact a decrease in HbA1c levels. However, the proportion of patients who are achieving a target of less than 7% is quite less, and we do definitely have to fare better. There is an improvement in dyslipidemia levels, and also a lot of patients are also being prescribed statins. And also there is an increase in the use of antihypertensives. However, optimal blood pressure control is only achieved in a small percentage of patients. The study also suggests that we do need to target our patients with ABC, which is the A1C, blood pressure and cholesterol, more effectively with holistic approach with our patients, and more aggressively treat our patients, since we have younger patients being diagnosed and detected with type 2 diabetes, effectively reduce complications. Thank you.
Thank you, Dr. Nandita. I must congratulate you and Dr. Ramchandran for this very, very important study. One question I'll ask you. Is the doctor's performance better or patient's performance better, according to your study? Are doctors performing better over 10 years, or patients themselves perform? Now, I don't see physical activity in that data. I know it is very difficult to get from the retrospective data, but still, what is your idea? I would like Dr. Ramchandran's opinion also.
Sure. He's also here. But I think that is it's a wonderful question, of course, coming from you. But I think that, like you said, it is difficult to assess that, and we haven't looked at that in our study as well. Um, but if you ask from my opinion, I think it's probably both. The patients and the doctors who have been more sensitized over the years and become more aware of the ill effects of the long-term complications of type 2 diabetes and the importance of multifactorial intervention to reduce cardiovascular risk in our patients. So I think we as doctors are more aggressive in our, as we found in the data, the triple therapy has actually increased. So we have realized that diabetes is more of a complex disorder which does require more than a single drug to achieve targets. So maybe we as clinicians have become a little more aggressive in our treatment.
Uh, uh, from your data, let me give you my comments to you. I mean, I may be totally wrong.
Sure, please.
I feel doctors are performing very well. From a single, two fact, one you have said already, 4 drugs, quadruple therapy and things like that. The second, the LDL level is fantastic. 80, achievement of 80 LDL level on the average, given that this is a real world type of data, is fantastic, you know. So that means the statin use, which is perhaps one of the most important thing, is being done very well. So doctors are performing well, but patients are not, because despite quadruple therapy, the A1C reduction overall is not particularly encouraging. I think their diet and exercise is still, I think it's worsened over a period of time. So they will take what Dr. Ramchandran says and you say, but they will not do much on their own. Dr. Ramchandran, your opinion?
Yeah. Of course, it's a combination of both. But as you rightly said, it's more probably because the doctors are little much more aggressive today, and we have better drugs. We are also more convinced about the uh, conviction that the statins can do much better, and the side effects are much less. In fact, we did an international study also. This is only the Indian one. The international study exactly showed what you said, that from, if you exclude North America and Western Europe, almost the rest of the countries we have analyzed, almost for 50,000 patients, and we have found the use of statins have skyrocketed, and that has resulted in much better LDL values. And as we rightly said, or Nandita said, the multiple drugs used for hypertension also has occurred. So we have been more aggressive. But we are not analyzed whether it is the behavior of the doctor versus the behavior of the patients. There is no doubt there has been an increased literacy or medical literacy among the public, especially in the urban population. To some extent, that would have contributed a little. So, but I think 75% the contribution must have been the doctor's behavior has changed. We have become more aggressive because of the availability of better drugs and without much side effects. Thank you. Thank you for selecting this paper.
Thank you. Dr. Banshi, anybody in the panel has any question before I ask another question to them? Dr. Banshi, are you there? I think he's in another discussion. So
Sir is in another hall, sir.
sorry, is there somebody else who wants to?
I think someone mentioned that sir is in another hall.
Oh, okay, yeah, that's fine, that's fine. So one thing, what I suggest is, and maybe you have data, you have such good data, is just weight changes over a period of 10 years. That will give you idea what a patient is doing. But of course, you have to subtract patients who are on SGLT2 inhibitors or GLP-1 analog or pioglitazone. If rest of the patients are gaining weight, they are not doing well as far as their lifestyle is concerned. So I think you may that itself is actually a paper. Weight changes over 10 years despite increasing use of drugs which can lead to weight loss. That's a data should be available with you, I'm sure. So because you have BMI data anyway, isn't it?
Yeah, sure.
Right.
I think we can look at that. We are not looked into that. You're right. But the baseline, the data, it depends upon what is the weight at entry into the first clinical encounter, and then what happens. As you rightly said, what we have found,
These are snapshot of patients. Every year, about 10,000 to 20,000 patients are seen. So it's a combination of new patients and review patients. Some of them may be repeated every year, but you may not have a follow-up with the same patient. It may not be the same cohort being followed up for the last 10 years. It is just snapshots of patients who are being seen, but still gives you a trend in the clinical profile of patients seen in the urban population.
Yeah,
It's a
I'm
good
sure you
suggestion.
have.
You can look at the video.
Yeah, I'm sure you have patients who have been following you faithfully for 10 years. So if you can have cohort of that, that'll be good, the changing profile over 10 years. But Dr. Ramchandran, Dr. Nadita, congratulations once again for that wonderful paper. And please keep on writing such papers. And we would certainly like, although, I mean, I'm sure you can submit anywhere and your paper will be accepted anywhere. But we would like to get you to submit to our journal, and we'll be very, very happy to consider any further papers. Thank you, Dr. Ramchandran and Dr. Nandita. Thank you.
Thank you so much.
So we move on. Dr. Mondal is right here. Dr. Mondal.
Yes, sir.
Okay, are you ready with your presentation, Dr. Mondal?
Yes, sir. Yes.
Please go ahead.
I hope my slides are visible, sir.
Yeah. It will be
Good morning,
visible.
everybody. I earnestly thank all the editors and editor-in-chief, sir, for considering our paper worthy of presentation in this esteemed conference. This study was done in a super specialty hospital in Durgapur, West Bengal. I am Dr. Shunetra Mondal, consultant endocrinologist, and we do not have any conflicts of interest or funding sources to disclose. So the idea of this study was conceived at a time when several reports of diabetic ketoacidosis were being published in COVID-19 patients, not only in those with pre-existing diabetes, but also in new onset diabetes following COVID-19. And a systematic review in the same esteemed journal of 110 cases of DKA showed that around 77% had pre-existing type 2 diabetes mellitus. Now, the glucocorticoids, we all know that it worsens glycemic status not only by inducing more of insulin resistance, but also some amount of beta cell dysfunction. But the occurrence of DKA per se after glucocorticoid use alone is actually very rare, only seen with acute high dose parenteral use of glucocorticoids. The bidirectional relationship between diabetes mellitus and COVID-19 was known quite early in the course of the pandemic, in that diabetes mellitus increases severity, mortality, post-COVID complications, and COVID-19 worsens glycemic control, new onset diabetes, and an increased risk of DKA as well. Now, following the results of recovery trial, glucocorticoid use was almost unanimous in all moderate to severe cases of COVID with hypoxia. And no wonder this would have influenced both. While it reduces severity and mortality related to COVID-19, it increases rates of new core. And regarding diabetes, apart from worsening the glycemic control, possibly it increases the risk of new onset DKA as well. So our research question was that whether we could have clinical and biochemical parameters at admission of these patients, which can predict the onset of DKA after they receive glucocorticoids in patients with type 2 diabetes and COVID-19 infection. So our objectives were to identify in this particular cohort of patients who are having type 2 diabetes, moderate to severe COVID, and receiving IV dexamethasone, the proportion who developed DKA, and the clinical and biochemical parameters that could predict its onset. For this, we screened all the patients with diabetes and COVID-19 admitted during the study period of June to November 2020. We excluded patients with non-type 2 diabetes mellitus, those who were already receiving glucocorticoids due to some reason before admission, those who are having any comorbidity that could predispose to ketosis, like alcoholism, starvation, chronic liver disease, malignancies, pregnancy, and of course, those with mild or moderate COVID-19, but not requiring glucocorticoids. A baseline ABG, blood glucose, and urine for ketone bodies was done at admission. We again excluded those who were already having ketosis at admission. The remaining cohort was included and they received parenteral dexamethasone at a fixed dose of 0.1 milligram per kg for the next 6 days. And they were prospectively followed with daily monitoring of ABG urine ketones for the next 7 days to find who developed DKA and who did not. And we compared parameters between these two groups. Regarding definitions, severity of COVID, we used the guidelines laid down by the Ministry of Health and Family Welfare at the time of this study. DKA, again, standard definition of high anion gap metabolic acidosis. We could not do serum ketones. We checked for ketonuria alone. Assay methods, I will just mention about interleukin-6 because a lot of controversies regarding its accuracy. We did it by electrochemiluminescence using the COBAS analyzer, having pretty good analytic as well as functional sensitivity. Coming to our results, so out of the 302 patients who were screened, 196 were finally included, of which 26 patients, that is around 13.2%, developed DKA. Comparing those who developed DKA versus those who did not, those who developed were younger, had significantly lower BMI, but the duration of diabetes, prevalence of complications, and the prior use of insulin or any oral hypoglycemic agent, including SGLT2 inhibitors, were similar in both the groups. Regarding the DKA characteristics, 15.3% had severe DKA, 3 patients died. The median time to occurrence of DKA following the initiation of IV dexamethasone was 18 hours, and the median time to resolution of DKA was quite high at 43 hours, as was the mean total daily dose of insulin required for resolution, 2.1 unit per kg, much higher than what we usually see in DKA patients due to non-COVID reasons. Those who developed DKA also had a significantly higher prevalence of severe COVID and higher pro-inflammatory biomarkers like CRP, interleukin-6, procalcitonin at D-dimer at admission. Now, we use the parameters that were significantly different between the two groups to do a multivariate logistic regression to see which could be the independent predictors of DKA. And we found that BMI, HbA1c, and interleukin-6 were the 3 independent predictors. Next, we constructed ROC curves to find the cutoffs for these 3 with the best trade-off of sensitivity and specificity. Interleukin-6 performed best with an area under the curve of 93% and at a cutoff of 50.95 picogram per ml. It could predict DKA with a sensitivity of 88 and specificity of 85%, followed by HbA1c at a cutoff of 8.35%, followed by BMI with a cutoff of 25.56 kg per meter square. So to summarize our results, in type 2 DM patients with moderate to severe COVID-19, quite a significant proportion of around 13% can develop new onset DKA after giving parenteral dexamethasone. Those who developed DKA had lower BMI, higher HbA1c, more severe COVID, and increased pro-inflammatory biomarkers, of which BMI, HbA1c, and interleukin-6 were independent predictors. And this cohort of DKA required higher insulin requirement and longer time to resolution than the other cases of DKA we see. Now, the high prevalence of DKA in COVID-19 has been reported in multiple other studies, but we were the first to prospectively follow these patients following the initiation of glucocorticoid to look at the onset of new onset DKA. This is quite expected given that if we look at the pathogenesis of DKA, both SARS-CoV and glucocorticoids could have synergistic effects in producing an insulinopenic state by their actions on beta cells, stimulating lipolysis, the actions of the cytokines to increase the counter-regulatory hormones, etc. So it is expected that these two could synergistically act to produce a ketogenic state. Now, low BMI and interleukin-6 have previously been proposed to be risk factors for DKA in type 1 and HbA1c in type 2. Now that our cohort was having a combined state of insulinopenia and insulin resistance, it was expected that these 3 could be independent predictors. The increased time to resolution and increased requirement, again, due to the insulin resistance, due to the glucocorticoid use, as well as the effect of cytokines. During the second wave, we had 411 patients, out of which 335 required glucocorticoids. 28 patients had DKA, of whom 8 patients now presented with DKA right at admission, and they had history of having received glucocorticoids at their home. We had 3 cases of mucormycosis. 1 had history of mild DKA during admission, but left against medical advice. So the clinical implications of our study could be to identify the patients who are at particular risk for DKA following the initiation of glucocorticoids, and this could help us prioritize intensive glycemic monitoring, hospitalization, ICU-I2 admission, and early insulin administration. Now, this becomes particularly relevant during the second wave, when many of the patients had received glucocorticoids at their home, often unsupervised and often injudiciously in some cases, of course. So we propose that this mild or inadequately corrected ketosis state in many patients following glucocorticoids could be one of the reasons for the surge of mucormycosis that we have seen during the second wave. Our study was limited by being a single center study, and we did not have a methylprednisolone group which we could have compared with dexamethasone. I thank all the critical care staff, and I again thank you all so much for sir, so much for letting me present this study.
Thank you, Dr. Model. I think that was wonderful presentation. You stuck to the exact guidelines for presentation, starting with the hypothesis and finally acknowledging your limitations. This is how it should be done. I also congratulate you for turning a epidemic into opportunity for research. This research of yours did not take much of an investigation except whatever is being done, but only your effort and your people's dedication for research. So I would expect that you will continue doing such studies and also publish more. One point is a question for you. Um, there are studies now which show that follow-up of such patients, the decay totally disappears. Patient is off insulin and on oral drugs. At what time will you look at the C-peptide levels, their beta cell function, and look at the future prognosis in such patients who have developed decay? What point of time?
I think 6 weeks is the minimum time we need. And at 3 months, at least we can expect that the effects of COVID-19 on beta cells would go, sir.
So would you follow up some of your patients long term and see whether they recover and then their beta cell function again goes down, something like a honeymoon period, that has been described in classical type 1. I don't know what category of patients these are and how they will behave in the future. Dr. Banshi, a study on decay in COVID-19, she's presented very well. Would you like to comment or ask any question? But Banshi Shabu?
Sir, actually speaking, I
moment.
was not there in fully in this paper, so sorry for
No problem. No problem. We had 3 wonderful presentations. I don't think Dr. Piyush Ranjan has turned up. So, but the first presentation by Dr. Sanyal was on the long-term efficacy and safety of anti-hyperglycemic drugs and new onset diabetes after transplant. Retrospective data, excellently done. And second, by none other than Dr. Ramchandran and his team, Dr. Nandita, of retrospective analysis of huge data over 10 years, last 10 years, in changing profile, and Dr. Sunetra's data. So I think they have discussed it very well. Their papers have been well received by the reviewers, and they have, of course, Dr. Ramchandran has a great track record. I'm just keeping him away, but Dr. Sunetra and Dr. Sanyal have a great future ahead of them because they're just starting. Yeah, Dr. Shabu.
Yes, sir. So I just want to make one comment only that as this editor choice symposia, we will continue in all the Diabetes India meeting.
Absolutely.
And I will request Dr. Anup Mishra if he can find out of these 3 papers which was presented, he can choose any of them as a best paper as a presenter, because already the paper has been already accepted and it is fully written. So for all, and we have already chosen 3 best oral presentation in Diabetes India meeting. The best posters, we got more than 150, and out of them 50 were selected, and we will be choosing best 3 for that poster also. And in this particular session also, if Dr. Anup Mishra wish or he wants to choose one of the best, we will send not only the certificate of participation to all the 3 and 4 from the journal as well from Diabetes India, but we would like to send also the either a cash prize or whatever Dr. Anup Mishra, which he decides. I'll be more than happy to do it for that. Thank you.
Thank you. Good idea. I will do so. Thank you.
So
Thank you,
over
sir,
to
for this
Jimit for the
excellent.
next session. Yes, Sushil, please.
Yes, thank you, sir. And it is wonderful discussion going on for the 3 papers. And now the another innovation by Dr. Bansi Sabu, sir, that it is going to be happen on each and every year. So now we are concluding this session, and I'm handing over to the Dr. Akanksha Pataria for the reporter for the next session. So if she is there,
yes,
she can
she
take
is
over.
there, and we can conclude or we can close this session. Thank you. Thank you, Dr.
Thank
Anup
you,
Mishra, sir. Thank you.
Over to you, Dr. Akanksha. Please unmute. You are muted.
Just a minute.
Yes.
Yes, a very good afternoon to all the faculty members for this point of care symposium. I'm Dr. Akanksha Patsia, adult and pediatric endocrinologist from Surat. And today, in this era of pandemic, we required some specific tips from our speakers who will highlight regarding the point of care during this pandemic period. I would like to introduce the chairpersons for this point of care symposium, Dr. Rahul Taparia and Dr. Jimit Vadgama, sir. Dr. Rahul Taparia is from Siliguri, practicing endocrinology there, and Dr. Jimit Vadgama, sir, is an adult endocrinologist and diabetologist from Surat. Over to you, sir.
Jimit, sir. Yeah, thank you so much, Dr. Akansha, for the introduction. We are delighted to have this symposium, and the one and only man is here to start the session. So, point of care symposium we will be discussing, and we have two wonderful speakers for this symposium, Dr. Bansi Sabu sir and Dr. Rajiv Kovil sir from Mumbai. This is a introduction for Bansi Sabu sir, but I wonder if anyone in the hall or in the symposium or in the whole conference needs his introduction. One and only showman, Dr. Bansi Sabu sir. You can start the session, sir. There is no words to describe you, sir.
Thank you. Thank you, Jimit, for a very kind introduction. Thank you, Akanksha, and thank you, Rahul. I can see Rahul Tapadia, Bharat Sabu, and some of my colleagues like Sushil and Malay. Thanks, Rajiv, for joining. And I'm just sharing my screen. I think it's visible.
Yes, sir.
Visible? Okay.
Yes, sir.
Thank
Yes,
you.
sir.
So what I am going to talk about the relevance of point of care testing in the COVID-19 pandemic. Even this meeting is primarily for a diabetes, but we know that during this COVID time, whatever we are talking, we have to talk during the COVID time. Also, it's very important. It's very pertaining during this point of time. By table of contents, my agenda will be, I will be introducing the topic. We will be talking about diabetes and obesity, which are related COVID-19 risk and outcomes, the role of point of care testing in this pandemic, point of care C-reactive protein in context with COVID-19, implementing POCT in our clinical practice, and then in clinic POCT adoption, which is growing. The COVID-19 pandemic has presented a number of challenges for diabetic patients. Today only in Ahmedabad Times, in Times of India, me and Sanjeev Phatak had written one article and regarding that how during COVID time and post-COVID time, we are seeing the number of patients with diabetes are increasing. The progression to severe illness is more likely with people with diabetes. The mortality rates in those with diabetes are also very high. The undiagnosed type 2 diabetes, pre-diabetes, and new hyperglycemia are risk factor for critical COVID-19. There is a high A1C level associated or start with is associated with higher inflammation, hypercoagulability, and low saturation of oxygen in patient with COVID. The COVID viral infection and the resulting pro-inflammatory state may have profound impact on a lipid metabolism. Decrease in LDL and HDL was more profound that greater the severity of the illness. People with kidney disease, which is again whether diabetes kidney disease or overall kidney disease, seems to have a higher risk for more serious COVID-19 infection, and mucormycosis was seen in patients with poorly controlled diabetic patients with severe or with critical COVID-19. The older individuals, those with underlying comorbidities, are more vulnerable to COVID-19. According to World Health Organization, individuals may be susceptible to severe COVID-19 and death if they have non-communicable disease. The non-communicable disease are diabetes, high blood pressure, cardiac disease, cancer, patients of chronic lung disease, and cerebrovascular disease patient. The World Health Organization survey results that prevention and treatment services for non-communicable disease have been severely disrupted. And this is very important that we had seen even our OPD also decreased during the lockdown period, but online consultation was there, but still it has been severely disrupted since the COVID-19 pandemic began. So the long-term upsurge in death from NCD are likely to increase. The WHO conducts a survey about the prevention and treatment services for NCD in 155 countries during the 3-week period of May 2020, and the data which had shown that diabetes and diabetes complication management was partially disrupted, or in some of the patient it was even completely disrupted also. There was a high impact on a patient care. India is a second and globally as far as diabetic patients are concerned, and second as far as COVID cases are concerned. The first and second wave peaks reached in September 20 and then again in May 21. Reportedly, daily death had crossed almost 4,500. The patient services, especially chronic condition like diabetes, took a back seat in 120 countries as per World Health Organization, and that's really a worry for an Indian International Diabetic Federation too. The clinical conditions were initially impacted but have resumed with precautions, and realization with COVID-19 has higher hospitalization and severity and mortality with patients with diabetes, and obesity is also one of the major comorbidity which we are seeing with the patient with COVID-19 to increase risk of hospitalization. So the exploring the role of point of care testing in managing diabetes and its complication, especially during this pandemic, as diabetic and obesity related and COVID-19 risk, which I had already talked, and the outcome which we know that higher in hospital mortality for the patient with diabetes. I mean, this I'm sure all of you agree that, and you know about it also because there are multiple such papers which published from all over the world which had shown there is an in-hospital mortality in the patient with diabetes was higher. The obesity also a major risk factor for a patient with diabetes or to have diabetes, and appears to an independent risk factor. Even they are non-diabetic, they may not have cardiac problem, but still it's a very important independent risk factor for severe illness in COVID-19. The rates of severe illness are therefore likely to be especially high in regions and population where both obesity and diabetes are common, and that is common in our country. Complications of diabetes include renal, cardiac, peripheral vascular disease, and these comorbidities can be additive risk factors that call for specific action. Obesity itself leads to a severe course of COVID-19 at the level of respiratory dysfunction. Obesity is also related with other comorbidities, and there are other metabolic risk factors with obese patients. So obesity itself is a very important comorbid problem to severity, to increase the severity of COVID-19 infection. But well-managed diabetes had lower mortality, and this is very important to understand that those patients who have better controlled diabetes in compared to the patients who are poorly controlled. And I think this message we should also give to the society, to all those clinicians. We should talk more about that. A well-controlled diabetic will have a less problem in compared to the patients who are not controlled, and maybe in next wave or even the COVID is going on, they will have higher mortality, those patients who have uncontrolled diabetes. The patients with poorly managed diabetes have higher risk, and this is the data from NHS England, which is talking that patient in death in people with diabetes have more than doubled during this COVID-19 pandemic. Death from COVID-19 is strongly associated with poorly managed diabetes. I think this statement is very, very important, that death from COVID-19 is strongly associated with patients with poorly managed diabetes. And this should be the message on your Facebook, on your social media, to tell the people that they should have a tighter glycemic control for getting the less severe COVID infection, if at all they get the infection. There is a patient behavior that many are concerned about the impact of pandemic on their health as well as for economy. Although many patients are choosing to skip or delay the follow-up visit. And this is very common what we are seeing, that they are not coming to the doctor just because they tell that, see, during this pandemic, how I could come to you. But many patients with chronic disease will spend more on medication to ensure the better adherence. So there are two varieties of the patient. They may remain uncontrolled and they are not visiting the doctors. There are patients who are managing their sugar very well, controlling very well. Even they may not visit the doctors, but they may contact the doctors on a telephone, on a e-platform, on a digital platform for a teleconsultation also. Now, how this role of point of care testing which can be there? One is the advantage of HbA1c point of care testing, and this is where we are using the point of care testing for A1C. The glycemic control, we all know it has to be optimized. People might be staying at home. They are asked to do so. Fear getting infected is they are especially vulnerable. Face-to-face visits are substituted by telemedicine consultation, and that may not allow them to test for A1C or lipids. So the HbA1c point of care testing enables discussion and treatment decision at the time of the visit. So even they are visiting very less number, less time to the doctor, but still if the doctor himself is having a point of care testing, they can do their A1C or lipid or urine for microalbumin. At least these are the tests which can be done in a one point of care device, and you can immediately give the treatment decision at the same time of the visit, rather than sending their blood for the lab, getting the reports on the next day, and again calling the patients for the treatment decision on next day. So that makes or sending the patient again to the lab for getting A1C. The patient has to visit 2 or 3 places, and again patient has to wait one more day or one more time he has to consult to the doctor. So I mean, this HbA1c point of care testing will definitely enable the patient to get the treatment at the same time without going 2 or 3 times to the doctor. So the glycemic control treatment decision can be achieved just with one single clinic visit. The point of care testing is having a patient-centric approach because it allows physician and medical staff to accurately achieve real-time lab quality diagnostic results. It ensures patients receive most effective and efficient care when and where it is needed. The point of care testing enables staff to make rapid trials and treatment decision when diagnosing a patient's condition or monitoring a patient treatment response. It allows users to improve efficiency and productivity. It brings the focus back where it belongs, on the patients. So the effective management of diabetes requires a partnership between a person with diabetes and a health professional. Both traditional lab-based the treatment and POCT have utility in distinct areas. So those areas which they don't have the bigger labs, they have also a better because of the point of care device which is available to them, and various avenues present a clear case of POC implementation. So in summary, that people with diabetes are more likely to experience severe complication and higher mortality. The patients who are poorly managed diabetes have higher risk of outcome, which are bad outcomes in the patients in compared have a better control. The complication of diabetes, including all complications like renal, cardiac, and peripheral vascular disease, have an additive risk factor. During this COVID-19 pandemic, regular diabetes management, which is already disrupted, delaying the management of these chronic conditions, decreased adherence to the medication may have impact on acute as well as on chronic disease outcome. And by using the point of care testing for A1C, improved glycemic control can be achieved and the lab visits can be significantly reduced. The availability of this point of care testing, the growing number of options are available. Simple one like glucose testing, the thermometer, the blood pressure monitoring, pregnancy testing. These all, we know that these are the point of care testing which are available to many of us. The infectious disease testings are also available with some of the infectious disease specialists or some of the hospitals lab or small clinic lab also for dengue, malaria, HIV, or even COVID-19 antigen tests. The testing for diabetes and related complications, as I already talked, in diabetic clinic or metabolic clinic or physician clinic, we have like HbA1c, lipid profile, microalbumin, and albumin creatine ratio, which can be done with a point of care device on your satellite centers or on your main centers. Other like HB, high sensitive CRP, prothrombin time, blood gases, and D dimer. These are also available as a point of care testing. Those who are physicians using and seeing the patient with COVID complication, post-COVID. So they are seeing the patient with diabetes and other problems. So they can use these point of care testing in their clinic to do the hemoglobin, CRP level, blood gas, D dimer, or prothrombin time also. So one very important here, during this COVID time, if we have a point of care testing for C-reactive protein, and that's very important because CRP is in a need for a rapid and accurate diagnosis, which continues to increase in COVID-19. I will not be going in a detail of CRP because all of you are physicians who are practicing diabetes as well as the internal medicine, and many of you are practicing the infection also. And during this COVID time, we all know the importance of CRP, that how important it is for the patients to have COVID. This is an inflammatory marker which gives you the idea that how much CRP is increasing, which is also gives you the prognosis way that how the patients of COVID is behaving. So the point of care CRP test could potentially add information in just a few minutes for patients who have tested positive for COVID-19. As CRP levels are elevated in most cases, and particularly in patients with severe disease, this elevation is very, very high. The recommendation on CRP testing in COVID-19, again, there are multiple guidelines which are talking that in COVID-19, the CRP testing is must, and all of us are getting it. If a point of care testing of CRP could add the information in just few minutes, as we are having a patient in front of you and you are getting the CRP value as with the point of care testing immediately in your lab or wherever you are working. So elevated CRP may reflect to the severe complication, the cardiac complication because of high inflammation, which you can see in the patient with cardiovascular disease or during the COVID-19, which can be also picked up by CRP. Even the cytokinin storm induced by viral invasion, as a CRP increases, you can see that yes, it could be a condition where the cytokinin storm may be there in few days or maybe in a day or two. The secondary bacterial infection, which also increases the CRP value, will have the associated poor clinical prognosis. So, I mean, CRP is very important, and definitely you would like to have the other investigation like procalcitonin for secondary bacterial infection or to confirm all those things. But at least in a point of care testing, if you can get the CRP value immediately, you can decide or you can think what the treatment patient will require for that. The role of point of care testing during COVID-19, as I already told you, that high CRP value above normals, which are exceeded within 4 to 8 hours after an acute inflammatory event. The managing the patients with COVID-19 in a fever clinic. This was a one paper in China where CRP testing is one of the suite of tools used to assess patients who are diagnosed with COVID-19 in a flow chart in a fever clinic in Wuhan, China, developed, published, which was published in March 2020. So, I mean, how the CRP is very important, and this paper was published in March 2020. So CRP is one of the first IVD tests which is recommended after a patient presented with symptoms and with low saturation of oxygen. So, I mean, this low saturation patient can do on their own. So any patient who is suspected with COVID infection with their symptomatology of sore throat or cough or with the fever, if they have the saturation which is whether high or low, the first thing to get them is a complete blood count and CRP. If the CRP is high, you can think of getting their chest CT scan to confirm the viral pneumonia, and then accordingly you can decide if there is no viral pneumonia, there is a oxygen saturation is not very low, then you can think of putting them on a home care, thinking of them in a hospitalization. Again, accordingly you can decide them whether they require an ICU setup or they require just hospital or just in the room. In ICU, again, whether they will need the BiPAP or will they need the invasive ventilation, that also can be decided as per the dyspnea or hypoxic level. So, I mean, this is what a CRP at the level of primary care physician will give you the lot of idea during this COVID time, that how CRP with the point of care testing can decide that this patient, whether it requires a designated COVID hospital admission or whether it can be managed at home also. So the implementing point of care testing in a clinical practice, I just wanted to show that how in a diabetes clinic where we are using the A1C, a point of care testing in a busy clinic in this COVID time, the COVID-19 pandemic, as it has influenced the interaction between a non-infected patient with their healthcare professionals or providers, there is a significant decline in physician visit and clinic visit. So we are seeing less number of patients, but whatever the number of patients who are coming to us, They are non-COVID mostly, but still there is a possibility of infection. So how you have to use? You have to try to do more with the telehealth or telemedicine, which we are doing, but still few patients who come to us to meet face to face, and we want to do their A1C or lipids or microalbumin with the help of point of care testing. So the workflow at the diabetes care testing, it gives files report at reception, and they confirms the appointment, and we try to see only 1 or 2 patients at a time, so not many patients are allowed to come. And then the patient has to be tested for the weight, BMI, and the point of care testing. Here you can see the one lady or the nurse which can do with the A1C or the lipid profile, and the patient is been seen by the clinician. Here my good friend Dr. Manoj is here to see the patient and wait the patient for their turn for consultation. And again, for the post consultation, during that period of time, you get the report of the A1C, and patients can go back with all the reports. I mean, within a short period of time, patient had come and he had gone back with the consultation along with the A1C report also. And that's how the point of care workflow, it can improve the compliance for the patient. At the same time, it is not exposing the patients for more time in a clinic or in a busy clinic with this. With this, I thank once again, thank to Abbott and giving me an opportunity, and thank you all of you for listening this talk. Thank you very much.
Thanks a lot, sir, for a wonderful insight on how point of care testing creates a great impact during this pandemic, where you not only have the age old HbA1c, which was being used as a point of care treatment, and now the CRP through, easiest way of knowing the mortality prediction for a patient with diabetes and during this pandemic with COVID infection. Now I request Jimit sir to invite the second speaker, please.
Dr. Rahul, you can invite. Rahul.
Can we have a slide, Dr. Rajiv Kovil's slide, introductory?
Rahul, it's okay. We could start,
As we know, sir, you can start, sir.
I know.
Yeah.
You have the slide, sir.
It's done. Yeah.
Yeah. Good afternoon, sir. And today, point of care testing is a must for in clinic OPD management of diabetes and its complications. So our speaker will be Dr. Rajiv Kovil, who is from Mumbai, and he's a medical director and consultant diabetologist. He has done his MBBS, diabetology diploma, FRCP. He also runs Dr. Kovil's Diabetic Care Center. He is a consultant diabetologist. He also works in Nanavati Super Speciality Hospital, Raisa Hospital, KLS Hospital, Arogya Nidhi, BACS Hospital. He has been invited for faculty as Diabetic Fellowship Program at DY Patil College. He is founder, member, and secretary of United Diabetes Forum.
Let's start.
Yes, sir. Yes, sir.
Thank you so much. Thank you. At the outset, Bansi spoke about how POCT management has come in. And actually, Bansi has revolutionized a lot of things. So I keep telling him that he should do a workshop on how to conduct conferences. And today he has shown that how to conduct a digital conference. And the world has actually become flat. We all have realized that in this conference, we have, I don't know, at least 5 dozen international faculties and probably 2 dozen international associations together, and that itself shows that the world has become flat. And POCT is one of the offshoots of how the world has become flat. So 35 years ago, when we had to go to a bank to get money, we used to write a self check, signed ahead, signed behind, wait for a line. Cashier would take his time, tell us कि मैं चाय पी के आता हूँ, and another half an hour, 45 minutes to withdraw 5,000 rupees. Today we go to an ATM, within 5 seconds the money is in. And POCT is exactly bridging that need. It's a must for clinic, for all metabolic care physicians, and also for all physicians who practice diabetes. And thank you, Abbott, and thank you, Diabetes India, for getting me here. My agenda is on what's the trend, what are the testing frequencies, what are the challenges we are having. Any point of care always comes, the people with gray hair always raise their eyebrows about point of care. So whether it's glucose meters or anything, a point of care always has an eyebrow raised that probably the accuracy is not good. So we will speak about that. We'll speak about some India specific recommendation. We'll speak about lipid profile and also use of point of care to risk stratify patients and screening for kidney disease as well. So if you see the trends of diabetes, alarming only thing is that the diabetes population is growing more than the world population is. And if you look at it, you have an eager number of pre-diabetics, whether they are IGTs or IFG, who are willing to or very keen to join the population in India. And again, as you can see that the expenditure is also going haywire because of this particular trend. So there is a huge amount of emphasis to be put on what are the tests and their frequency as per guidelines. So, so the surveys done on why do patients do not reach their target control, whether it's HbA1c, lipid, blood pressure, weight. Studies show that 40% is patient related issues and 20 to 25% of the time is system related issues. So by patient related issues, patient feels that I'm all right. Why should I go and check? I did a random sugar, it was 180. I don't feel any kind of symptoms. Why should I check? 25 to 30% of the time is system related check, that we have not been able to tell the patient or convey to the patient what are the guideline recommendations, what are the guideline frequencies that one needs to check. So whether it's a SMBG where we need to give them a structured point of structured SMBG guidelines, or HbA1c, ACR, lipid profile, liver functions, GFR and blood pressure, we need to give them the testing frequency. That's what the ADA says, that the HbA1c is 2 to 3 times per year in a stable control, quarterly in patients. Sometimes in pregnancy, I even do it 1.5 monthly. ACR at least more than once in a year, 3 to 6 months to confirm. Fasting lipid, again, a diagnosis to monitor a therapy, and annually. I would also recommend non-fasting lipid profile for patients, which we'll come to later. Liver functions, we all know almost 75 to 80% of our patients would have some form of fatty liver disease, and that's the harbinger of the metabolic syndrome and the kingpin in this metabolic disorder. EGFR at diagnosis and annually, and blood pressure at every visit. What are the targets? I don't need to tell this learned audience, but the ABC, which is the A1C, blood pressure, lipid, and the ACR targets achieved in India to their targets is less than 5%. So there's a huge moral, ethical, economic need for all of us to come out of a clinical inertia. We all know that this needs to be done, but this needs to be conveyed. The guidelines needs to be conveyed. The frequency of testing needs to be conveyed. So the end consumer, that is the patient, becomes health literate. He grows up one level higher. He puts himself at the center. He becomes responsible for his disorder. That's the time when the patient starts coming and gets himself checked for all these things. And in India today, people have not understood that preventive tests are cheaper than any kind of treatment of a complication. What are the challenges in achieving guideline recommended testing frequency? As I said, only 26.7% patients diagnosed with diabetes met guideline targets for frequency of glycemic, blood pressure, and cholesterol control, which is very good because it comes from a Caucasian country. But if in India, I would say it is less than 5 to 7% where patients actually check for all their comorbidity and risk factors on a guideline recommendation. And as you can see, less than 7% was tested at the recommended frequency for HbA1c testing. Now, where is the problem? Problem is that achieving HbA1c less than 7%, 2.5 times patient managed in compliance with HbA1c testing frequency. 5.3 times patient managed in compliance with anti-diabetic recommendations and A1C testing frequency guidelines, compared to those who did not follow the guidelines. So 70% of patients tested and treated according to ADA guidelines met HbA1c, and only 30% of met HbA1c who did not follow guidelines. So just by telling patients to do their checks regularly, we would be able to make changes in our therapy, whether it's lifestyle or pharmacotherapy, and help patients, handhold patients to reach their target control. What is the impact in guideline recommended HbA1c testing frequency? If you can look at this study, which is done, which is published in 7 years back, again retrospective, but point of care testing increases the chance by 27%, and 95% of patients had guideline compliant HbA1c would have a reduction in HbA1c level. So just by making sure that the patients repeat their HbA1c at least 3 times annually is what is recommended for stable control, or at least 3 monthly, we would have most of our patients coming under control, because that would shake us out of our clinical inertia and make us much more intensive in our approach. So when do we look for a POCT device? What do we look for? We look for one ease. It's extremely important, because we are here in medicine because we were not too good in maths or engineering. Otherwise, we would have been in another field altogether. Though technology has invaded chronic care, we are still not become diabetotechnologists. So it's very important that the machine that we use is automatic, easy to use, certified, and accredited with most of the bigger bodies, with the US FDA, the NGSP, and the IFCC. So India's specific recommendation for in-clinic POCT in diabetes management came in, and we had a board meeting for this on the sidelines of Diacon 3 years back, and we came up with this recommendation for in-clinic POCT, especially for India. And the following summarized principles were established. We defined what is POCT, what are the advantages and the critical aspects of it, key recommendations of in-clinic POCT implementation by the panel. What was recommended was that acceptable performance standardized by an established reference. We should have an NGSP and IFCC certified simplified operation. Good memory, we should at least have 500 patient tests. Clinic management software connectivity, we should have data collection or sharing via USB should be there. All diabetes chronic related parameters, whether it's A1C, lipid, ACR, should be done at a single platform. Again, reports should be presented in both way, NGSP, which is more common in India than the IFCC, and also the estimated average glucose. Again, if there is any kind of error, whether it's patient related, whether it's doctor related, whether it's the drop related, no results should be reported or displayed when the correct result may not be possible to achieve. Again, there has to be a lot of control processes in POCT devices. That's extremely important. So there is minimization of probability of pre-analytical and post-analytical error by accurate calibration based test on the bar-coated test cartridges. So all the cartridges are bar-coated. That again gives them a good amount of pre-analytical calibration. There are a lot of internal quality control checks for the Afinion meters. And again, it is tested based on optimal operating temperature, humidity range. All the people who have used it would realize that I always have told my clinic staff that as soon as they enter the clinic at 8 a.m. in the morning, to remove it from the fridge and make it to room temperature. So by the time I start seeing patients at 9 o'clock, it's come to room temperature. And many a time it's the lipid which needs to come to the room temperature. Any kind of hemoglobin related issues, we should have reports which works in an acceptable range. Again, check for sample coagulation and hemolysis. We again, the additional error minimization in POCTs, because there's no sample transportation. Imagine 30 years back when we used to go with an heparinized syringe to do an ABG, and then as a houseman or an RMO go to the lab in a public hospital, wait for reports for 3 to 4 hours. Today you have point of care ABG. Today you have point of care, all kind of cardiac markers, including pro BNP in high-end hospitals, the cardiac triage. Today you have an RT-PCR antibody. So a lot of things have become easier because of point of care. And I think that majority of patients in urban India come to the clinic having a specific race against time, and they want to finish off everything in a quality time and go back with quality reports. So they want to make sure they go to a quality doctor, They want qualitative reporting. They want qualitative performance. They need integration of the reports. They also need counseling, and they need pharmacotherapy based and individualized pharmacotherapy. So it's important that point of care comes in, because that's what Dr. Bansi Sabu showed in his last slide, that this is a cycle that one can establish, and it has to be fully automated. And again, it doesn't require a lot of expertise at all. It's a very simple thing to be done. So again, availability and accreditation of other point of care, as you can see, HbA1c has been accredited by the NGSP, lipid also by the Lipid Association, US FDA, ACR by the US FDA, and CRP by the CE, which is from Europe. If you look at lipid profile and cardiac risk assessment, many a time we know that it is these abnormalities in patients with diabetes which drives cardiovascular disease, and we need to risk stratify our patients with cardiovascular disease, with diabetes. And the CUP study clearly showed that there was a huge burden of cardiovascular disease, and it was increasing decade after decade, with a 50% increase from 2007 to 2019. Cholesterol testing is integral to diabetes management. I would say that most of my patients go back from my clinic on a statin, irrespective of whether they are on an anti-diabetic therapy or not. There is risk stratification happening for every patient. Barriers to use an ASCVD risk stratification tools is very difficult. Many a time it needs to be integrated with the EMR. We require to make sure that there are a lot of guideline behavior, lack of universal guideline to measure ASCVD risk. Risk stratification tools are complex and time consuming. Risk profile not fully integrated. This is the major problem. It's not integrated. Behavioral barriers presented by physicians, no motivation to spend that extra time in counseling and telling them where do you fit. Lack of knowledge, risk communication is difficult. Again, shared decision making comes in when you have a perfect rapport with your patient. So this is what POC can give you. Behavioral barriers presented by patients is again lack of knowledge. So it's important that we need to give that kind of health literacy to our patient, that he can come back and give us this kind of a feedback. Do not present in a fasting state. Preventive medicine practices are not entitled for claims or reimbursement. It's very important that various strategies can be recommended to overcome these barriers. A CVD risk model should be adopted, which is easy to calculate. The POCT device, which is programmed to calculate a CV risk on physician. This is extremely important that we have in the Afinion. You have know your heart risk score, can be useful to spread awareness. And what it does is that there's a lot of shared decision making, because patient, it's not that the patient gives the blood in the morning, gets reports in the evening, goes to the doctor after a week. Patient is sitting across you or in the next cabin, does his blood test and sees his report, visually sees the report. So he knows that this is my report. There is no kind of errors happening. And that is where shared decision making becomes very important. Patients who participate in shared decision making would have better outcomes and would have lesser events as such. Where I would recommend non-fasting lipids to most patients. The ACE recommends non-fasting lipids to diabetes. The Mayo Clinic recommends non-fasting lipids to diabetes, basically because if you're going to fast for 10 to 12 hours for a lipid profile, a lot of our patients will go into hypoglycemia. Now in India, at least you have you can call the lab home, or you can call a technician home. But in the Western countries, you need to drive. You need to drive for half an hour, 45 minutes to an hour to reach the lab. And many a time you can go into hypoglycemia. That's why I recommend non-fasting lipid profile. A time will come where non-fasting or postprandial lipid profile would be the norm of the year, or norm to be treated for diabetes, because we strongly believe that postprandial lipemia and postprandial hypertriglyceridemia, which accompanies postprandial hyperglycemia, is strongly linked to cardiovascular risk, as well as is linked to endothelial damage. So where are the recommendations by the AHA? In primary prevention, adults more than 20 years who are free from ASCVD can measure LDL cholesterol with a non-fasting. Again, if the triglycerides should be less than 400. So again, monitoring we can do once we have started a statin, we can, because we all know that total cholesterol and HDL do not change in a fasting or non-fasting state as far as the triglyceride is less than 400. Moderate hypertriglyceridemia also use it. Children and adolescents also use it. Again, this you have the point of care testing today, which also has the ASCVD risk scoring inside, and that can really help in helping patients reach the target control. So again, use of POC to stratify ASCVD is a promising technology. Rapid blood test right in front of the patient. You can have risk stratification, shared decision making. Results take 7 minutes, and you can have reports given to the patient immediately. How do these actually handle the barrier? Lack of universal guideline. A POCT works on the Framingham risk coefficient, works on the Framingham risk model. Risk stratification tools are complex. You have an ill-built algorithm, so you don't have to scratch your mind about. Again, patient and physician barriers, no motivation. POCT facilitates a face-to-face discussion and shared decision making. Lack of motivation, POCT enables screening. Again, you have a single risk factor. First reaction is drug prescription. ASCVD risk on the POC enables consideration of multiple risk factors. So there's a lot of holistic healing that one can do after a POCT. Behavioral barriers, lack of knowledge which the patient has. POCT facilitates a face-to-face discussion. Again, do not present in a fasting state. New guidelines allow for non-fasting lipids too. Again, stressing that new guidelines allow for non-fasting lipids. ACR, today we know that most of our patients with kidney disease are at higher risk to develop a cardiovascular event rather than progress to next stage of the kidney disease. And no better marker of kidney disease in a diabetic or diabetic kidney disease rather than an ACR, which actually identifies patients who are at risk for progression to chronic kidney, and also identifies patients who are at very risk for cardiovascular events, whether it's heart failure, coronary artery disease, or sudden cardiac death. Now, who are the patients who should be screened? Type 1 diabetes after 5 years of duration. All type 2 diabetes at diagnosis. Type 2 diabetics with hypertension surely, and all type 2 diabetics annually. Again, look for a US FDA approved POCT you should choose. Again, what would I finish my talk with? POCT testing benefits in managing diabetes and complications. Most important benefit, you give a holistic healing to the patient. Two, you have a discussion immediately on the patient. Third, it's like going into an ATM. Patient loves the experience that otherwise he has to report to the lab, take a token, wait for it to be collected. Then he will have reports come in, he'll fix up an appointment with the doctor, come in, wait again. In this waiting period, you can do his POCT testing. So in a short period of time, patient gets his adequate amount of therapy and goes out. We should use POCT, which is certified. The Afinion is US FDA and GSP IFCC certified. Improves HbA1c testing frequency. Again, economically, it's better because a lot of travel related expenditure, a lot of other expenditures comes down. We can assess a lot of other risk factors, whether it's kidney, heart, eyes, everything using a POCC. Again, easy to measure lipid and stratify patients. It surely leads to better disease management. I've been using POCT for the last decade or so, and patients have improved. Most importantly, practice has improved, economy has also improved. So it's very important that most people in the metabolic space start using POCT, and it's easy to use device, makes it easy to adopt easily by any paramedical staff. Thank you all for a very patient hearing. Thank you so much.
Dr. Sir, you are muted. Please unmute.
I'm very sorry, sir. Sir, I think Bandhi Sabu sir at the outset gave us the relevance of POCT, and then at the end, Dr. Rajiv Kohli sir beautifully summarized the recommendations for an ideal POCT device and what are the precautions we should take while analyzing, and what are the different parameters that we should address as metabolic physicians, whether it is HbA1c, analyzing lipid profile, CRP in this COVID era, and albumin creatinine ratio. We have a few questions. I think Dr. Jimit sir, can you please take them?
Jimit only asked one question, that how to interpret non.
Dr. S.G. Mandal.
Dr. Mandal sir, Dr. S.G. Mandal sir has put up the question.
That is from Dr. S.G. Mandal.
But I am very interested that for second question answer, that some patient deny to do testing in clinic and they won't pay also. How to convince them? I think we have.
Dr. Pradeep Rai, sir.
Dr. Rai, if we can, that is something which requires another workshop in itself. But importantly, if you just compare the costings of lab and POCT is cheaper to the patient. POCT is cheaper. Patient sees his results, so he cannot have any kind of his own interpretation of the results, or he cannot deny the results, which most people do. That you get a bad report, they will go and cross check it. He sees the result. And two, it's all upon us to tell patients that this particular device that we are using is a state of the art device, and it is single calibration. Most importantly, all the bigger counters which happens in laboratory, unless you have a good administrative staff, a good calibration doesn't happen. And each of the POCT test is self calibrated before it starts. So that is what makes the device accurate. And the intra lab and inter lab difference is 2% to 3.5%. And what is acceptable between a lab and POCT, whether it's HbA1c or lipid, is plus minus 6%. So you can put this in your clinic that the device I'm using is so and so approved, and you will have maybe a plus 5 or a minus 5% difference, which is acceptable. Then if the patient starts paying the first month's money, please send it to me also.
But it is not only for this device, Rajiv, how you convince, how you educate. And that's how, Rajiv can take 5,000 rupees consulting fees in Mumbai, and we poor guy are taking only 500 rupees. So that's, how the difference, how you educate the patient, and what type of patients also you get, that's also important. So you have to decide. And I always go with that. It is all your education. It's not only for the POCT, for other investigation for which also you are convincing your patient, whether you are convincing the patient to start the patient on insulin therapy, starting the patients on GLP-1, which is also a costly therapy. You may be asking the patients to get the pharmacy from your place only, to get other lab investigation. For everything, it is your educated. I mean, your educator, your supporting staff, and yourself also, how you educate the patient. That's the only way by which you can convince the patient, the way Rajiv is convincing the patients in Mumbai. But the same with Dr. S.K. Sharma with a Galaxy Diabetes Center. Once patient enters, he can do everything there in the same place. I mean, we have Dr. S.K. Sharma also. But it's all the convincing mean it's an education. We are not talking the word using the convincing. It's an education, education, education. The second important question is asked by Dr. S.G. Mandel about the non-fasting lipid profile. Dr. Rajiv, would you like to take that?
So the ACE says non-fasting. Mayo Clinic recommendation says non-fasting. Fasting, again, 12 hours of fasting in a patient with diabetes, especially if the patient is on secretagogues or on any kind of insulin, would put the patient at hypoglycemia. So again, if you find hypertriglyceridemia, then probably you need to discard that sample and tell the patient that you need to come fasting, and then we would interpret the results. But otherwise, if the triglyceride is less than 400, total cholesterol and HDL doesn't change. And whatever therapy today, the AHA and ACC is directed pharmacotherapy is towards LDL cholesterol. So our treatment doesn't change. So as we have in SMBG, we have an error grid analysis that as far as these reports, the finger prick doesn't change our interpretation or our therapy, it should not change anything. Similarly, when we do a lipid profile and in a non-fasting or fasting state, if the triglyceride is normal below 400, then our pharmacotherapy or our lifestyle modification wouldn't change. So we should encourage a patient to do non-fasting lipids.
Great.
Sir, could you please highlight the device that you're using for the point of care testing at your
So I have
center?
multiple, I love technology, so I have multiple devices. So I'm using the Affineon for my HbA1c and lipid. I'm using Biosense for my ACR. I'm also using biosensor for doing a TSH as well as doing a pro BNP. So using all these things, and it gives you good results. And we also have a tie-up with a laboratory, and which is one of the top 3 laboratories in Mumbai, and we keep cross-checking our results. And that's extremely important, that whether it is US FDA calibrated or an NGSP calibrated, it's your treatment and your therapy. You need to make sure you are able to keep calibrating your system and cross-checking whether how the machines are functioning. So this is what we are using in the clinic.
So do you prefer using direct LDL levels?
So this doesn't measure direct LDL. That requires a separate kit also in the laboratory. So if you have, so most good laboratories have direct LDL cholesterol. So you could just ask for only LDL cholesterol rather than lipid profile, or just HDL cholesterol, because they also have kits. But the POCT doesn't have that feature. So it's calculated by the Friedewald equation itself.
In my clinic, Akansha, I do use the point of care testing of allele for A1C mostly, but I also use D10. But all my satellite clinic have POCT of, and they use in the allele machine with the HbA1c along with the lipids and microalbumin. But I have both D10 and this, and full-fledged lab too. But sometimes we use point of care because immediately we want to give the patient the results, and patient has to go. Maybe this during COVID time, we don't want our patient to stay here more, but otherwise we use both the systems.
Sir, you use fundus screening also as a
Yes,
POC?
yes. I have that with artificial intelligence also, and we do have the retina specialist who is also with us. So all the photographs which are taken with the patient, each and every patient, the fundus camera with the fundus photograph is transferred to my retina specialist doctor, and then he can answer immediately within few minutes. And if those patients who require the specialist consultation, he comes twice in a day at my clinic, and we can keep the patient. Either we call the patients again during that period of time. We do even fundus photography as well as fundus angiography also.
Sir, you had told about CRP in COVID pandemic, sir. So do you feel the need of home collection is also going up? We have seen so many patients, they are now calling the labs to their home during this pandemic. So how do you see this scenario also changing? Still, even after the lockdown is over, patients are more preferring to call the lab guys at home.
So the home collection, I'm sure you know, Jimit, in Bombay and in Ahmedabad or in Gujarat area, in western part of India, the home collection of the lab monitoring is very popular. Even not from now, since long, since last 10, 20 years, our patients are getting, and we also ask them to get their fasting reports to be done from home. Then slowly over a period of time in last 10, 20 years, some labs have come, they are started getting the body profile and completely, patients are getting that complete test of, which is also becoming popular. Now, during this COVID time, what I'm seeing even from the eastern part of our country, which is also now becoming popular, people are getting collected their blood from home. Though it's okay. I mean, the only thing is when patient is coming to your clinic, whatever the reports which are needed in that, bunch of 100 reports or 120 reports, which may not be of any use, you may find 3 or 4 reports which are really required to do some intervention. If you can find those reports in that bunch of reports, you write it and you can start treating, or you can give. These are the biochemical report, but some of the biochemical reports, because of these so many things, suddenly some selenium or some chromium starts coming out.
I was going to say
I
the
don't know
same.
what to do with
Copper,
that.
arsenic, magnesium, selenium. What do
I
you have
don't
to
know
do with
anything
that?
about it. I have to call immediately Rajiv. इसको क्या करने गया? Rajiv कहता है take 2,000 rupees extra and give some tablet.
So do we have any other questions from the audience? I don't think so.
Not from the audience. The panel here can ask the questions.
Yeah, we have Dr. Tirthankar, we have Dr. S.K. Sharma. Sharma Saab, good morning.
Morning, sir. Good morning. So
They
it
are
was
going to
beautiful.
talk on the
It was
pills which are
beautiful
going
lecture
to
by
thrill,
both of you. Beautiful. And we are using POC in our clinic also. As Dr. Bansi highlighted, sometimes we had to keep the things moving fast. And these are not, you can say, not there is really not a concern about accuracy. They are more or less, as you highlighted, 6%. That is the point that we tell the patient that if you are really in hurry, then we will be going for a POC testing. So we have both the facilities in most of the things.
So actually, this session was supposed to get over by 1 o'clock, but if we can close it early, because we have the next session speaker are there, and we can always have more discussion in that, because that's very interesting sessions. The pills with thrills, So the four eminent speakers are already waiting. We can't cut on. I mean, we can't say that they should wait. So over to now, Akansha, to close the session for both the
Yes,
chairpersons.
it was indeed a pleasure to listening all the eminent speakers for this symposium. And I request now hand over the session to Dr. Rohan Patel for the next topic of pills that is going to thrill us all in the next symposium. Thank you.
Thank you so much. Thank you.
Hello.
Yes, Dr. Ron, you are audible.
Good evening. Good evening, Jimmy. Good afternoon, Jason. Yes. So everyone is there. Can I introduce the chairpersons?
Yes, yes.
Yes. So now the next session will be the pill that thrills, and I'd like to invite the chairperson, Dr. B.B. Solanki sir from Ahmedabad and Dr. Ashutosh Chaturvedi from Jaipur, and to start the next interesting session, pill that thrills. Over to you, sir.
Good afternoon, everybody. And first of all, thanks to respected Banshi Sabu sir and organizing committee of Diabetes India 2021 for giving us this opportunity. And today we have a galaxy of speakers in this our very important session, that is pills that thrills. And first of all, I would like to invite my own mentor, my own teacher, from whom I have learned a lot, Dr. S.K. Sharma sir from Jaipur. He's a renowned figure in the field of endocrinology. He's at present consultant endocrinologist at Galaxy Specialty Center, Jaipur. He has been professor of medicine at Mahatma Gandhi Medical College. He has a lot of research publications in reputed index journals. He has been the regional faculty in CCBDM, CCMTD courses, which are enrolled by the PHFI, Public Health Foundation of India. He has been awarded the Naresh Bhu Oration in 2016, also awarded by Times of India Rajasthan Health Award Endocrinologist in 2013, and also awarded by RSSDI 5th Annual Conference as Distinguished Service Award. So I welcome you, sir. Please proceed to give your talk on the topic of repaglinide.
I am not able to share my screen. Somebody has to, yeah. Thank you. So, good afternoon, dear friends. As we are going into the end part of this fabulous Diabetes India by Dr. Bansi Sabu and Dr. Arvind. So thank you very much for making me a part of this very important seminar. So today I am going to discuss a drug which is not really very commonly used, so underused, and we will be discussing what are the pros and cons of repaglinide. So dear friends, as we all know, the diabetes requires multiple therapy, combination of therapy. The repaglinide is also considered to be one of the good molecule. So today we are going to have some introductory discussion about the diabetes and its global impact. Then we will be discussing some of the importance of postprandial hyperglycemia. What are the current therapies in postprandial hyperglycemia management? And then of course the molecule which will be discussed at length will be repaglinide. Discussion about mode of action, what are the indications and doses, what are the side effects and contraindications. There are some clinical evidences there, then place of therapy of repaglinide, and then we will be having summary of this. So dear friends, if you look into epidemiology, we all know at present we are having something like 9% prevalence, 77 million diabetic patients in India, and figures are going to be more than 101 in 2035. So we always discuss that during control of hyperglycemia, fasting, postprandial HbA1c, we want to avoid hypoglycemia and we want to have least of glycemic variability. And that's why we say all together in a single word, that glycemic pentate. So in that pentate, the most important part remains quality of life also, and we then label it as glycemic hexate. So dear friends, we spend large amount of our time in postprandial phase because we are eating three major meal. In between, we are eating some small snacks. So patients with type 2 diabetes may be spending more than 12 hours per day in the postprandial status. And you find that in a normal person, as soon as he starts eating, there is a first phase of insulin secretion, and it is followed by second phase of insulin secretion. First phase lasts for 10 to 15 minutes, and then second phase lasts for as long as normoglycemia is not achieved. And loss of first phase of insulin secretion is considered to be the earliest change in the development of type 2 diabetes. And this loss of first phase of insulin is also contributing to the postprandial hyperglycemia. If you look into relative contribution of fasting and postprandial hyperglycemia to A1C, we find that once the patient is newly diagnosed, his HbA1c is in between 7 to 8.5 or so. And in that range, the contribution of postprandial hyperglycemia is very high as compared to contribution by fasting hyperglycemia. Is postprandial hyperglycemia harmful? Yes, of course, because there are many studies which clearly indicates that postprandial hyperglycemia is an independent risk factor for the cardiovascular complications, and it is associated with so many micro and macrovascular complications, increase in carotid intima media thickness, decrease in myocardial blood flow and volume, and there are more, you can say, risk of cancers and impaired cognitive function. Postprandial hyperglycemia basically causes oxidative stress, inflammation, and endothelial dysfunction. You can see here large number of defects and consequences are there as a result of postprandial hyperglycemia, whether it is increase in insulin resistance, glucose autooxidation, increase in triglycerides, decrease in HDL, hypercoagulability of the blood, decreasing fibrinolytic activity, increase in low-grade inflammation, endothelial dysfunction, decreasing plaque stability, and you find so many other defects. So uncontrolled postprandial hyperglycemia may lead to serious consequences. Thus, it is important to control postprandial hyperglycemia. We have also learned many messages and many lessons from the UKPDS. We know that HbA1c is equivalent to fasting plus postprandial, but here once the HbA1c is less than 8.5, contribution of postprandial is higher. Previously, it was considered that HbA1c is mainly depending on fasting, but now we realize that in 8.5 and below, it is mainly contributed by postprandial hyperglycemia. And there are many studies which clearly links postprandial hyperglycemia to increase in cardiovascular risk and mortality. So it is a need for the hour to control postprandial hyperglycemia and reduce the risk of complications. So current available therapies which are there for the management of postprandial hyperglycemia are like alpha glucosidase inhibitor, glinides like ripaglinide and natiglinide, short-acting sulfonylurea, and short-acting insulin. And in addition, we had DPP-4 inhibitors which are also targeting postprandial hyperglycemia. But today we are going to discuss at length ripaglinide. Ripaglinide is a short-acting insulin secretagogue, just like sulfonylurea, but they are different from sulfonylurea and they are short in their action. So they are short-acting insulin secretagogue used for the reduction of postprandial hyperglycemia in our type 2 diabetic patients. They are having a favorable safety profile with low risk of hypoglycemia as compared to sulfonylurea. Their potency is good. They are very effective drug, and they elicited insulin release in more rapid and brief form. So insulin release is rapid, but it lasts for a short time, and that's why the chances of hypoglycemia is less. And it can be used with other, you can say, oral anti-diabetic drugs other than sulfonylurea, like metformin. So most commonly used combination is ripaglinide with metformin. If you compare ripaglinide with sulfonylurea and mechanism of action, you find that sulfonylurea acts at the sulfonylurea receptors, blocks the ATP sensitive potassium channels, closure of the channels, then causes depolarization, then calcium channel opens and there is a release of insulin. by exocytosis. But there is some difference, subtle differences, as ripaglinide is acting with sulfonylurea. So ripaglinide exerts direct action on the pancreatic beta cell, unlike the sulfonylurea. As we know that glucose is entering into the beta cell and causing, leading to formation of ATP from the ADP, and ripaglinide binds to a receptor which is different from that of sulfonylurea binding site at the ATP sensitive potassium channel. So binding site is slightly different than sulfonylurea. And then the rest of the mechanism is more or less similar. It causes closure of ATP dependent potassium channel, thereby leading on to depolarization and opening up of the calcium channels, leading on to insulin exocytosis. But slight difference is that ripaglinide, unlike sulfonylurea, glucose dependent insulin release, which is helpful in reducing the blood glucose, but on other hand, it is very effectively reducing postprandial hyperglycemia, and chances of hypoglycemia is significantly less. So let's look at a glance about ripaglinide. It is having distinct binding site at the beta cell membrane, greater insulinotropic effect than the glibenclamide and or glimepiride, a more rapid onset of action, greater stimulation of insulin release and reduction of blood glucose level than glimepiride and glibenclamide. Effects were glucose dependent, and that's why the chances of hypoglycemia are less. Glucose and dose dependent insulinotropic effects is seen. So as you keep on increasing the dose, we have better, you can say, insulin release. So other benefits of ripaglinide is that it improves the beta cell function in patients with type 2 diabetes, restores the early phase insulin secretion. That is very important, that somehow it is short acting. That's why it is restoring the early phase of insulin secretion, improves postprandial hyperglycemia, and reduces lipolysis. Because of its rapid onset of action and short life, you can say short-lived action, hypoglycemic effects are shorter. So let's look at the pharmacokinetics of this drug. Absorption is very rapid. It is complete within a period of 1 hour or so. Tmax is achieved at 1 hour, and it is bioavailable by 56%. And you find that it is distributed in all the areas, and you find that it is highly protein bound. 98% of the drug is protein bound, and it is mainly metabolized at the level of the liver by you can say biotransformation and direct conjugation with glucuronic acid, and this process is CYP450 enzyme mediated, and that's why this cytochrome P450 enzyme is required for the metabolism of this drug, and metabolites are not active, so they are neutral, and it is eliminated in the bile. That's why you find 90% of the drug is recovered in the urine in an inactive form, and T half-life is about 1 hour. So these are some of the unique features which make the ripaglinide different from sulfonylurea. And you can see that it is to be indicated in patients who are on diet and exercise. And adjunct to that, if the patients are not controlled with diet and exercise, you can use it as a monotherapy. But you can also use it as a add-on therapy to patients who are not controlled with diet, exercise, metformin or thiazolidinedione, AGI or DPP4 inhibitors. So that's why you find that this drug is useful. And ripaglinide is effective as a prandial glucose regulator, and it should be taken before meal, something like 10 to 15 minutes before meal. And you find that if the patient is eating 2 meals, he has to take 2 tablets before each meal. If he is taking 3 meals, every meal should be having a ripaglinide before meal. And if the patient is omitting the meal, he should be omitting ripaglinide also. Therefore, if a meal is missed or delayed, you find that ripaglinide should not be given at that time. That is important. And what are the contraindications to ripaglinide? It should not be given in our type 1 diabetic patients who are suffering from diabetic ketoacidosis, because it is metabolized in liver. And that's why it should be avoided in moderate to severe liver patients, injury patients. And it should not be given with gemfibrozil or clopidogrel, because somehow the values of, you can say, hypoglycemia are very high when you are using it with gemfibrozil or clopidogrel. That is an important caution. Doses are no fixed doses regimen. You start with 0.5 milligram, you keep on increasing according to the blood glucose profile. and according to the meal, patient taken 2 meals or 3 meals or 4 meals, you have to give it before meals, and maximum doses can be 16 milligram per day. So most of the time we are using 1 to 2 milligram before meal in our usual practice, but you can use up to 4 milligram before each meal, and the maximum dose is 16 milligram. And patients who are not previously treated with any oral antidiabetic drugs, you can start with low dose like 0.5 milligram and then up titrate according to the blood glucose profile. Patients who are treated with other drugs or having a HbA1c which is in a higher range like more than 8%, you can start with 1 or 2 milligram with each meal. And combination of therapy can be given, as we say that you start with low dose with combination and then gradually up titrate. So according to the renal profile, we have to be a bit cautious, but because it is eliminated by the bile, so chances of problem is not there in mild to moderate renal function. So here you can see creatinine clearance of 40 to 80. You can use full doses. In 20 to 40, you should start with low dose and gradually and slowly up titrate. Below 20 ml per minute of creatinine clearance, you should avoid this drug. Drug-drug interaction is a bit important. Drugs which are inducing CYP3A4 like barbiturates, carbimazepine, rifampicin, etc., may increase the ripaglinide metabolism, and you have to increase the doses of ripaglinide. Otherwise, sugar will go up. Drugs which inhibit the CYP3A4 like erythromycin, clarithromycin, ketoconazole, miconazole, they inhibit the ripaglinide metabolism, and then you find higher glucose reduction will be there with ripaglinide. So you have to be careful about that. Those drugs which increases the hyperglycemia, sometimes you find that your drug is not really effective. So you look at that. And we discussed about GM fibrinogen, which causes increase in the blood level of this drug and then causes more hypoglycemia. So we have to be cautious while using ripaglinide. We have to monitor blood glucose. We have to give it just before meal. Meal means you have to take first drug and then within 10-15 minutes you have to take your meal. And it should be avoided during pregnancy. Lactation should not be given below 18 years of age. Above 65, you should be very careful. And about 75 years of age, we should not give because there is no clinical data. In renal function, we can use with low doses, and we should be careful about, you can say, renal significant renal impairment where we should avoid it. In liver dysfunction, of course, because it is eliminated by liver, so we should be more careful. And in moderate or severe liver impairment, we should be avoiding this drug. And because in hepatic dysfunction, what happens, gluconeogenesis and glucose output from the liver also decreases, so the chances of hypoglycemia is more. There are some clinical evidences with this drug. A study found that ripaglinide controls postprandial hyperglycemia excursion better than the glimepiride, associated with significant decline in other surrogate markers of cardiovascular, you can say, profile like markers of inflammation, platelet activation, and lipid profiles are improved. It suggests that indirectly or indirectly there may be some important role in lowering the cardiovascular risk and cardiovascular benefits. That is very important because the drug is acting only at the beta cell site. So it is not acting on the cardiocyte, cardiac myocyte, or in vascular cells. That's why ripaglinide treatment is not associated with any cardiovascular adverse effect. It has higher reduction as compared to glibenclamide in carotid intima media thickness. It also diminishes the progression of CIMT, markers of inflammation, platelet activation, lipid parameters, endothelial function, and adiponectin and oxidative stress. So these are some of the subtle, you can say, effects of ripaglinide, and it is associated with lower cardiovascular risk than other insulin secretagogue. In one of these Danish study, registry, I should say, you look into patients with no previous myocardial infarction, total death, or cardiovascular death, or MI, stroke, or cardiovascular death. You find if the metformin is at line of unity, then you find that ripaglinide is on the left side of line of unity as compared to other sulfonyl ureas, indicating that as compared to other sulfonyl ureas, this drug is having better profile. Ripaglinide has a positive effect on the antioxidant parameters, and it plays an important role in protecting the kidney from oxidative insult also. As regards side effect profile, if you compare them to sulfonylurea, you find that more or less similar profile is there, but hypoglycemia is less. Severe hypoglycemia is really very, very less with repaglinide. So you find that similarly it is tolerated. And recommended repaglinide in CKD, you can see here, because it is excreted by the liver into the bile. So in CKD patients, the chances of you can say upgradation of the repaglinide is not there. So ACE guidelines, Spanish Society Nephrology guidelines, and Canadian Healthcare Societies and other Swiss and others, they highlighted that it can be given in patients with moderate to severe renal impairment patients also. Even in patients who are having peritoneal dialysis, they recommend that you can use repaglinide. So it is considered to be safe in our patients. So most of the time we are using it in mild to moderate renally impaired patients. What is the place of repaglinide? You find that repaglinide restores the first phase of insulin secretion, and it is a potent drug, and particularly when you are using it with metformin, significant HbA1c reduction is there. And repaglinide is a choice of drug in our CKD patients, and repaglinide has the choice of drug when you are having cardiovascular risk patients. So these are some of the points where you can consider repaglinide in place of sulfonylurea, where you are really thinking that more chances of hypoglycemia, or patient is having kidney disease or having cardiovascular risk profile. So in the end, we can see that this combination of repaglinide and metformin is considered to be the best approach, because we know that combination therapy is required. Metformin on one hand reduces insulin resistance and causes decrease in fasting hyperglycemia. Repaglinide, which is taking you can say improve the first phase of insulin secretion and acting as a postprandial glucose regulator. So a optimum management can be seen with metformin and repaglinide, because the actions of metformin and repaglinide are complementary to each other. And you can see here in this slide that when you are using repaglinide alone or metformin alone, less number of patients are able to have good HbA1c control. But once you are using a combination of repa plus metformin, greater number of patients achieve glycemic goal, and combination therapy appears to be a good treatment choice in our patient. So dear friends, in summary, repaglinide is a underused and under-discussed drug, but it is a rapid-acting insulin secretagogue, but works slightly different from sulfonylurea, lowers postprandial glucose excursions by targeting early phase of insulin release, effective glycemic control, and it is well tolerated. Effective in treatment-naive and adult patients on other oral antidiabetic drugs in our type 2 diabetic patients, including elderly patient up to 65, but above 65 to 75, we have to use lower doses, and we should be more careful. And it can be given in our mild to moderate renally impaired patients. And flexibility of doses is also very important, because many a times it is seen that when you are using sulfonylurea, patient has to take 3 meals, because otherwise in between he will develop hypo. But here, if the patient is eating, he is taking a dose of repaglinide. If he is skipping a meal, he is skipping repaglinide also. So the forceful in between, you can say snacking, etc., are not there, and thereby in many of these studies, repaglinide is losing weight. Patients are losing weight on repaglinide as compared to patients on sulfonylurea, probably because in repaglinide treated patient, they are not forced to take snacks in between the meals, and they have not to omit their meals. So here you find that repaglinide, 1 meal, 1 dose, extra meal, extra dose, no meal, no dose. That is the flexibility given to our patients there. So with that, I thank all of you. Thank you very much. I will stop my sharing of slides. Thank you.
Dr. Sharma, you really gave a whole monogram on the repaglinide. No meal, no drug, extra meal, extra drug, or along with the meal, you take the drug, prandial regulator, and should be used in caution with the liver disease, can be used for the renal disease. Really a great job you have done. Ladies and gentlemen, we will take up the questions after the end of all another 3 lectures which are pending. Now I will invite our next speaker, Dr. Tirthankar Chaudhary, who is going to speak on sulfonylurea. Over to Dr. Tirthankar Chaudhary. Please, sir.
Okay. Thank you very much for the kind introduction. Can I share my screen, please?
Yes, sir.
Okay. So let me. What is happening?
Hello, what happened?
So by mistake, he logged out. He is again here.
Dr.
I think it got disconnected.
Yes,
Let
Tirthankar, you
me
can reshare again.
let me share my screen.
Sir, are you there now? Sir, join.
Yeah, you can see me.
Okay.
Yes,
I'm
sir.
trying to
Yes, sir.
see whether
Yes.
you are seeing my slide.
Okay.
So we are able to see your Chrome window. Yes, now I am able to see your slide.
You can see my slide. Okay, so let me go to the. You can hear me also, and
Yes, sir.
okay, let me start. Thank you very much, Bansi, for inviting me to speak on this grand platform, and also congratulations for doing such a good program. The topic that I'm going to discuss today on sulfonylurea is my original paper and was accepted for oral presentation at International Congress of Endocrinology in 2021 February, and I presented it virtually. Now, the topic of my lecture is effectiveness and durability of extended release glycoside in the treatment of type 2 diabetes, a real world perspective. This is the place where I work. It is Apollo Gleneagles Hospital, Kolkata. And I had the pleasure of many of you coming to my program here. Before I start, I think I need to give some preliminaries. That glycoside, the modern sulfonylurea, is slightly different from the older generation because glycoside binding, I'm talking of the mode of action, is that it attaches to the sulfonylurea receptor complex on the SUR1 and it bypasses the EPAC. So what is the consequence of this? The consequence is that it is reversibly attached, it has got a pulsatile insulin release, and it does not affect the KATP channel in the cardiac myocyte. It is on the sarcolemmal KATP. Therefore, it does not affect the ischemic preconditioning. It has chances of less hypoglycemia. So that is the mode of action I'm showing you. The same for glimepiride again. Another modern sulfonylurea, it does not affect the KATP channel in the cardiac myocyte, but on the sarcolemmal KATP. Therefore, these modern sulfonylureas are much better and different from the older generation of sulfonylureas. Now, there are many myths attached to this. The hypoglycemia, weight gain, beta cell exhaustion, durability of glycemic control, and cardiovascular safety. I would like to context these myths with evidence. If you look at the 2020 ADA-ESD guideline, you can see that sulfonylurea has been kept under the heading cost. And of course, it's other places also, if you can see here, but much down the ladder. I believe it's an oversimplification of the efficacy and durability of this molecule because the same body puts glycoside as a highly efficacious molecule in its chart. If you talk about the hypoglycemia and weight gain, then you know the gold standard of diabetes care is, of course, insulin. And they are also not bereft of these virtues, ironically speaking. Now, let us say that weight neutrality. We often talk about sulfonylurea and weight gain. Remember that weight gain is not the property of an isolated molecule. Lot depends upon the diet, the glycemic index, the glycemic load, the calorie distribution, the compensating of minimal hypoglycemia and overeating, lack of exercise, calorie expenditure, and then of course comes the molecule. Advanced study is something which were 8 years average intake and then 6 years. So 14 years of diabetes did not show an weight gain. I think this is an important issue to remember, that gliclazide was given to 91% of patients in advanced study. And then what we found, and 40% had insulin at the end of the study. In weight gain in metformin and glimepiride. So this is the preamble I'm trying to do for sulfonylurea modern ones. Now, beta cell exhaustion is a very tempting hypothesis, almost said in a sweeping statement in many conferences. Remember that way back, diabetes may itself cause beta cell decline. This is a very important statement. Then, of course, you more pedantic one would like to know, do we have any laboratory evidence to that? This is the laboratory evidence, but the beta cell line, the pancreatic beta cell line, was exposed along with gliclazide with other molecules with a comparator to see whether it causes excess production of reactive oxygen species or beta cell apoptosis. And what they found, that if you look at the comparator here, and this is the gliclazide. So if not more, definitely, gliclazide did not cause, rather it benefited the experimental study where it did not show increased apoptosis or increased reactive oxygen species production. So beta cell exhaustion with testes, again, as I said in advance, 11,000 patients, 14 years, and then beta cell exhaustion, I think, is a myth rather than a reality. Now, CV safety is another issue that we keep talking about, but I think we shouldn't throw the baby with the bathwater. Now we have got any number of meta-analysis. This is one you can see where gliclazide is on the forest scatter on the better part. So again, the CV mortality, you can see gliclazide is quite safe. And if you look at the Braunwald's textbook of cardiology, then also you can see that gliclazide has entered and it does not affect ischemic preconditioning and has been said is non-inferior to placebo in terms of cardiac safety. So let us for 1 minute forget that this modern sulfonylureas are same as the first generation. So another meta-analysis for the cardiovascular safety, because this is the brass tacks of the molecule, and that meta-analysis in the European Heart Journal again showed that sulfonylurea was not associated with any significant difference in incidence of MI with respect to comparative. If you look at the real world evidence, then also there is, of course, a gliclazide from the real world evidence in UK, and it compared itself with sitagliptin, and it shows 51% more efficacious. Therefore, with these backup evidence on my presentation, I want to present my study and contest the age-old myth against modern sulfonylurea. Now, modern sulfonylurea, including extended gliclazide, are acceptable standard of care in the management of diabetes. And that is my hypothesis. Now, my objective was to assess the control rates and periods until the initiation of insulin from the onset of diabetes. So my primary goal was to see the durability. What I mean that once the patient was diagnosed with diabetes and they were put on gliclazide, how many years it took to start insulin. So I'm talking of the durability of the molecule. And also secondarily, we looked at the efficacy. We looked at the hypoglycemia and we looked at the weight gain. Remember, this is very important because in this study, we are looking at durability. What we are trying to say that if you say that if you get sulfonylurea on board, especially the modern ones, you are going to increase apoptosis, I believe is a myth. So let's see what my study found. My aim was to assess durability, second efficacy, third weight change, and hypoglycemia, as I mentioned already. Now, what is the method? What we did is, to maintain homogeneity, we recruited 300 patients who are regularly following up with me in our clinic to maintain a homogeneous character of the cohort. And we took the patients who are already 5 years of diabetes. So some patients who are already on 5 years of diabetes, they are continuously following up with us in our clinic to maintain the homogeneity in lifestyle advice as well. And what we found is that we had 159 male, 141 female, and then evaluate the patient under a retrospective longitudinal analysis. The study was conducted in 2018-19 in a dedicated institutional diabetes care clinic in our multi-specialty hospital, Apollo Clinical Hospital. The patient with the duration of diabetes was more than 5 years, as I said. And what I found interesting was we had patients even over 20 years on this regimen, gliclazide plus standard of care. And they were still on the oral hypoglycemic agent and not on insulin. Structured patient education and lifestyle management was provided during each follow-up visit. And we did a descriptive statistics for analysis. These are the results of our study. We had a mean age of 55.14 years. So the patient we included were probably the typical OPD patients, slightly older because we are following them up. The mean age beyond was 7.1%, which is almost near to the target of ADA guidelines. So we had 82% of patients who achieved target range of HbA1c less than 7%. So 18.7% patient had diabetes for more than 20 years. I think this is interesting to note. And not necessarily all of them were on insulin. The mean duration of treatment of the regimen of gliclazide, extended release plus metformin, was 12.81, almost 13 years, plus minus 6. What I'm trying to say is those patients who were diabetic and who were put continuously on gliclazide, the average duration was 13 years before they needed insulin. But remember, there are plus 6, so it's something around 19 years without insulin. And of course, there are a few who were 5 to 10 years and needed insulin. But we had an average of 13 years. Maybe some credit you would give to the standard of care that we have developed now. But this is an evidence that if it was acting as a hurdle, if the modern sulfonylurea was a hurdle to the durability, then it should have happened much earlier. Only 1% patient reported episodes of confirmed hypoglycemia, but were self-managed. Again, if you contest this data with the advanced study where it was only 1.5%, and of course, the reason that there is slightly more hypoglycemia in the advanced study is because they targeted HbA1c of 6.5% in the well, so you'd like to know exact distribution of the data that we found out. So you can see we had the sex 159 male and 141 female. Less than 25 BMI was 150. I want to draw your attention that we had 50% of patients who had a BMI of less than 25. So this is interesting because this is what our population demography looks like in our clinic. But of course, I'm not saying that they didn't have a central obesity. 26 to 30 was 124, 31 to 34 was 19 patients, 35 to 40 BMI was 5, and over 40 BMI was 2. And duration of diabetes, we had 5 to 9 years, 1/3 of the patient, and 2/3 of the patient had diabetes from 10 years onwards. So therefore, 87 patients, 54, 56, and 49, and 56 patients. So we had a huge number of patients who had far more than 10 years of diabetes duration. Insulin requirement, nobody needed below 5, that's why we recruited them. 5 to 9 years, only 4 patients. 0 to 14 years, we had 18, that includes the 4. Remember, so I'm including as I go. 0 to 14 years, we had 18, 0 to 19 years, 37, and of course, more than 20 years, 49, all inclusive. So this is the data. Weight is used for BMI group. I also, so you must remember that we have been using the standard practice. Some weight gain was also due to some patients were on pioglitazone. Therefore, this is the description of our finding. If you look at the pie chart for a better understanding, 6.3%, 49 patients in due course required insulin. So we had 16.3% of patients who needed insulin. The number of patients, the BMI, as I said, was 150 patients below 25, which is, of course, a very much a clinical picture. The number of patients, the duration of diabetes, again, I said 1/3 was 5 to 9 years, but rest was longer duration, 2/3. So you cannot say that I included only the younger patients to see that. Insulin initiation was started at more than age 1. The fundamental question you would ask me, when did I start insulin? Of course, if the patient failed to come under control at age more than 8%, we start. If you look at because you see 50% has got a BMI less than 25. And if you look at the duration of diabetes, then also you understand that there are a huge number of patients, 2/3 of them were beyond 10 years. So what is the conclusion? We observed a sustained glucose lowering attributed to gliclazide-based approach, demonstrated by majority of patients, which enabled to postpone insulin initiation despite a long duration of diabetes. This is fundamental. We often in our clinic try to advise and take out the sulfonylurea. You can do, of course, in your wisdom with individualized patient. But what I am trying to get home the message that this is a study that tells you that we can continue with gliclazide and even reduces the dose of insulin requirement. Overall, the patient achieved a glycemic level close to the target of 7% and below. Our findings support sustained glycemic control for durability with potential to postpone insulin initiation attributed to extended release gliclazide, a modern sulfonylurea. To sum up, if you are still not convinced, cost is also very important. And this was my bibliography. And thank you for listening to me. Thank you very much.
Thank you so much, sir, for the enlightening talk on sulfonylureas, especially glyclazide. And we will take up questions later on. So we will now proceed for our next talk, that is by Dr. G. Vijay Kumar, sir, on saroglitazar. Dr. G. Vijay Kumar, sir, from Chennai, is a consultant at Apollo Specialty Hospital Diabetes Medicare Center. He has over 40 papers published in various journals. He has got the New Horizons Award, Dr. Kisar Ahmad Madras University Diabetes Oration, Professor Sam G.P. Moses Oration. He has also got the Best Doctor Award from Dr. MGR Medical University and Lifetime Achievement Award by Dear Academy Hyderabad in 1999. He has been president of APDF in 1999 and 2013 and had been a member of Executive Committee of RSSDI Tamil Nadu chapter and organizing secretary of the 6th World Congress of Diabetes India held at Chennai in 2015. I welcome you, sir, to proceed and give your talk on saroglitazar.
Can I share my screen?
Yes, sir.
Am I audible?
Yes, yes, you are audible, sir. So please share
Video
your
screen. Cannot come. I think some issue in my computer.
Yeah.
Anyway, respected chairpersons and the co-speakers and dear delegates, good afternoon to all of you. And I would like to profusely thank Dr. Banshi and other team members for giving me this opportunity today. It's a wonderful meeting. If you see that the whole session is on the pills that thrill.
Sir, sorry to interrupt. Please share your screen, sir. Your slides are not visible.
It's not screen?
Your slides are not visible yet.
Some issue I'm having.
So is there any problem? May I help you?
No, I think I'm not able to come into this. If you permit me, I'll just go out and come back again.
Can you? Yes, you can. And if you want, you can mail me your slides. So I'll share it from my side.
No. Yeah, okay. I'll just go out and come back again.
Okay, okay. Dr. Ashutosh.
Yeah. We can proceed for it.
Sorry
I
about
think
that.
we
My
are
apologies.
yeah, you can solve the issue, sir, and we will later come to you.
Okay, you can ask the next speaker.
Yeah. I think we are having Dr. Sachin Chittawar with us. Sachin, sir, you are there?
Dr. Sachin, you must have got a notification to unmute yourself.
Dr. Sachin? I think we should call him once.
Yes, I'm calling him.
Yeah, I'm there. Are my slides visible now?
Okay, sir is here. Yes, your slides are visible now, sir.
Okay, then fine.
Please make it full screen, sir.
Yeah, sure. Is it okay?
Yes, we can move now.
My apologies for. Am I audible, sir?
Yes, you are audible, sir. Please proceed.
My apologies to the delay due to the technical issue here.
We are still on time, sir.
Yeah, pills that thrill. Thank you for giving this opportunity. I think Saraglitazar is now the newest kids in the block for management of diabetes. And the importance of this Saraglitazar is because of the absolutely an Indian molecule. This is actually the first NC of India, that is a national chemical entity of India. Let us see the details, what is going to happen, and then whether we can decide about whether it can thrill, this pill can thrill us. Now, if you look into that, it is almost 20 years of journey so far. The molecule was identified way back in 2001, and then it has given approval by DGC in 2013. In between, they have finished the they started the phase 3 trial in 2008. So it took about almost 12 years before they were able to get this approval for that. And after DGC approval for the the thing is that it is not approved for diabetes management initially. It is approved basically for approval for treatment of diabetic dyslipidemia, not for diabetes actually, if you see that. There are so many milestones happening over the time. You can see that 2014, there are some trials have been initiated, and there was a real world data clinical study done with 3,000 patients in 2015, and go on and go on. And one of this very eventful thing has happened is 2019 evidence 4 study, which is a phase 2 study done in USA. And then in last year, 2020, you could see DGC approved as given saroglitazar 2 new indications apart from dyslipidemia for NAFLD as well as diabetes management. So you can see the journey. By 2020, it took about it's almost 19 years before you get such an event actually. The issue is that what is saroglitazar? Saroglitazar is basically a PPAR activator, and generally what we see is that most often what we see is both glitazones in the form of ROSI and PIO that we had, and proglitazone we had, and then also glitazars which have come and gone away, like muraglitazar and other things have come and gone away before they could be entered into the market. This is probably the dual both alpha and gamma, PPAR gamma agonist. But thing is that if you see the glitazones, they're more of a gamma, PPAR gamma agonist. And it's always better to have a molecule which can address both alpha and gamma agonists, so that because we'll come back again why I'm telling about this, that it's better to have both. And saroglitazar, if you can see that it is higher specificity for PPAR alpha agonism compared to gamma agonism. But it is there, so that you can get a dual beneficial effect on diabetic dyslipidemia as well as glycemic control, and that is what is the most important thing. And these are the pharmacokinetics. You can see that, and it's basically given it as a 4 milligram administration, found to be metabolized into 3 minor oxidative metabolites. Non-renal route, saroglitazar is predominantly eliminated unchanged by the hepatobiliary route. Now, what makes a difference between the other glitazars, like muraglitazar, and there's so many other glitazars which are available, like ragaglitazar, muraglitazar, and all. But the most important thing is this one. If you can see the blue, and there is a novel West type, the novel substitution of the western portion in chemical structure of saroglitazar. This novel substitution, which is a pyryl moiety, which makes saroglitazar different from other glitazars. And most important thing is most of the glitazars which come because of very toxic, and then they were not able to be continued. But this is the one which seems to be safe and then can be introduced into use in human beings. In fact, it is not glitazone. Friends, you should recognize that this glitazar and glitazone are two different ones. If you look into this thing that the glitazones, if you can see glitazones, this TZD ring, which can be seen in red, is not there with glitazar, saroglitazar. And once you don't have the TZD ring, it cannot be a thiazolidinedione or TZD. Now, if you look into that, the studies that have shown that getting a 50% activation of PPAR for alpha activation, it requires only 0.00065 nanometer, whereas for gamma, it is so strong towards alpha And you can see that 3 nanomilligrams is for PPAR gamma. That indicates it's a moderate activity, very good activity with alpha and moderate activity with gamma, PPAR gamma. Now we are talking about that. Why is it we need both alpha and gamma agonism? Because these are the two aspects what we see, that we know in type 2 diabetics, most of the people, more than 85% people do have insulin resistance, and majority of the people will have fatty liver. And if you can see that they have different type of dyslipidemia, especially Indian dyslipidemia. And if you can see that if you can have agonism for both alpha, PPAR alpha and PPAR gamma, basically the receptors are nuclear receptors that function as transcription factors, and these work in transcription of the nuclear receptors so that we get benefits. For example, if you take an alpha, primary alpha effect, it will improve the plasma lipid profile. You can see here it becomes an anti-inflammatory. It increases the fatty acid uptake, fatty acid oxidation, and HDLC increases, and triglyceride reduces, and it also works as an anti-inflammatory. If you look at the gamma effect, gamma, it reduces basically the insulin resistance. It improves their insulin sensitivity, it improves the beta cell function, increase the fatty acid uptake. Look at this adiponectin secretion, which is also included, and again it can also work as anti-inflammatory. So through activation of both the alpha and gamma, it reduces the typical diabetic phenotype type of lipid profile, especially in Indian phenotype, the triglycerides, and improves the HDL, and it is supposed to reduce the insulin resistance as well. So this is the benefit of alpha gamma agonism. Now, has it got any role? So now you know that how it works, both for alpha and gamma, majority in alpha and moderately towards gamma. Look at that, has got any effect on atherogenic diabetic dyslipidemia? This is what we need to look into that. Now we know that type 2 diabetes is insulin resistance is a hallmark, and we know that the high triglyceride also will increases the CVD, and also majority of our people will have NAFLD, and causing that insulin resistance of the hepatic tissue can increase the hepatic glucose output and in turn causes hyperglycemia. And we know that there is exponential growth of diabetes in the world, as well as in India is exceptional exponential growth is being, we know that. And look at this typical phenotype in India, especially from India study, if you can see, 30% of the people had triglyceride, and 70% of the people had low HDL. This is the very, very typical dyslipidemia that we have. And only 12% had high LDL, and 14% only had high cholesterol. But the majority of them had either high triglyceride and low HDL. This is in 788 type 2 diabetic patients. And it looks like that 9 out of 10 Indian diabetics were dyslipidemic because of this, especially either low HDL or high THL. So this is what we need to look into that. Now, can this improve this particular diabetic dyslipidemia is a big question. And this is one study done by Krishnamurthy et al. This is basically they have taken newly detected diabetics, 20 of them. They had atherogenic diabetic dyslipidemia defined as a combination of high triglyceride, low HDL, and high LDL. And then what has been found is that in these newly detected diabetic people, we could see that the atherogenic diabetic dyslipidemia was found to be in 34% of the newly detected diabetics. And the most important thing is that those who had HbA1c of more than 8, majority of them, that is uncontrolled diabetes, higher the blood glucose levels, higher the HbA1c, you could see that this dyslipidemia is increasing. Now, the pattern of dyslipidemia, which is different compared to what is in Western world that we know, it is even newly detected diabetic, it's in 35% of the people. And then when the HbA1c is higher, more and more people are going to be having this atherogenic diabetic dyslipidemia. Now, this is where the importance lies, is that if you can reduce insulin resistance, reduce the HbA1c, and also address the triglyceride, I think with one molecule, you get more and more benefits so that you can reduce the atherogenic dyslipidemia. Now, apart from that, we are also should think that in spite of the maximum tolerated statin, we get maximum result of about a reduction in CVD is about 35 to 40% in various studies. Now we have another 75% plus of residual risk that has been found in heart protection study and as well as a CART study. There is 70%, close to 70% of residual risk. And the only option that we have to further reduce the residual risk is only then you need to address the triglycerides and increase the HDL. Otherwise, you don't have any other any way to do that. Now, whether this issue about residual risk reduction, if there's one more study, it will fortify what we think is a Predimed study. It's a trial population of close to 7,000 people, follow period for 4.8 years, and they had about 263 MACE incidents. The most important thing is that it is more predominantly seen apart from LDLC, those who had a higher triglyceride and remnant cholesterol and were been having to have a major that is high triglyceride more than 150, low HDLC were associated with more MACEs. And no doubt why both the ESC and ASC has clearly indicated that in high risk patients with triglyceride levels between 135 to 499, despite statin treatment, we need to consider other treatments. One of the things is that omega fatty acids, and if you can see the AAC guidelines, in spite of omega fatty acids, if you have a triglyceride more, and we need to think about fibrate. Now, is it this particular molecule which has got greater effect on triglyceride? Definitely, do you think that probably, hopefully, it is going to thrill us in future? It can be included. You can see that your triglyceride is more than 500, fibrate, statin, omega-3 plus niacin. Consider pioglitazone and insulin is being the consideration, the ASC. Maybe, hopefully, we can include saroglitazone in future as well. Now, let us look into one more study that is effect of a PPAR alpha gamma agonist or insulin sensitivity. Now, this is very interesting. They've taken about 30 patients and who had a fasting triglyceride of more than 150 and HbA1c between 7 and 9, and they did 1:1 distribution, and they given for 4 milligrams of saroglitazar or placebo, and this is clamp study done, and then duration of 4 months. You can see that from the baseline level, you can see that in 4 months, you could see that there is a phenomenal increase in insulin sensitivity in those people who received saroglitazar, and also improvement in glucose metabolism. So it reduces the insulin resistance and improves the glucose metabolism so that it is supposed to bring the HbA1c as well. Now, let us look into integrated review analysis of various studies that have been done with various duration. We can see that several authors from India, Shetty, Banshi Sabu, Shashank Joshi, Chatterjee Saab, and all these people have done it. And what has been found in this basic analysis about the integrated review analysis for all the patients involved in usage of saroglitazar, it was effectively and safely reduces triglyceride from anything between 45 to 62%, non-HDL cholesterol up to 36%, and you can see that the liver enzymes come down to almost close to anything between 30 to 70%, and the LDL is also reduced by 20%. And most important thing again is that HbA1c reduction has been phenomenal, 0.7 to 1.6%. Now, when this molecule was introduced in 2013, when I spoke about this molecule, the innovators have said that the reduction in HbA1c was 0.2 to 0.3, And now later we could see that the improvement, you can see that it is able to reduce points on to 0.16. And saroglitazar reducing such a HbA1c is to be noted. And these are the studies which have been looked into that. Now, the other aspect of thing is that NAFLD. You know that NAFLD is a NAFLD as also is a good question. And prevalence of NAFLD in India is almost 30%, and 70% of the type 2 diabetes will have a fatty liver, and obesity also will have 90%. And diabetes and obesity have a positive association with risk, and so that it is worth looking into whether saroglitazar is going to be improving the insulin resistance. Let us look into this. And this is interestingly, evidence 4 is the first ever phase 2 published data on NAFLD from USA. This is basically a prospective, multi-center, double-blind, randomized study of saroglitazar using 1 milligram, 2 milligram, 4 milligram versus placebo in patients with non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. That's evidence 4. Now look into the results. And by using saroglitazar 4 milligrams, you got the best results compared to placebo in 1 and 2. And you can see that the reduction in by way of a percentage change by ALT is about almost 45%. And then this is the primary efficacy endpoint. And then if you look into the secondary efficacy endpoints, you can see that the amount of change in the liver fat, the people, the percentage of the people who had a reduction in liver fat content of more than 10% is in almost 55%. This is very good result. And those who reduce the fat content for more than 30%, it's about 41%. This is a very, very good result. And then there is one more study looking into the effect of saroglitazar in NAFLD and diabetes dyslipidemia, a prospective observation real world study where they have looked into blood investigations, liver stiffness measurement, that is LSM, and controlled attenuation parameter CAP by FibroScan. So are compared from baseline and after 6 months with saroglitazar 4 milligrams. Look at the good results. The conclusion is that saroglitazar leads to significant improvement in the transaminases, LSM, and CAP in NAFLD patients with diabetic dyslipidemia. This is a very good result that has been found. So you could see that in 2020, DGCA has approved because of these evidences that you have. This newer indications, apart from triglyceride reduction, DGCA has given approval for type 2 diabetes and as well as NASH and NAFLD. So friends, big to say that, and this is one molecule which may be thrill in our usage in our practice, and which has got, which typically, if you can see that, it typically suits an Indian phenotype of diabetic patients who got insulin resistance, which can be reduced, which has got triglyceride reduction because Indian phenotype is high triglyceride and low HDL. And I think and this drug must be able to thrill us in using in your practice. Thank you for your patient hearing.
Thank you so much, sir. For yes, Solanki sir, please.
Yes, thank you, Dr. Sir. Hello, thank you, sir. You really gave a whole discourse on the saroglitazar. Everything has been given, and the newer indication and everything have been covered. We will discuss more during the question answer. But now in this session, Feel That Thrill, the last lecture is there. And for that, Dr. Sachin Chittawar from Bhopal. Dr. Sachin is an endocrinologist practicing in Bhopal. He is MD, MBBS and MD medicine from Government Medical College Bhopal and DM from Delhi. Apart from his endocrinology practice, Dr. Chittawar also is teaches the undergraduate and postgraduate student, ex-assistant professor of medicine at Gandhi Medical College and Hamidia Hospital, Bhopal. Award in his name are Rising Star Award, IDS Mayo Clinic Mumbai 2017 Award, AV Gandhi Award for paper writing in 2012, and many more. His special interest is in Cushing syndrome, metabolic bone disorder, reproductive endocrinology, and he is a guest faculty in many national and international conferences since 2012. So over to Dr. Sachin Chitwar. He is going to talk on the gliptin, and that is the 10 gliptin. Over to you, sir.
Thank you. Thank you for the kind introduction. I think my slides are visible now.
Yes, sir. Yes.
Yeah. Okay. I'm not been able to make it slideshow. I don't know why it is not coming. Okay, so I've been given the responsibility to talk about tenagliptin, a pill that thrills. That's really stands well for the molecule. When the molecule was launched, it was launched as an orphan molecule, and all of a sudden, it was a blockbuster in India. One of the highest prescribed molecule in a lesser duration is something like tenalagliptin, which has achieved. And we all, till then, we knew about the benefits of DP4 inhibitors. So we needed a molecule which is afforded by all. So an ideal treatment in diabetes would improve glucose level, which also targeting those multiple abnormalities as has been shown by Defonso. So we need a molecule which should be neutral for weight gain or reduce weight, hypoglycemia, poor compliance or lack of durability. So DP4 inhibitors devoid of above effects. So it is something which is an essential molecule, and over the top of it, if it is cheap, definitely it was bound to show the response what tenaligliptin showed in Indian market. And this is the defonzos ominous octet and the molecule uh, tenaligliptin or a DP4 inhibitor. It acts on the majority of the octet of defonzo. So it is an eligible candidate to be kept in armamentarium. So we all know about the effects of tenaligliptin or DP4 inhibitor on beta cells and the glucose-dependent insulin secretion, the beautiful concept which was hypothesized and theorized, and then we had this molecule. It has never happened so much effectively in the past. So I'm very fond of this GLP mechanism and DP4 inhibition that leads to increase in insulin as and when required. Apart from that, we were initially talking about this is a molecule which is good in early diabetics. Later on, they realized it has got this additional alpha effect, which makes it a candidate for secondary drug failure also. So nowadays, it has pushed in the usage of insulin or introduction of insulin later on. When combined with metformin, it reduces the hepatic glucose output for just because of metformin, moderate effect on insulin resistance, and apart from that, the beneficial effects of DP4 inhibitors, and that adds on to the beneficial effects of the molecule, and that is something extraordinary we never witnessed in the past. So the safety and general efficacy data of gliptins are robust and ideals. It is an ideal second line agent, and so what about the CV effects? Because there was a lot of hullabaloo regarding the CV effects of a molecule, and people are they used to say that the molecule doesn't stand because it doesn't have data. So now we have got enough about its widely studied short-term cardiovascular outcomes of newer anti-diabetic classes and see what it says as compared to sulfonylurea and basal insulin, lesser chances of having cardiovascular risk. So the what the CVO2 is telling us is CVO2 is just telling us the molecule DP4 in itself is a safe molecule and is a meta-analysis which provides robust reassurance about the CV safety of DP4 inhibitors with regard to individual antithrombotic events. So DP4 inhibitor is it a second choice, but which one to choose? Because there are so many DP4 inhibitors and all of them, I will say, are almost at par. Some of them scores in some other areas, some of them have some other brighter aspect. But there are two molecules like that is linagliptin and tenaligliptin, which are definitely they are specific and the renal excretion is less. So we need not reduce the dose of the molecule when it comes to renal failure. So teneligliptin is non-inferior to sitagliptin because we are comparing it with sitagliptin because the most robust data for gliptin is definitely from TECOS. So in the context of the triple therapy from type 2 diabetes, see the HbA1c reduction of 1.03 and the teneligliptin was non-inferior to sitagliptin in the context of triple therapy of type 2 diabetes and is an important option in this setting. So this is something good about. So all gliptins have demonstrated nearly similar efficacy. And when it compared to this as an add-on therapy in Indian type 2 diabetes, because we are always worried about the Indian data, and this is the molecule which has been prescribed like anything in India. So we needed to have a published data. And teneligliptin was found to be comparable to sitagliptin in terms of glycemic control and the safety in Indian type 2 diabetic patients. And it is significantly it is improving hyperglycemia in patients with type 2 diabetes, irrespective of eating patterns. That is the Ruby trial. I'll be talking about this trial in the subsequent slides. So teneligliptin is large data available because nowadays we judge a molecule on the basis of the published trials and data, and so we had a huge robust clinical experience with the molecule. Now it's been 6 years. So safety and efficacy of long-term treatment. So this trial, this Ruby trial, is a real-world data of 10,000 patients, and that is something phenomenal. So this is the distribution of the patient, and they were on concomitant anti-diabetic drugs, and see the HbA1c reduction throughout 2 years. As in the previous lecture, the gentleman was talking about the robustness. See the robustness. Once it is down, it is keeping the HbA1c almost at that point. If you will talk with respect to glycemic variability, this is almost, if you will talk about basal insulin, this is peakless insulin. So this is the response is phenomenal and very picturesque. That's why I use those words. So efficacy according to HbA1c level, as we all know, higher the HbA1c, more is the fall effect, and that is true for teneligliptin. And the adverse reactions less than 0.5% with respect to hypoglycemic unconsciousness, conservation, and so many things. So it appears to be a very, very safe molecule when it comes to teneligliptin. Incidence of serious side effects are cardiovascular safety, it is there, myocardial infarction doesn't go up. So no cardiovascular involvement, and there is a European or Western data because we are somehow somewhere we always look after what the FDA says, what the European Society says. So there is a study of 55 European centers, and is there a Western data for teneligliptin? This trial is having 447 patients, and see the effect of it. And with respect to it is co-administered with metformin and produce significant reduction in HbA1c in patient with type 2 diabetes without the risk of hypoglycemia. And there were issues for QT prolongation. The molecule is prolonging QT. It is not safe. It should not be given. So the 12 lead ECG recording, the study is just talking about that. And teneligliptin co-administered with metformin produces significant reduction in HbA1c in patients with type 2 diabetes without increasing the risk of hypoglycemia. So the European hepatic safety data, and it's just talking about overall teneligliptin was well tolerated by subjects with hepatic impairment because we know some part of it is excreted through kidneys, some part of it is excreted through liver. So it appears to be safe. And what about this QT issue? Because it is something which attracts everyone and does not cause QT prolongation in type 2 diabetes patient. This is a pooled analysis and was presented in IDF in 2017. In this analysis, they found that teneligliptin at recommended daily doses does not cause adverse events. And in India, we are using at 20 milligram OD, and in Japan, they are using it 40 milligram. So our chances of even getting this adverse side effects was even lesser, and now it has been refuted by the Congress. So the QT prolongation found with all DP4 inhibitors at supratherapeutic dose range is something which has been because they say the paper says all DP4 inhibitors have this tendency of QT prolongation, and it is not just with tenaligliptin at higher doses. This slide is making this a beautiful slide, which somehow somewhere has not been shown in majority of the publications. So I found it very interesting to show it. So what about the CV safety? It improves left ventricular diastolic function and endothelial function in patients with diabetes. And when compared with sitagliptin, vildagliptin, and sexagliptin, see the major advantages when the renal outcome. You need not reduce dose, and the CV outcome, the safety is there, and there is nothing like QT prolongation. And so, what about the renal safety of the molecule? The dose adjustment as per the DP4 in CKD and because we are now talking about CKD in diabetes, that's a hot topic because there are so many trials. The credence data, the data from DAPA CKD has enlightened us like anything. And there are two molecules, and teneligliptin is also one where we need not worry about the renal outcome. So, and the Ruby trial also substantiates this, and it validates the mean HbA1c time adjusted outcome, and it has got no renal adverse outcome. So to conclude, teneligliptin is specific DME4 inhibitor with dual excretion through hepatic and renal excretion routes, once a daily dose, and a low potential for drug-to-drug interactions, and clinically effective in reducing HbA1c, fasting, and PP, and have beneficial effects in reducing glycemic variability. It is weight neutral and has low risk of hypoglycemia. So I fully agree, and you will also agree with the fact it is a pill that has thrilled us and still thrilling us since last 5, 6 years. With that, I will end my talk. Thank you, Dr. Bansi Sabu sir and Diabetes India for giving me this opportunity. Thank you. Thanks a lot.
Thank you, Dr. Sachin Chitawar, for this very enlightening talk on teneligliptin. And the house is now open for discussion and question answers.
Request all our previous speakers, Dr. G. Vijay Kumar and Dr. Tirthankar Chaudhary and Dr. Sharma, because questions are there.
Good afternoon.
Good afternoon. One of the question is for Dr. Sharma. That question is that, can we add a ripaglinide with any 1 ml on top of some pre-existing sulfonylurea?
Well, usually we say that when you are using sulfonylurea, you should not be using ripaglinide. But here they have modified the question that probably they are using sulfonylurea with once meal or twice a day, and then the third meal can be covered with ripaglinide. Theoretically, you can do it, but because the duration of action of sulfonylurea is a long one, and the overall mechanism of action of this sulfonylurea or ripaglinide is more or less same. So probably you will get less response of this drug when you are combining it with sulfonylurea. And on other hand, chances of hypoglycemia may be slightly more. So that's why we say that because it is a secretagogue, so you should not be combining sulfonylurea with ripaglinide.
Sir, another question is for repaglinide, and that is regarding that since it has been a long time since glinides are in the market, but what do you find the reasons for its lesser usage still?
Well, one important point is that the noise level, what we say in our usual terminology, is that the noise level of the drug is very low. It is underused, under-discussed, and even in our, you can say, guidelines, it is not really appearing that commonly. So one point is that. Then very few companies are making this drug. Thirdly, because it is to be given with meal. So sometimes people argue that because patient is taking 3 meals, so you have to give it 3 times a day, it becomes a compliance issue. Patient may forget it, something like that. So higher the pill burden, more is the chances of, you can say, adherence issues. And that's why people, I think, are not really using it. But you can use if the patient is taking, let's say, 2 meal, executives who are working and sometimes delayed in their meal pattern, so they can take a drug and take a meal. If they are omitting that meal because of busyness, they can omit the drug. There's something like that. In sulfonylurea, because of their long action, you have to take meal. So if a person has taken a long-acting sulfonylurea like glimepiride, etc., at the morning, and if they omit their lunch, probably they will develop hypoglycemia. So the compelling need is there for distributing the meal pattern there. But in repaglinide, it is considered to be safe because very short action, fast action, short action, and the action is over by the time you are having, let's say, 1.5 hour or so. So it is just prandial control of hyperglycemia. Thank you.
Sharmaji, can I have a clarification?
Please, please, sir.
Yeah. See, repaglinide is such a short-acting molecule.
Yeah.
Now, do you think that it is compulsory? We need to use something like a metformin in a regular basis so that, especially for the case of, hepatic insulin resistance, and
In
which increase in insulin definitely with repaglinide can improve the hepatic output.
Yeah.
But it is short-lived. Do you think that definitely we should have metformin along with repaglinide, or you got any studies to say that as a monotherapy it's a good one?
Absolutely right, Dr. Vijay, because as you see the mechanism of action, you find it is short acting and it is mainly prandial. And once you combine it with metformin, which is taking care of insulin resistance and fasting hyperglycemia, and this drug is taking care of postprandial hyperglycemia. So most of the studies, when they combine it with metformin, the results are better. So last slide of mine was highlighting that if you are using a combination of Repa plus metformin, you are getting more patient into the range of HbA1c below 7. Thank you.
So I have
Sir,
one personal question for Dr. Tirthankar sir. Sir, very enlightening talk on glycologide sustained release combinations, and being a consultant diabetologist at a nephrology based hospital, I have been attending so many renal patients, and I have also used glycologide sustained release combinations for long, and even I have used up to 240 mg per day dosing. So I would like to know your opinion regarding this. That what is your experience in nephrology patients about glycologide XR? So please unmute yourself. Please unmute.
I think it's a very good question because, see, mild to moderate, when you are talking of the early renal failure, I think, of course, you have to individualize and titrate the dose of glycologide you are giving. As you said, there are, in spite of early renal impairment, you get very high blood sugar and you want to control them, and you can freely use the modern sulfonylureas. But of course, I would be slightly hesitant in using them in severely impaired renal failure. But yes, I think that I use it. But you have to be also alert because insulin clearance, you know better than me that insulin clearance is slowly gets decreased in renal impairment.
Can you hear me? Can you hear me?
And please mute yourself.
Okay.
The session is going on.
So
yes, sir,
basically, as the impairment increases, you can understand that there is an issue about hypoglycemia. So therefore, and glycologide has got a hepatic metabolism also. So you can use it, yes, but I want you to individualize the patient, and you are very correct that you have been using it even in full strength. I have done that also, but mostly in the mild to moderate. Once things increase, that I always go for maybe a teneligliptin and a repaglinide, as Dr. Saxena was saying. And then, of course, you may need insulin, prandial insulin, but whatever. You have to individualize the patient, and I have no hesitation in saying that there are vast number of patients in the early stages. You can use glycologide XR, and they do not cause as the previously expected hypoglycemia as you used to think. Thank you.
Tirthankar sir.
Yes.
Sir. See, of the two molecules, that is glipizide is one which is given safely in mild renal insufficiency apart from glycoside. My question is, which one do you prefer, glycoside or glipizide? That is number one. And then if you decide about giving glycoside, do you think that we can give that extended release, or you would like to go for immediate release tablet?
Again, very good thing you have pointed out. See, I'm slightly a glycoside man because the evidence, the body of evidence for glycoside, uh, or even for your glimepiride, I think the body of evidence for glycoside is huge. As I was telling you that even for hypoglycemia in my presentation. So I think number one. And second is because if you look at the mechanism of action, as I was saying, that is the reversibly attaching to the SUR1. Therefore, I think I would prefer glycoside. And if I have to prefer, I would act on extended release. My study was also on extended release. And I think slowly we are phasing out that. And I think that causes also less glycemic variability if you are using an extended release. And you may also, on the other side of caution, you may up titrate the dose very carefully, that you don't suddenly start with a very high dose and land up in a hypoglycemia. So yes, I'm slightly in favor of glycoside extra, and I use it very cautiously. And yes, more than glycoside. Thank you.
Thank you, sir.
Dr. Sachin, one question is regarding teneligliptin from you. That most of us has been using it in 20 mg OD dosing, but in many of the Chinese and Korean studies, they have used 40 mg dosing. So the question is regarding that what is your experience? Are you using it on 40 mg dosages, 20 mg BD, and do you find it the results are better than 20 mg OD or
Am I audible? Initially, there was a little bit gray area was there. Initially, we were not very clear, and even DCGI was at point was about to improve this 40 milligram dose. There was a proposal. So I had some patients in between who were on 40 milligram of teneligliptin, but that was a time when we did not had SGLT2 inhibitors. So at that point, in those patients who were not getting control somehow, somewhere, if they are convinced about it, we used to make it very clear to them. We used to give 40 milligram also. That was a limited experience, and that is anecdotal also because we could not publish it because of the approval part. But definitely it used to work better. And since this other molecules which has been launched in the armamentarium after SGLT2 inhibitors, I'm not finding the need of increasing the dose to 40 milligram. My patients are on 20 milligram of teneligliptin, and I think the response is very good, no doubt. As compared to all gliptins, they're all equal with respect to HbA1c robustness. So I'm not saying ki it is teneligliptin which is better, or Vilda is better, or Sita is better. They're all doing well. In my clinical practice, I prescribe all of them, and I'm happy with the response. But when it comes to 40 milligram,
I just
definitely in
share
Japan, they are giving it 40. But the chances of QT prolongation or those issues were always there on the back of mind, and they are more with the higher doses. Definitely, that is true. But now the data is coming, as I've told you, regarding the Ruby trial and the latest data from the European Society and all. So that is somehow, somewhere, is a kind of breath of fresh air. India might approve 40 milligram in future.
I'll share my short personal experience. As you said that.
Yes, sir.
Yeah.
Yes, sir, Sharma sir.
What I will suggest is that we should stick to the guidelines actually. So DCGI says that you should use only 20 milligram. We should be using 20 milligram. So there's no, you can say, debate whether it causes prolongation. As I know that Sachin is now again using only 20 milligram, and we all are using 20 milligram once a day.
Yes.
And then important point is sometimes we find that even vildagliptin is used once a day. That is again wrong because vildagliptin should be given twice a day. So all other gliptins can be given once a day, but sometimes we find that vildagliptin is also given once a day. And we know that if you are giving once a day, it is not really effective. So why you are wasting the money? So vildagliptin twice a day,
This brings in one more question, sir. Actually, now you got a sustained release medication of vildagliptin, 100 milligrams once a day. And then it is also cost effective nowadays, actually. In that situation, with a vast experience of 15 years or plus with vildagliptin, do you think that you prefer vildagliptin with teneligliptin? That's Sachin.
Definitely when it comes to cost and the response, I will definitely give weightage to trials and studies, no doubt. There is no question of comparing a Mercedes with a Maruti 800. Definitely, it's true. But now this Maruti 800 has also got some more airbags now, just because in the name of this Ruby trial and all those things. So it is looking safe. The car has been upgraded. I will say the molecule has been bestowed or decorated with more studies and evidence now. And what you can say that the kind of huge prescription which India had about the molecule is itself is talking about the safety. Now, if we have a validating data, there's no point. We can continue with both, and I'm writing all the molecules nowadays.
And one more important point is that for the last 5 years or so, we are using teneligliptin in large number of our patients. Yes. So that experience, if you look, you find that, and nobody has highlighted any major side effects or major QT prolongation, etc. And another important point is that there is always a rivalry between the companies. And at present, till date, we are not able to identify any side effect profile by all other multinationals or other companies regarding bad effect of teneligliptin, except QT prolongation when it is given in larger doses. That is the concept there.
Sir, I will share my personal experience regarding this, that what was, we were talking about the 40 mg dosages, and due to some economical and compliance issues, I have put my 5-6 patients on 20 mg BD dosing about 2-3 years back. And I was surprised that 2 of them landed in acute pancreatitis, and I couldn't find any other reason apart from gliptin.
See, gliptin and pancreatitis is something which has every time which has been discussed, studied, and since TECOS we have stopped talking about gliptins and pancreatitis. But my practice, what I do is I don't prescribe a gliptin when there is a history of pancreatitis. That is true. But when it comes to a drug causing pancreatitis, there can be n number of other reasons which could have led to that pancreatitis. Maybe hypertriglyceridemia, maybe other comorbidity, even drug reducing even the phenofibrate initially to start with. It is supposed to be preventing pancreatitis. It causes pancreatitis. That's true. But your experience for these 2 patients may be anecdotal. It may be a by chance data. It's very difficult to say and pinpoint it is because of teneligliptin.
No, not due to teneligliptin. I am just talking about the high dosage used. I used
high
40
dosage
mg
and
dosing in that.
pancreatitis. I don't think there is any data of high doses of teneligliptin and pancreatitis.
And diabetes per se increases the risk of pancreatitis.
Risk of pancreatitis.
So
yes.
You have to remember that point also. And now, as Dr. Sachin highlighted, we really don't bother about looking into pancreatic function before starting these DPP-4 inhibitors. But once they have a history of pancreatitis, we omit all these incretin-based therapy, whether it is DPP-4 or GLP-1 receptor agonist.
Sir, just for the benefit of the delegates and the practitioners, US FDA has given a caution for, in general, to blanket caution for DPP-4 inhibitors, taking into consideration saxagliptin, but here they have given blanket reservation about usage of, especially in high-risk population. In that situation, I think we need to also tell that whatever, especially teneligliptin, which has got no cardiovascular data, maybe we should be caution them not to use probably in high-risk patients and established cardiovascular disease. This is one thing I think we need to look into that. Not that it is going to be harmful. No, we are not telling, but for the sake of practical usage.
As I highlighted that we should stick to the guidelines and recommendations. So you are absolutely right. Once we have this type of patient, we should avoid using any, you can say, aspects which is making the things query. Okay, thank you.
And in fact, MSD people have gone to US FDA and asked for the TCOS trial, which is being found to be safe, non-inferior to placebo. They said that, but they said, I believe that it's the interest of the whole population we are doing it. That's what they told us.
Absolutely, you are right. So the whole group is blamed because
Yeah.
of one culprit. That was, and again, people argue that even sitagliptin was having some faults in the design of the study. So that
Yes.
was a outlier, and probably something happened during the rapid inclusion of the patients, and something missing there. That's why. And then subsequently, if you look into sexagliptin in other studies, there was no increase in heart failure with sexa also. But once you have a, you can say, बदनाम हो गए हैं तो थोड़ा बच के रहना पड़ता है.
And we cannot compare two studies, sir, because two molecules, when you compare the two studies, the whole inclusion criteria, exclusion criteria, the nature of the population that has been involved, entirely different, sir. We cannot look into that and compare this is superior, this is inferior. Very difficult to say.
This is just,
Something.
yeah, this is just like the metformin story. It was not approved in US till so many years.
Yeah, I know. Yes,
And we
yes.
were using it right and left.
Yeah.
And now the kind of number of patients we have, and we have used teneligliptin like anything. So our anecdotal experience is enormous. It is huge beyond proportions. So I'm not, still I will give weightage to publications. I will definitely see weightage to published and systematic data. But this also counts because in India, whenever a molecule goes up, it is written, there are millions of prescriptions which are generated. So that should also be taken into account.
But at the end, stick to that. Yeah.
Yes, definitely. Fully agree with sir. Fully agree with sir.
So I think we don't have any more questions, so we can sum up. So thank you, our eminent speakers, Dr. S.K. Sharma sir, Dr. Tirthankar Chaudhary sir, Dr. Vijay Kumar sir, and Dr. Sachin Chittawar sir. Thank you so much for joining this afternoon.
Thank you
Thanks
very
a
much.
lot. Thank you, Bansi sir.
Thank you, sir. Thank you. Thank you,
Thank
Sharma
you.
ji.
Thank you, Bansi
Thank you,
sir.
Bansi.
Thank you, Bansi sir.
Shankar, Ashutosh.
Thank you, sir. Thank you so
It was
much.
real good. Great.
Thank you.
Thank you.
Thank
God
you.
bless
Thank
you
you.
all.
Thank you, sir.
So the next
Thank you, Bansi
session is
sir.
also very interesting. Jimit, you can take and you can invite the reporter for the next session, and then we can start with the chairperson also.
Thank you so much, all the esteemed faculty from the previous session. We had wonderful discussions about pharmacotherapy. And now we are moving towards another interesting symposium, that is Lifestyle Modification Symposium. And there are wonderful talks going about lifestyle. So I'm glad to invite our rapporteur, Miss Hetvi Verma from Ahmedabad. She Over to you. Hello.
Hi, good afternoon, everyone. I hope everybody is charged up post the lunch session. Our lectures are usually like, I hope the energy is not dipping down because we are going to have a lifestyle symposium. We're going to talk about some exercise, so we need the energy back. So I would like to invite our chairpersons, Ms. Reema Rao ma'am and Ms. Rekha Gupta ma'am. Can we have the slides?
This, yes. Reema Rao, you can introduce the Cheryl. What happened? Reema Rao, you can introduce the Cheryl. Unmute yourself.
Yes. Okay. Good afternoon. And we are going to have a symposium of lifestyle modification. Our first speaker is Cheryl, and she's a master in role of diabetes nutrition and diabetes management. I am I have a pleasure of introducing her to you all. She is the founder of Nurture Health Solution and a health and well-being company. She is the course director of TIS Certified Diabetes Educator course. She is an RD, CD, CPT, and many other, and a registered dietitian. She is a visiting faculty and trainer at various educational institutions. She is author of a recently released book, Diet in Diabetes Simplified, Family Guide for Mumbai. It is a very well-known book now, and many people are taking advantage of it. She is a co-author of Purple Book and a chapter on diabetes in Clinical Dietetics Manual, and selected among 15 people in worlds for ISPAD and she features as an expert nutritionist on TV shows. And she's a speaker in several local, national, international conferences and has national and international publication to her credit. She has publication in national and international journals. Welcome, Cheryl, and we are looking forward to hearing from you. Thank you.
Thank you so much, Rekhaji, for the introduction. And thank you so much, Dr. Sabu, for the kind invitation, and to entire Diabetes India team. It's been a wonderful learning experience. It's a pleasure to have Reema Rao and Rekha Gupta chairing my session. And without any delay, I'm going to start my presentation. So my topic is role of diabetes-specific nutrition in diabetes management. I'm sure you all will agree with me that 20 years back it was very, very different in terms of diabetes nutrition. We used to have the diabetic diet, and there was a long list of foods that we used to tell people don't eat, and a very small list of what to eat. And today there's so much of confusion. People are every day getting some messages, or there's so much of infodemic also that is going on what kind of diets to follow, and people are often confused. And again, this is another thing in India, that you want to try some natural remedy because you think that medication is harmful, and therefore you go on having Karela juice, or you'll have methi seeds, and sometimes even stop your medication. And therefore the person with diabetes is completely confused as to what to do, and therefore there is zero compliance and follow-up. Like I was saying, there was a general diabetic diet. In fact, I'm sure Rekhaji and Reemaji will agree with me that 20 years back, we used to have these 1200, 1400, 1600, 1800 calorie ka cyclostyle sheets, which is just saying the number of, ek roti, ya do roti, ya 4 rotis. And list of no's was more than the list of allowed foods. And patients used to ask me, Madam, should we eat this before food or after food? There were no follow-ups, and it was a one-size-fits-all. So be it any medication that the patient was, because even that time, the medication, the number of the brands and the molecules were not so many, and therefore there were very limited choices, even in terms of insulin or even in terms of drugs. Now it's no longer a diabetic diet. The entire family, and I think this is the most important point that I would like to emphasize here, is that everybody in the family eats the same food, because there is nothing called a diabetic diet. It's just a healthy meal plan for people. It's not a one size fits all, because people are on different medications which require different and customized meal plans, whether it's insulin or drugs. It has to be flexible, because today you have people working different shifts, different kind of jobs. Their jobs require them to travel or different kind of demands. And therefore we have to be very understanding, because if somebody is diagnosed at a very early age, which we see commonly today, in the past, we used to see people only after the age of 55, 60 getting diabetes. Today we have 20-year-olds, even 10-year-olds who get diabetes, and they have to live with this condition lifelong. So it has to be very simple, easy to follow, and flexible. It has to be personalized. Very important is regional preferences. India is so diverse, with North eating so differently to South, East India eating so differently to West, and therefore we have to plan it as per the kind of meals that the person is eating at home, so that there is not too much of a strain in the house to cook separately for this person. The goals of meal planning in diabetes is emphasis on healthy eating patterns, address personal and cultural preferences. Very important, while we are saying that there is no diabetic diet, but focus should be on quantity and quality. So where we are talking about portion control, we however have to emphasize that the quality of nutrients that the person consumes has to be very good. We have to try and avoid lows and highs, HbA1c less than 7% as far as possible. In certain cases, you could be a little bit flexible. In certain people, you will have to be a little more stringent in terms of HbA1c targets. Ensure that we give optimum nutrition to improve health status, achieve and maintain body and weight goals. I think this has become a boon to all of us, especially the dietetics fraternity, because today we can show our patients that, okay, if you've eaten a poha, how is the blood glucose spike versus you've eaten a ragi porridge versus you've eaten a moong chilla. And therefore the compliance really improves, because here you get to see data in real time. And we also have today the time and range. So while we're talking about HbA1c, we're looking at SMBG records, but time and range is something which has changed the entire dynamic. So at least 70% of the time for people with type 1 and type 2 diabetes, they should be in range. For pregnancy, again, it's 70%, and for GDM, there is no defined goal. Now, this is another thing that I think in India we have to really look at, is we are thin fat people. So it is not about just BMI, it is about adiposity. So it's not obesity, but it's adiposity and insulin resistance. And therefore we have to look at The adiposity, we have to look at the waist circumference. Waist to height ratio is an important indicator today of adiposity. So while we are doing BMI, it's also important to check the waist to height ratio. Now we had the food pyramid, then we had a new food pyramid, and then we have a healthy eating plate, and we are back to our simple homemade thali. So it's very simple. Our traditional Indian meals, we always ate the thali, but it had to get popular when it was launched by Michelle Obama in 2012. And then we decided, yes, the food plate is very, very good. And it's only about distributing your food group. So basically half your plate should be vegetables, 1/4 of your plate your cereal, millets and starchy vegetable group, and 1/4 of your plate should be your protein group. Again, ADA emphasizes that saying instead of taking a 12-inch plate, you now opt for a 9-inch plate. So it's very easy to do portion control. So it's not about restrictions, it's about choosing wisely. So making wise choices and emphasizing on portion control with emphasis on nutrient quality is key. Now, if you look at the guidelines, before we had a clear demarcation that, okay, you have to have so much of carbohydrates, so much of protein, and so much of fat. However, now even the ADA says that there is no ideal dietary distribution. You decide what is best for your patient. And whatever you decide has to be done under strict medical supervision. So macronutrient distribution should be individualized while keeping total calorie and metabolic goals in mind. Now, we all know that we Indians love carbs. We are a carb country, which is very clearly shown in the START study that we eat around 65 to 70% of our calories coming from carbs and very little from our protein. And therefore, we're always in the postprandial hyperglycemic state, and high dietary carbohydrate causes higher PPG values. Now, I've just reviewed the different guidelines from different bodies, RSSDI, the ADA, and the ICMR. While ADA says that there is no specific carbohydrate intake, the ICMR and the RSSDI says at least 50 to 60% should be from carbs. In fact, ICMR says that at least a minimum of 130 grams per day coming from carbs. And I've just summarized the key takeaways. So reduce overall carbohydrate intake. So if you're taking around 65 to 70% calories coming from carbs, moderate it. So bring it down. So at least 50%. And whatever is convenient and possible, and gradually step it down. Nutrient dense carbohydrate sources. So we've also seen from the START study that we consume a lot of polished and refined foods. So instead of having that, choose unpolished, choose whole grains, choose nutrient dense carbohydrate sources. Up your fiber intake to 25 to 40 grams of fiber per day, which is 20 grams per 1,000 calories, and focus on consuming low glycemic index and low glycemic load foods. Now, when we're looking at so many different kinds of diets which are there, and people often come and ask us that should we go on a low carbohydrate diet? So for that, the ADA has very nicely laid down certain, guidelines that if you are pregnant or lactating, or if you have a risk for disordered eating, or if you have renal disease, then you are not an ideal candidate to be on a low carbohydrate diet. However, in patients with who are on SGLT2 inhibitors or on insulin or on certain drugs, the doctor will have to tweak the medication in case the person goes on a low carbohydrate diet. And this has to be done under strict medical supervision under the guidance of a qualified dietitian. RSSDI also speaks the same thing. It's that if anybody chooses to go on a low carbohydrate ketogenic diet, it has to be planned and executed following consultation with physician and nutritionist and for a short period. Lentil carbohydrates really work well, and we know that our pulses, especially all our whole pulses, you have soaked pulses, you have oats, barley, which are good sources of lentil carbs, which keeps the blood glucose levels maintained or sustained, as well as it prevents post-meal excursions, as well as it gives you a good feeling of satiety. Millets. Today, there's a lot of talk about millets, and millets are definitely good. And you do have low to moderate GI millets, which are really good, like Spaniard millet, foxtail millet. You have your pearl millet, you have your sama, you have kodo millet, you have jawar, and so much is there to explore. So while we're only looking at rice and wheat, we can also explore the different millets and use them in our menus and in our recipes to ensure that we get good glycemic control while also enjoying variety of foods. Now, when we come to protein, now the START study has also emphasized that we eat less protein, and there are so many surveys that have been conducted which have shown that we Indians are deficient in our protein intake, whether we are vegetarian or non-vegetarian. And therefore, we have to try and up our protein intake to at least 15 to 20% of calories. Key takeaways are focus on quality and quantity. So very important is also to look at the quality of protein that we're consuming And that we know that when we add protein to the diet, it not only adds satiety, but it also blunts the post-glycemic blood glucose response. And a cereal pulse combination, which is a very commonly consumed part of, whether we're having khichdi kadhi, or we're having dosa, or we're having idli, or we're having pongal, all of them, dal dhokli, or you're having dal pakwan, they are good cereal pulse combination. And when you combine cereal and pulse in the combination of 3:1, you get good quality protein. Now we come to fats. So while we are saying moderate carbs, up the protein, and where fat was considered a villain, today we say that fat in moderate amounts is good, and it in fact helps to achieve good glycemic control. But very important is choose good quality fat. So focus again on quality and quantity, Mediterranean style eating pattern, which is rich in MUFA and PUFA and low in SFA. So while we are trying to cut down the carbs and we want to meet the calorie requirements, we can increase the quantity of MUFA fats. And 6:3 ratio between 5:10. Use of vanaspati or trans fat should be avoided. Reheating and refined should be avoided completely. So Mediterranean kind of diet, which is again, if you see our vegetarian, or even if we are non-vegetarian, we don't eat non-veg every day, every meal. And it really fits in well. So more plant-based foods such as fruits and vegetables, whole seasonal fruits and vegetables, no fruit juices, whole grains, legumes, nuts, replacing butter with MUFA fats, using herbs and spices, I think, which we use plenty in our Indian cuisine, eating fish and poultry at least twice a week, enjoying meals with family and friends. And if we don't drink wine, we should not start drinking wine, but wine in moderation. And very important is to look at what we are consuming with wine, because that is usually the culprit, and getting plenty of exercise. Now, nuts again, people come and ask us, do nuts have cholesterol? You're telling us to eat nuts, whether it's peanuts or almonds or walnuts or pistachios. But today we know, and we have enough evidence to show that it is very, very important to improve your metabolic profile, so glycemic profile as well. And we have enough evidence to show us, and studies done in India itself, which have shown that yes, in actually adding nuts to the diet helps. And nuts are low carb, good fat sources, so it's extremely beneficial to health. Now, we have this interesting, study which was done by, basically a cohort study and meta-analysis, which was published in the Lancet by Sarah Settleman and group, which showed that very low carb diets and very high carb diets both were associated with increased mortality. And therefore, they saw that the lowest risk of mortality was observed at around 50 to 55%. However, they've detailed out again that, having more plant-based sources, more plant-derived protein and fat intake is in fact more better for our health as well as to improve glycemic control. So in simple, what should we try and achieve? So the plate method works well. So instead of taking a 12-inch plate, you take a 9-inch plate, make half your plate vegetables. And vegetables is non-starchy vegetables. Again, in our country, people have potatoes and sweet potato and arbi and suran, and they think it's a vegetable. That comes in your cereal, millet, and starch group. So that will be the 1/4 of your plate and 1/4 of your plate protein. So by just doing this, you actually are consuming, moderate or low GI foods. You're going to ensure that you're eating all the food groups in the right amounts and achieve good glycemic control while focusing on protein and fiber. So therefore, again, as I said, it has to be customized. You have to look at any kind of comorbid conditions. With diabetes, you may have somebody with dyslipidemia, hypertension, renal disease, etc. So again, it has to be customized accordingly. What is the health goal? What is the age of the person? The body composition? I think today, very importantly, is economic status. While it may look very fancy to give designer meal plans with, exotic vegetables and grains and stuff, we have to look at what is the pocket of the person as well. Can he afford? How many people at home? And who's cooking? I think all these are very, very important, because we have to ensure that this plan is something that can be sustained for a long period of time, and it should not have any kind of an expiry date. Again, individuals with pre-diabetes, and we know that we have large number of people with pre-diabetes in our country. And we have also had this, the direct trial, which has shown us that if initiated early, and if you do a calorie restriction within the first few years of diagnosis of diabetes, you can actually bring diabetes into remission. And therefore, there is a role of meal replacers. And you do have a lot of meal replacers which are available in the market. And under the supervision of a medical professional and a qualified dietitian, a person can be initiated on a meal replacer or on a calorie restricted diet, but again ensuring that the person is getting adequate nutrition. So nutrient density while doing calorie restriction is very, very key, and with it comes your activity. Now, this is a very interesting study, which is actually done by a very good friend of mine, Dr. Alpana Shukla, in which she's shown that just changing the order in which you consume the food. So one is how you fill your plate and then how you start eating your meal. So when you start your meal with protein and fiber, it actually helps you get better satiety, and it also helps to improve your post-glycemic blood glucose response. So these are simple tips that we can give our patients, which can actually improve compliance. And our patients can go back home smiling and follow what we are advising. So start your meal with a vegetable and a protein. So if there's some salad or there's a vegetable or protein like curd, dal, or chicken or fish or egg, start with that and then follow it up with your carb sources. This is another very interesting study which actually showed that a meal with low glycemic index has a lower postprandial glycemic response during the first. So it actually impacts your first meal, but it also impacts your second meal. So if you add something which is a low GI, low GL food for breakfast, it will not only keep your post-breakfast blood glucose under control, but it will also impact your post-lunch meal glucose. And these are very interesting things which you can incorporate in our patient's diet very easily. Often asked question is alcohol. How much should we consume? Can we consume? So again, the guidelines are 1 drink per day for women and 2 drinks per day for men. So this is what the guidelines suggest. Again, very important is to look at our medication, because otherwise it can cause hypoglycemia. Ensure that we're eating something or advising the person to eat and eat healthy snacks. My last slide on artificial sweeteners. Again, this is an often asked question that what about artificial sweeteners? Are they harmful? So if you look at the ADIs, and we really do not consume that much also. So if you see within the ADI limit, most safe artificial sweeteners are your sucralose and stevia, whereas saccharine is not recommended for pregnant women and children. Aspartame is not recommended for children, pregnant women, people with hyperphenylalaninemia and phenylketonuria. Asulfane potassium, again, use it with caution in patients on a potassium restricted diet or having sulfur antibiotic based allergy. So to summarize, sucralose and stevia is perfectly fine to consume within your limited within the ADI, and honestly, we do not reach it. If you look at the kind of body weight and the amount that we consume, we do not actually exceed our ADI. So to conclude, it has to be supervised, very important, under supervision of a qualified dietitian, because it's definitely not a one size fits all. It has to be tailor-made, looking into account what is the person's lifestyle, his body composition, his medication, etc. It has to be simple, it has to be sustainable and affordable. So choose foods higher in protein, healthy fats, fiber, moderate carbs, low in glycemic index and glycemic load. And honestly, our traditional Indian diets with slight modifications can become diabetes-friendly meals. So thank you so much for your patient hearing. All what I've spoken is in my book, Diet and Diabetes Simplified. Thank you.
That was wonderful. Wonderful presentation, Cheryl.
Thank you, Rima.
As always. I think you need to go, so we can finish your questions here. So one, the timing of your talk is the mango season. So what do you say about that? And it's the most controversial thing, for diabetics.
So again, if you look at the mango, I think this is such an interesting question. And often in the past, I've told people not to eat mango. So all my people with diabetes were strictly said no mango. So it was in your list of no's. But we know that people will go at chupke say they will eat, and they come back with very high blood glucose levels. So I think today, with so much of evidence which is there, if you look at the mango, depending on the variety, because we have so many varieties of mango. Yes. So the GI is between 51 to 60 and the GL is between a 9 and 11. So again, it comes in your low moderate range. So mango, again, we tell them that you check your glucose levels. If they are controlled, you should know when to eat it. Always eat fruit with nuts and know how much to eat. So we tell them the size of fruit to eat, when to eat, and what should be your blood glucose control. Then we have people who enjoy mango, and our children love it, Rimaji, because, we get a lot of type 1 kids and they love mangoes. The moment you tell them eat a mango, and I tell them you eat it in the evening and go and play. So go exercise, and they're very motivated to go and play. And then they come back in the evening after their play with very, very normal blood glucose levels with a big smile on their face. And that gives us a lot of gratification and satisfaction.
Yes, true. One more thing, I, saw your slide on millets. And, nowadays, a lot of people, just feel that taking the millets, because they have been rediscovered, right?
True.
And so they feel that, just swap it with wheat or rice and it's fine. And then they end up with hypoglycemia and things like that. So what do you have to say for that?
Again, millets is not, I mean, it's good that we actually encourage them, because millets are not fluid, guzzlers. So we tell them that, okay, you must use millets, and millets are great because they have a lot of micronutrients as well. Some of them have got iron, some have got all the essential fiber, etc. However, they have to know that they still have to consume it in that amount. So they will have a chapati, which is so small, or a fulka, and they'll have a bhakri, which is so big, which is actually 3 times the carbs, because they feel that millets are carb free. So that is something that we have to educate our patients on, that they are still having carbs. So whether you have millets, even oats, they think oats means zero carbs, or dals have no carbs. So I think these are some of the misconceptions which are there with our patients. So we try and clarify it. But again, and ragi, ragi, everybody thinks because it's brown, it's supposed to be the most healthy. We have this fixation about brown, that whether it's brown jaggery, brown sugar, brown honey, anything brown is supposed to be diabetes friendly. But in fact, ragi has a very high GI. The GI of ragi is 84. So we've seen that even when people do the CGM, we see a spike in glucose level, and they'll have that malted ragi, which actually spikes the glucose pretty high. So then we have to actually clarify them, and they're very surprised. Oh my God, I didn't know, because sometimes they will just have ragi porridge as a mid-meal snack to keep the diabetes under control. And then we see pre-lunch sugars are 300 and 350. That's why CGMS has made a world of good for us. I mean, as I'm sure all the dietitians here will agree with us, that it's amazing, because here we can actually show patients that, okay, this is what you've eaten and this is how it has impacted your glucose. So we get better compliance today.
Okay, thank you so
Thank
much.
you so much.
Thank you so much, Sharif.
So can we have the next speaker slide, please? Our next speaker actually doesn't need any introduction. She's Dr. Kavita Gupta, director, nutritionist, certified diabetes educator, insulin pump trainer at Sunil Diabetes Care and Research Center, Nagpur. She's a PhD, MSc, and CDE, presented research papers at international and national conferences, honorary secretary, Indian Dietetic Association, Nagpur chapter, joint secretary, Association of Diabetes Educator, executive committee member of Nutrition Society of India, Nagpur chapter, awarded the Best Indian Diabetes Educator Award 2019-20 by Diabetes Awareness and You, awarded the Dainik Bhaskar Women Award 2018 social category, organized many CNEs, diabetes education programs and diet exhibitions, and she's been active since the last 22 years. Has special interest in type 1 diabetes, CDM, obesity, insulin pump, CGMS, and diabetes educator. Over to you, Kavita.
Thank you. So thank you so much, Reema Rao and Rekha Gupta. Thank you so much. And it's always a pleasure to be with everyone. And just give me, yeah, I'll just share. And I think now, is it visible?
Yes. Yes.
Yes, visible.
Yes. Yes.
You could put it on the slideshow, Kavita.
Yes, right away. So again, it's a warm, it's in fact a pleasure to be here at Diabetes at the 11th World Congress of Diabetes India. And at the outset, I would like to thank and congratulate the entire team of Diabetes India. More so, I would like to thank Dr. S.R. Arvind sir and Dr. Banshi Sabu sir for having me here at this prestigious platform. Thank you so much. And I would also like to thank the organizers for giving me such an interesting topic. It made me learn so many things, when I was, when we always keep on talking about carbs and proteins and fats, but this was such a complex thing. What I would like to take you through the journey from farm to fork. I think we mustn't have ever imagined what the journey would be of a nutrient. You know, we hardly just eat, you know, quickly whatever right it is in front of you, and we quickly eat and gulp, and that's it is done. But have we ever thought what is the complexities of the food it has to go from farm to the plate? Yes, believe me, this is the whole lot of journey what a food has to go. And there are variety of things which happens, you know, that's not only food production, there's growing, harvesting, storage, packaging of food, and the different logistics which has to go while, you know, when the food is going to be distributed till it reaches to the people. And then finally, what about the waste products, and then again, you know, recycling for the food production. So the entire food gets exposed to high levels of heat, light, oxygen, and due to that it may lose lot of nutrients in that whole process. So this is the whole, I would be really taking you through the different processes what a food goes through. So first, like when the food is being grown, it's been harvested, like whether it's the crop or the livestock or the milking or the fishing, the different processes. So like they can be cutting, cleaning, packaging, miling, pasteurization. We will be talking a bit, you know, about all these. And then finally, what about the packaging and the storage and the refrigeration? So these are the different procedures what a food undergoes, and we hardly have ever given a thought to these procedures. So let me take you through it one by one. What would be the effects of the different food processes? Like maybe we start first with the fertilizers. So the increased use of the nitrogen fertilizers may reduce vitamin C in most of the vegetables, fruits, or the crops. Miling, we know that miling may cause a lot of loss in the minerals, and we all know that the fiber, the husk in the wheat and in the rice, it contains a lot of dietary fiber. It contains B group vitamins and phytochemicals. And the conversion of whole wheat to flour, you know, when we from the whole wheat to maida or the atta, it results in a loss of around 16 to 80% of loss of micronutrients. So that is a big amount of loss. And when the food goes for blanching, in few of the foods we go for blanching of food. So it is blanching is like when the food is canned or frozen, it is usually heated very quickly with steam or water. And due to this process, some water soluble vitamins, it's mostly the vitamin C and B complex, which are very very versatile. I mean to say, they're very sensitive, you know, that is why they are destroyed while in most of the processes. And this is one of the studies which has also shown that the blanching, for example, results in leaching of losses of vitamins and minerals, and also the miling and extrusion also causes in removal of minerals during processing. And this is the different vitamins and mineral losses we can see when the food is being frozen or in drying or cooking and drying. A big amount of vitamins are being lost when the food undergoes through all these processes. What happens when we are going to can the food? And now we see that a lot of canned foods are available on the shelf. So here we see that the food is heated inside the can to kill many dangerous microorganisms, and to increase the shelf life. The severe heat treatment may affect the taste and the texture, and also the soluble vitamins are lost when it undergoes heating. when we see a lot of freezing foods, and I think most common of the frozen foods is the green peas and the corns, which are being used left and right in our kitchen. Usually the freezing do not cause any nutrient losses, but most of the nutrient losses are caused when the food is thawed. So thawing causes most of the losses of the nutrient losses. Then it is the pasteurization, which involves liquid of heating of liquid foods like milk and fruit juices. And let me tell you, in case of pasteurized fruit juices, there's some amount of vitamin C which can be lost. Then another method is the high pressure processing. And this is again an alternative preservation method which subjects food to elevated pressures. But as heat is not required here, the process impacts less on the vitamin content, flavor, and the color. Then nowadays we see a lot of dehydrated foods as well on the shelf. So drying out foods, it can be whatever we usually use dry kasturi methi as dried foods in our kitchen, or it can be other fruits and vegetables also. So these drying actually reduces the amount of vitamin C, but it can also concentrate other nutrients, particularly fiber. And fiber is not lost while when you are drying a food. And we also see a lot of food which is while the foods, if they are dehydrated and if we reconstitute and cook them with water, further nutrients are leached out in the food and lost in the cooking water. So in the way, we should not throw away the water in which we are cooking the food. So, and these are the different vitamins. Usually, the most unstable vitamins is, we have seen, the vitamin C and the folate, which is being lost when the food undergoes a lot of processing. And the stable vitamins are K, D, and vitamin B as well. Now, this is a wonderful study. In fact, the NIN has gone through data which they have released in their NIN in 2018, and which has suggested that the foods we eat today are less nutritious than what we used to consume just 3 decades ago. In fact, they saw that there was a reduction in the nutrient value of the fruits and the vegetables, what they have compared in the NIN, what we all refer 2011 and now in 2018. So there was a lot of changes. And so that is why the we can actually see that there's a lot of reduction in the nutrients. And probably one of the reasons can be that the soil also in different states of the country are different. So probably the macronutrient content or the chemical content, I'm not going to much in detail of this, but just one message what I would like to give you, that the soil of different states are different, and probably that is what is affecting the nutrition value of a particular food. And that is the reason why people are opting for organic farming. And organic farming is well defined by USFDA as a system which avoids or largely excludes the use of synthetic inputs, and to a maximum extent feasible rely upon crop rotations, crop residues, animal manures, and off-farm organic waste. So it's going more towards organic farming, and which also includes organic meat and dairy products. So these are the different logos what we should actually see for if we want to look in for organic food. We want to choose an organic food. And moreover, when there is losses in a particular food, so that is why the Food Safety and the Standards Authority of India, FSSAI, FSSAI 2220, they have notified with certain norms of food fortification, maybe whether it is milk or rice or salt or oil and wheat flour, and they have set certain criteria of food fortification, and they have fixed up certain levels like iron has to be within the level of 1.4 to 1.7 in 100 grams of cereals. Vitamin C, usually vitamin C is lost in most of the fruit juices, so that is why it is always, you'll see that the fruit juices are always fortified with vitamin C. So fortification is a way, is an answer to most of the queries, what arises due to food processes. And HFSS says like the high fat, sugar and salt food shall be excluded from the fortified processed foods. Then another important aspect in this process is food labeling, which is very, very important. And the FSSAI has also laid guidelines about it, and it labels a lot of things, which probably I think we should make people understand. Not only we usually see only the date of expiry and manufacturing, but I think there is a lot more what we need to look into the food labeling. At least the nutritional information is what we need to look into. Then goes the packaging, and let me again tell you, this again is a very, very important aspect, because we have to protect the food from the physical, chemical and biological sources, and so that there is food security everywhere. And for that reason, we have HACCP, which is the hazard analysis and critical control points, which is recognized system for reducing the risk of safety hazards in foods, and it recognizes the biological, chemical and physical agents, and they have a lot of steps. In fact, they have a full team of audit, and these audits are being done at places to perform a hazard analysis. They determine critical control points. They have their own critical limits, and they monitor the system very closely, and they establish a record keeping procedures. So HACCP team is actually very, very important and playing a very important role in controlling the quality of the food when it reaches to the people. So these are again the different labels which you can actually look in for, because there are different things for the drinking water and certain processed foods. There's the ISI mark, FSSAI have their own logo, then agricultural products, and the green dots and the maroon dots, which we all know about. After the food has been packaged, labeled, and gone through all the audits, the time comes for the food distribution. And the Food and the Agriculture Organization considers food distribution as a very important aspect when the food is collected from the producers and it goes to the warehouses and different manufacturers, the groceries, the restaurants, the cafeterias, and also to each and every of our homes. Now the thing is important when we are going to cook the food. And let me tell you that cooking affects the nutrient content of the foods, and there are a number of studies which has shown how we can actually enhance the availability of the healthy nutrients through proper selection of the method of cooking. We all know that cooking has ample of benefits. Most of it is the most important is that it creates food, it makes the food palatable, and it also helps to destroy the bacteria and other harmful organisms that can contaminate. It breaks down the toxins, and it makes certain phytochemicals that are unavailable in some raw food, which makes it available. And the best example is tomatoes. The lycopene becomes more available when it is cooked. So this is very important. So that is why cooking is very, very important. Then comes the washing of vegetables and fruits, and I think pandemic has taught us beautifully and thoroughly that yes, we need to give more emphasis on washing of vegetables and fruits, and Center of Disease Control and Prevention has its own guidelines. And this is something what I have very, very important, that we do not have to wash our fruits and vegetables with soap, detergent, or any commercial produce wash. We do not should not use any bleach solution. Only simple water with some amount of salt is good enough to clean the fruits and the vegetables, keep fruits and vegetables separate from raw foods, and the other animal poultry foods. We need to refrigerate the fruits and the vegetables within 2 hours after you cut, peel, or cook them. So these are very important guidelines which we have been learning since last 1 year. So do not wash the food grains and vegetables repeatedly, as it will result in loss of nutrients. Then there are again different methods what we actually follow every day, maybe whether it is soaking or steaming or boiling. So soaking also helps to reduce some anti-nutritional factors like phytates and tannins. The moment if we soak the chola or the rajma, it helps to reduce the phytates, and it increases the nutrient availability of the protein and the minerals in the food. Steaming is supposed to be the best method, and especially if the people are looking, if patients are looking for weight loss. So this is something best method where we usually prescribe, because it also helps to preserve maximum nutrients. So steaming is something what we highly recommend. Boiling of food at 100 degrees centigrade is another important thing, which destroys the vitamin C and vitamin B, and it also helps. But however, it preserves the omega-3 fatty acids while boiling the food. What we can do is, like, you can retain the food in which the food has been boiled, and that food and that water can be used to make our gravies, soups, or even we can also knead our dough. And these are the root vegetables, usually, whether it is potatoes or it is sweet potatoes or even arbi. So we should always boil them with skins, so that it helps us to retain the nutrients of the food. Fermentation is another very important, because it helps to maintain the gut health and improve the immunity. So fermentation is, most of the foods like your dosa and idli or dokla, these are all fermented foods. But let me tell you, the glycemic index of these foods are very high. So that is why we also ask them to add more of fibers, whether it is tomatoes or onions, and add a lot of vegetables to these fermented foods. And fermentation of the milk into curd, so that is also helpful, because the lactose gets converted into lactic acid, and this is also helpful for the people who have lactose intolerance. And yogurt and fermented milks have a higher antioxidant activity than milk. So then again is the sauteing and stir frying, and this again is the most favorite of all of us, but because it needs a shorter time to cook, it needs less of oil, and it prevents loss of B vitamins. So whenever you have green leafy vegetables like broccoli or cabbage or green peppers, try to opt for sauteing. Um, then again, I would like to focus on the alterations of the low molecular weight carbohydrates. I mean to say, like, when the food are going for blanching, like, so same whether it's there's a considerable loss of low molecular weight carbohydrates, that's the monosaccharides and the disaccharides, and even of the micronutrients. So whenever the carrots or the peas are blanched, there is a considerable loss of these carbohydrates, and losses can be minimized if by using small amounts or by adding back the processed water. So to kindly use the water in which you are being boiling the food. After all this, another important aspect is the food wastage. And let me tell you, friends, the amount of the food wastage in 2016 is almost 92,650 crore. So I mean to say, that is a big number what we India has to pay for the food wastage. And again, this is a very important line, 50 kgs of food wasted per person per year in Indian homes. So it's not only about growing and cooking and processing, but it is also important that it's high time that we need to save our food for tomorrow. And this again is a nice paper which shows the impact of transportation, storage, and retail shelf conditions on lettuce quality and phytonutrient losses in the supply chain. And we can see that there is a decline in the ascorbic acid, chlorophyll, and carotenoids when the food is being transported, storage, till it reaches to the retailers. So then now I'm going to come to the how we can actually do, how can we actually increase the vitamins. Yes, you can go for sprouting of vegetables, which helps to increase the vitamin C and vitamin B and fiber as well. Cook in the iron utensils. You can also resistance starch is something very important, which it helps to lower the glycemic index of the foods when the foods which are cooked and cooled. So like say maybe the basa rice or the basi roti or something, they have resistant starches and which helps to blunt the blood glucose. So these are the tips what you can actually do in your day-to-day life. We need to eat fresh vegetables and keep them at a cold place. Keep fresh fruits and vegetables, dairy and juice products. Buy fresh foods in smaller quantities and use them fresh. Need not load your fridge with lot of stuff. Choose fresh, local, and seasonal fruits. This is very, very important. The more the food is travel, if the travel time of any food is more, the more the nutrient losses. Avoid peeling the foods like cucumbers, carrots, radish, and apples. Cut salads and fruits just before eating. Avoid food exposure to prevent vitamin losses. And similarly, do not, you have to cook for a short.
Kavita, can you wind up?
Yes. So finally, do not, one important thing is, again, I would like to add that the vegetable stock and the whey water, which we used for the protein, they are a good source of protein. So do not drain the water in the vegetable of the vegetables and the rice what you are cooked. So again, we need to promote kitchen gardening. And yes, I think there are enough nutrients what we may get enough nutrients if we follow the right method. And I would just quickly, just in 2 minutes, I would just like to focus on, this is an assignment which has been just given to me. And I would just like to focus on the PRIDE study, which is open label randomized controlled study to evaluate partial meal replacement program with Prohance D, which is targeting the glycemic levels and the weight control in type 2 diabetics. And here I would like to say that once there were two arms, which were one arm, they were given Prohance D plus, which was with the standard of care versus only standalone, the standard of care, and there were around 176 patients across 5 centers were given. And I would just like to focus on the results. They were actually they were seen for the glycemic control for the patients using Prohance D, and the standard of care were seen. And let me just come, and they were seen, they were checked for the weight, waist circumference, postprandial glucose, and the fasting glucose, and the lipid profile was measured. And also along with that, the quality of life was also measured. I would like to focus like there was significant more reduction was seen in the HbA1c, postprandial blood glucose, fasting glucose, weight, and the waist circumference in the test group as compared to the non-treatment group. And there was also difference in the significant between the groups in the favor of the test arm at week 6 for HbA1c. So this is these are the different arms which we can see that there was a reduction in A1c, in weight, and also the waist circumference in the arm where the Prohance D was given. So the PRIDE study pridely concludes that the partial meal replacement with Prohance D, it resulted in significant reduction of HbA1c, weight, and waist circumference when compared to standard of care in patients with type 2 diabetes, and was well tolerated. So that is why I think the take-home message also can be that the partial meal replacement can be considered as an useful tool on as well, along with pharmacotherapy and lifestyle modifications to achieve good glycemic control and weight reduction in type 2. Thank you. Thank you so much.
Thank you, Kavita. That was a nice talk from farm to plate. Should we ask the questions now or after the talk is after the
And
session
this
is
way,
over?
everybody will disappear. So the method is that we have to wait. Our
Okay.
international speaker is last. So we have to wait for the discussion at the end. So
At the end. Okay.
yeah.
Thank
There's
you,
a 25-minute
Kavita.
time for
Now we
discussion.
have the next speaker. Okay. Now we have the next speaker. Can I have the slide, please? Okay. Now we have Miss Meenakshi Bajaj, who will be talking on prebiotics and probiotics in the kitchen, which is a very good topic, and people are very confused about the prebiotics and probiotics, and they keep on hearing about this in their normal and day-to-day life. Meenakshi Bajaj is a registered dietitian with 27 years of experience in clinical and therapeutic nutrition. She is a PG, DND, MSc, CDE, RD, CCN, LLL, Onco, Renal, DM, and ESPN. She is a PhD, certified bariatric and critical care nutritionist, certified diabetic educator, and nutrigenomics consultant. LLL certified renal onco-obesity, DM, metabolic syndrome, sports nutrition, state rank holder, and best outgoing student. Presently, dietitian at Tamil Nadu Government Multi Super Speciality Hospital, Chennai. Former dietitian at Institute of Diabetology, Rajiv Gandhi Government General Hospital. Former executive committee member of NSI, National Executive Committee member of Indian Dietetic Association and Association of Diabetes Educator. Executive Committee member of Nutrition Society of India, Chennai chapter, former president Indian Dietetic Association Chennai chapter, resource person for several national and international conferences, former organized several national and international continuing nutrition education programs and workshops, author of a Diet Metrics Handbook of Food Exchange 2019, author several chapters in textbook, journals, and manuals related to nutrition and diabetes, contributed several nutrition and health related articles in national print media, received Best Nutritionist 2019 award from Fit Up Fest 2019, recipient of Sadhana Award to 2020 for contribution in the field of clinical and therapeutic nutrition, medical nutrition therapist, former His Excellence Tamil Nadu. Welcome, Meenakshi ji. We are all waiting to hear your talk.
Thank you so much, ma'am, for the warm welcome. Give me a moment. I'll just share the slides.
Oh, please.
Ma'am, are my slides visible?
Yes, ma'am.
And am I audible also?
Yes, ma'am.
At the outset, I'm really grateful to Diabetes India and its organizing committee team for the opportunity to be talking to you in the august presence of the august audience, as well as the respected chairperson, Rima Di, as well as Rekha ma'am. I'll be talking to you about prebiotics and probiotics with reference to diabetes mellitus, specifically found in the kitchen. And Dr. Kavita Gupta has taken us beautifully through this farm to fork. So in this present situation where we are, surrounded with insecticides, pesticides, and several, a lot of layman popping in a lot of antacids, we can expect nothing but gut dysbiosis. But is there something beyond that? Do we need to, challenge and take up with the help of our food ingredients available in the kitchen? Let's probe and see. So basically, when we talk of gut microbiota, it's very interesting to know that, in a human body, about 2.5 kgs is gut microbiome. And definitely there are several factors which influence the gut microbiota. One important factor is the mode of feeding, whether you're breastfed or you are formula fed. That itself gives us a little clue that diet also has an important role when it comes to gut dysbiosis. So let's probe to see whether type 2 DM causes gut dysbiosis or the gut dysbiosis actually causes type 2 DM. Because this question of the chicken or the egg first always confuses us. So same way, let us probe and see whether we can actually, get some data on type 2 DM causes gut dysbiosis or gut dysbiosis causes type 2 DM. So with the very first slide, I gave you a little hint saying that diet has an influence. Definitely diet has an influence when it comes to clean eating and junk eating. What do I mean by saying clean eating? When we are avoiding high fat, salt, sugar, specifically when it comes from the processed and the ultra processed foods, and we are replacing, plant-based diets with meat-based diets, we are moving towards gut dysbiosis. So what really happens with gut dysbiosis is we find that, there is actually bacterial translocation. There is an increase in the intestinal permeability. There's an increase in the pro-inflammatory cytokines, which in turn causes insulin resistance and raises the HbA1c. And there is low-grade inflammation throughout this process of gut dysbiosis, which when becomes chronic promotes type 2 DM due to insulin resistance. So we have some information to tell us that evidence has shown that altered gut microbiota comes before diabetes. But on the other hand, if you're having dysglycemia in a person with diabetes, in a PWD with dysglycemia, what really happens? The gram-negative bacteria in the GI tract of the DM patients increases insulin resistance. The blood glucose levels in the blood promotes inflammation, once again increases fat storage and insulin resistance, again becomes a cycle of events. So how do we sort it out? We can sort it out with the help of both pre and probiotics. What do? They help improve the leptin, reduce the ghrelin. Basically, how is this done? By restoring the gut barrier. That is, the leaky gut has been sorted out with the help of pre and probiotic. I wouldn't say 100%, but it is an attempt to restore the gut barrier, inhibits the alpha glucosidase activity, improves the intestinal gluconeogenesis, reduces the hepatic glucose output. And then you see the change in the metabolic variables like the fasting blood glucose improves, the postprandial improves, the HbA1c improves. There is an improvement in all the metabolic variables like total cholesterol, your HDL. That's a little controversy still whether HDL improves or reduces, but definitely the TGL definitely improves. So with this little background, we understand that pre and probiotic can play a role in improving insulin resistance. So what is a prebiotic? A food which contains, GOS or FOS or OF or chicory fiber or inulin, any one of them, or even the human milk which is consumed contains, human milk oligosaccharides, all these oligosaccharides. Even as Dr. Kavita mentioned, an oral nutrition supplement used in the PRIDE study, most of the glycemic friendly oral nutrition supplements contain fructooligosaccharides, which is again a prebiotic, which also could play an important role, as she mentioned, with waist circumference and the other parameters. So similarly, a prebiotic will not only help to improve glucose metabolism, also improve bowel irregularity, improve mineral absorption, as well as immune response. 80% of our immunity depends on our gut health. So there is a small snapshot of the various studies, though the duration of the study is very, very small and the number of subjects are few. They have found that when they use prebiotics in the form of FOS or resistant starch, they found improvement in the pro-inflammatory cytokines like the HSCRP, interleukin-6, interferon, fasting blood glucose improves, postprandial HbA1c, HOMA-IR. All these variables do improve with the intervention with prebiotics. But remember, they are short-term studies with few subjects. So then what about probiotics? One important thing with prebiotics is these prebiotics also help in synthesizing probiotics. So when a pre and a probiotic work in conjunction as a symbiotic, the host benefits maximum. So what does a probiotic do? As the term itself says, pro means for and biotic is life. Most importantly, when it is processed or heated, the microorganisms may get destroyed, and any food component or food ingredient which contains live microorganisms, probably the processing done at a particular temperature, which holds the microorganisms in their live state, only then they could be called as a probiotic. So live microorganisms, which when administered in adequate amounts, confer a health benefit on the host. But most importantly, probiotics contain a variety of strains, and these strains, each strain has a definite organ to work on and a definite action in which it produces a metabolic benefit. It also improves the immune system, and there is some, evidence to tell us that in non-alcoholic fatty liver disease, they can use probiotics of a specific strain, therapeutic dose, and a specific duration. It does help. But apart from that, obviously, it is used, very widely, especially in antibiotic-associated diarrheas, and importantly, even in those patients whose gut is dysbiosed and they are having constipation also, this really works. It helps in digestion of lactose, but there's not enough evidence to tell us that for lactose intolerant patients, it may be of benefit. But definitely it is used commonly in respiratory tract infections, gut infections, and vaginal tract infections. Apart from that, it helps in the synthesis of vitamin K, thiamine, folate, B12, and most importantly, how does it do its job? How does it prevent this leaky gut syndrome? What is this leaky gut syndrome? Usually the lipopolysaccharides from the membranes of the gram-negative bacteria of a gut which is unhealthy penetrate into the bloodstream. And what does it do? How does this really happen? The permeability of the intestinal mucosa is impaired, because of which the tiny spaces develop between the intestinal cells, and there is metabolic endotoxemia. In other words, these toxins walk into the bloodstream, cause a negative inflammatory response, leading to metabolic alterations. That's why you've seen that you'd have heard and read also that a lot of COVID-19 patients with gut dysbiosis, they are at risk of opportunistic infections and land up with COVID pneumonia. And obviously, the cascade of events walk in, increasing and worsening the morbidity and mortality of such patients. So we have some studies to tell us that, probiotics do help on the glucose parameters, lipid profile, blood pressure, in toto metabolic syndrome. All the metabolic variables of Reven syndrome or syndrome HEX can be worked upon with the intervention of probiotics. As I mentioned to you previously, different strains have a different role. Most commonly used two strains are the lactobacilli and the bifidobacterium. Say some work on HbA1c, some work on improvement of the urea, preventing the progression of diabetic nephropathy or nephropathy per se. Inhibition of DPP4 in type 1 children helps to improve oral health. But understand and see that each strain is a different one. As I scroll through these slides, you'll understand, because of paucity of time, I wouldn't be going through each slide in depth, but there are few strains which help to reduce the risk of GDM. Also, they have found that it helps to improve cholesterol, and the ProDIA study, which was done in Finland, was conducted in order to determine whether the consumption of probiotics during the first 6 months of life reduces the appearance of type 1 diabetes mellitus associated with autoantibodies in children who are genetically at risk for developing type 1. Their attention-grabbing results showed the ability of probiotics to reduce diabetes autoantibodies in children with genetic risk for type 1. This was a small study done, but we have some more information going beyond this slide. So obviously, they have used even probiotic in the form of a yogurt, which helped to improve the total cholesterol and LDL cholesterol. Also, there was another study, Finnish study, with 200 and odd subjects in the GDM, wherein they found that decreased incidence of GDM, reduced frequency of maternal waist circumference, as well as meaningful decrease of maternal fasting glucose concentration in the third trimester in diet bar probiotic group. But then there was a study published in 2019 in ADA, that was the findings from the spring double-blind RCT, which very, very clearly mentioned that probiotics did not prevent GDM in overweight or obese pregnant women. But in type 1 children, there was a role of probiotics with specific lactobacilli, rhamnosus, and bifidobacterium lactis, which said that there is a mention of preserving the number and proliferation of pancreatic B cells, and probiotics in type 1 adults did help to improve or ameliorate the conditions of metabolic syndrome, wherein high blood pressure and high TGL were improved, but not the HDL cholesterol. Moreover, further research is necessary to investigate the role and functionality of gut microbiota with reference to prevention and protection against type 1 DM. Apart from that, in type 2 DM, it has played a role, and there is some emerging data to tell us that probiotics appear to be an attractive emerging option for the management of type 2 as an adjuvant therapy. But a lot more studies are required. You need to know the therapeutic dose, you need to know the duration, you need to have larger sample size, you need to have longer research periods and rigorous experimental designs for us to confirm as as a recommendation on regular basis in type 2 DM patients. Though it is helpful in improving total cholesterol and triglycerides, not enough data on LDL and HDL cholesterol. We would say that it could be a non-pharmacological alternative for the treatment of type 2, but pending a lot more needs to be done in the future. And when it comes to the kitchen, these are the commonly consumed foods which contain FOS, inulin, ROS, SOS. All these are nothing but prebiotics, raffinose oligosaccharide, soy oligosaccharide, fructo oligosaccharide, xantho oligosaccharide, all of them put together, whether it's the oats, barley, wheat bran. But remember, oats, barley, wheat bran, and rye is a problem for those who are having celiac disease or gluten sensitivity. And similarly, those with IBD also may be troubled, if they are to consume whole grams, even if they are sprouted to some extent, maybe it may be of benefit. But otherwise, it's little difficult to, handle it in those patients who are already having IBD. I'm not talking of IBS, I'm talking of IBD, wherein the beans, legumes, and the soya may not be tolerated as much. Onion and garlic also are a super source of xantho oligosaccharides. Apples are great. Avocado, though it doesn't belong so much, though it's grown a little bit in the Andhra, but majorly we don't have our own homegrown avocado apart from a little bit in the Himalayas or in the Andhra Pradesh. Cow's milk is also an important source, and I already mentioned to you previously the human milk is a source, and there is some amount of data to tell us that you can use from 3 to 5 grams, but it may cause osmotic diarrhea, bloating, cramping, flatulence when it is consumed as a commercial prebiotic. And the fructo oligosaccharides as well as the inulin, if you see the food sources, they are common. They are basically garlic, onion, leeks, chicory root, which is usually found in filter coffee, the bananas. These are all sources of fructo oligosaccharides as well as inulin. These are nothing but prebiotics, which in turn help in the synthesis of probiotics. Apart from that, we have the galacto oligosaccharides, which are present in most of the whole grams like the peas, kidney beans, lima beans. But remember, as Cheryl already mentioned, that these whole bean varieties are also lentil carbs. So they also, postprandial peak is blunted. So it may be because of the prebiotic, maybe because of the soluble fiber present in it, or in combination, it helps in the synthesis of probiotic and also helps to improve glycemic control. And last but not the least is the probiotic sources for people with DM. Most often you will see food products which are available off the shelf are sugar based. A lot of sugar is present in a lot of probiotic drinks. You have probiotic yogurt, sweetened, unsweetened. So you need to be careful when you pick them. Apart from that, you also have ice creams which are available in the market with probiotics. So you need to keep all this in mind, that just because the term probiotic is available there, it may, if it is going to be a refined carbohydrate source or a source of trans fatty acid or saturated fatty acid, as I mentioned to you previously, when you're going to do junk eating or inclusion of saturated trans fat, you're going to worsen gut dysbiosis. So this probiotic, when chosen in that particular food ingredient, may not do good to you. But fermented oats, unsweetened yogurt are a super source of probiotics. Apart from that, we have kefir. Kefir is a fermented milk product found mainly in the origins of Caucasus mountains of Russia. You have kimchi, which is a staple in the Korean cuisine, which is basically, fermented vegetables. Then you also have kimchi prepared from spring onion, garlic, ginger. Remember that garlic and onion also contain some amount of prebiotics. So they do the role of synthesizing probiotics. Apart from that, you have tempeh, which is soy, traditional Javanese soy product. Then you have kombucha, which is also a tea mushroom. But this tea mushroom is usually served sweet. So if it is served sweet, how is it going to help your type 2 DM patient? Food for thought. Miso is also a traditional Japanese seasoning produced by fermenting soybeans. So basically, we get the information that soy, fermented vegetables, yogurt in specific, kefir are super source of probiotics. And I would say, you need to do mindful choice of probiotics. And when we do not have enough information on the therapeutic dose, on the duration of the probiotic, we need to look upon the pre and the probiotics which are available in our kitchen, but do mindful choices. At the outset, I would thank Dr. Banshi Sabu and his entire team for this wonderful opportunity, scientific piece also. Thank you so much. for the patient listening.
Thank you so much.
Thank you, Meenakshi.
Thank you.
For your excellent presentation. I think we'll need to take the questions at the end only. Can we have the slide for the next speaker, please? So it's my privilege to introduce the next speaker, Dr. Rucha Mehta, our very own dynamic endocrinologist from Ahmedabad. She is a MD, DM, FACP, chair of the Research Ethics Committee at Muljibai Patel Urological Hospital in Nadiyad, panel of expert group for diabetes and obesity of joint RSSDI and ESI clinical practice guidelines for management of diabetes in India. Past HOD Endocrine Department, Global Hospitals, Mumbai, Director of Research, Western University, California, clinical faculty at UCLA, Director of Diabetes Clinic, VA Hospital, San Antonio, Texas. Clinical and research interest areas are prediabetes, obesity, and metabolism. She did her MBBS at Sheikh GS Medical College and KM Hospital, Mumbai, and MD Internal Medicine at University of Illinois at Chicago. She also completed her MD in endocrinology and diabetology at the University of Texas Health Sciences Center in San Antonio, USA. Welcome, Rucha. Over to you.
She just messaged that she's logged out. She's connecting again.
Okay. Is she having some technical issue? Can we?
I'll check with her. I'll just check.
Yeah.
She's here. She's here.
She's here?
Yeah, yeah.
So welcome, Rucha. We just finished with your introduction.
Yes, I apologize first. I just got somehow disconnected at the right timing. And thank you, Rima. It's a pleasure. Rima is a dear friend, and I see all of my friends on the panel that is near and dear to our heart. So you can take out 30 seconds or 1 minute from my presentation. I'll go ahead and get started. And I've always kept it short because I always anticipate technical difficulties when we are all doing this virtually. So the topic given today to me is exercise prescription in primary care. And my disclaimer is I have no financial disclosures for this talk, but neither am I an exercise physiologist and neither am I a primary care physician. So that would be my biggest disclaimer. So you're wondering why an endocrinologist is here talking about this, because this is something that is near and dear to my heart, and Dr. Sabu knows that exercise is something we use or we cannot do without when we are managing patients with diabetes or endocrine disorders. So that's why on the very first slide I put, you cannot modify your genes, but you can definitely change your lifestyle, because this is who you are. You are a composite of everything, and a healthy lifestyle will go a long way. It's been a pleasure listening so far to all my friends, and I'm really grateful. I thought my topic was difficult, but when I heard Cheryl talk and then subsequently the other speakers, I feel that I got off on the easy end, So this goes as far back way, and Hippocrates, who is the father of medicine, he wrote that eating alone will not keep a man well. He must also take exercise. So I know that we are sort of in this Sunday afternoon siesta, so I'm going to try to keep it a little bit rapid fire and a little interesting so that I don't put you all to sleep. And hence I divided it into three parts: is why should we exercise, which exercise and how much. And since we all are guideline driven people, we should know what the guidelines say and how can we apply this as primary care physicians. So I'm going to wear my primary care physician's hat today and speak so. So let's keep this patient in our background. Here's a young patient, 45 years old. He has type 2 diabetes, long standing. He's sedentary. He already has history of CAD with a stent, dyslipidemia, uncontrolled diabetes, on insulin and multiple medications. Currently, his 2D echo is normal. He's obese, as you can see. And number one, he wants to lose weight. But what he really wants to know is, how is this going to help him? Is this going to change his diabetes? Is this going to prevent him from getting a secondary heart attack? Will this prevent his children from getting any of the diseases he has? So, what will you advise him? Start running 30 minutes daily? Should he start yoga and swimming? Should he go see his cardiologist first? Or maybe just go for a walk, check your blood sugars. And if you're walking fine, start running. So, really, these are all the conundrums, and we don't really have time in our busy practice to change their prescriptions as well as tell them what to eat, what to exercise. So, it becomes very difficult. So that's the reason why patients come to us, and if we are just as confused as they are, then how are we going to tell them what to do? So I'll simply try to break this down. Yes, exercise helps. The answer is yes. It's not simply because you feel good, you lose some weight. There are several metabolic effects. At the level of the fat cell, it reduces inflammation, reduces fat mass, improves insulin sensitivity. At the level of the skeletal muscle, it improves again glucose uptake, and this is an insulin independent pathway. At the level of the pancreas, you might have an improved beta cell mass. It has extra glycemic benefits. At the level of the circulation, you have several cardiac benefits. And of course, at the level of the liver, where it's going to improve insulin sensitivity, reduce your fatty liver. So you have several metabolic effects of exercise. If you can sustain this in the long run, there are also several chronic effects of exercise through several pathways, wherein your AMP kinase seems to be a very new interesting key molecule. You will in the long term activate your aerobic pathway through mitochondrial biogenesis. You may build muscle through fiber type transformation and improve your overall diabetes through increased GLUT4 protein expression. So these are several different things that will happen long term. You need to sustain this exercise long term. Of course, we know from several studies, and we cannot ignore the Look Ahead trial, wherein we showed that an intensive lifestyle intervention versus simple diabetes support and education helped in remission of diabetes partially or completely. And this was as simple as going to the gym, and they had a very good intensive lifestyle intervention. However, this may not be feasible for all of our diabetic patients, especially since they have limitations. Now let's look at something else. So these are 6,000 men, and as you can see, they range in BMI from less than 24 to more than 26. Now, if you're already lean, if you exercise, this is less than 500 calories per week, almost 2,000 calories per week, or more than 2,000 calories per week, does that decrease your chance of getting type 2 diabetes? And as you can see, it doesn't make that much of a difference if you're already lean. But the minute your BMI goes even above 24, if you start exercising intensively, you can lower your chance of developing type 2 diabetes, especially at BMI more than 26. So yes, you can prevent diabetes. Now we also know for each additional hour spent in the car, there's a 6% chance of getting obese. And for every additional kilometer you walk, there's a nearly 6% drop in obesity. And you could also be environment friendly by not using your car and trying to walk your short distances. So to answer another question, I thought this was a very interesting study from the New England Journal of Medicine. So we are still stuck at should we exercise? So I've shown you that yes, exercising can have several metabolic benefits. In the chronic long term, you can even prevent CAD, diabetes, as well as even prevent lifestyle complications, cancers, dementia, Alzheimer's, several other things. Now the patient that I just showed you, he wants to know if he really develops a healthy lifestyle, will that also reduce his chance of getting coronary artery disease? So here's a study looking at a huge cohort of patients, and that looked at genetic risk, adherence to a healthy lifestyle, and what happens to CAD. So there were 7,800 patients from the ERIC study, 21,000 patients in the Women's Genome Health study, another 22,000 from the Malmo Diet and Cancer study, and again 4,000 patients from the bioimage study. So clearly there's no doubt in any of our minds, this is a huge number of patients. And what were they trying to do? They were trying to see, is your DNA your destiny? Because a lot of us don't want to exercise because we think, you know, everybody in my family has diabetes, everybody has heart disease. How can I offset my risk, or can I truly change that risk of mine? In this particular study, what the investigators did is, at this huge cohort, they divided the patient based on underlying genetic mutations which have known risk for CAD into low risk, intermediate risk, or a high risk. Okay. Now, what they also then went on to do is that they then looked at lifestyle categories for these patients. Under the lifestyle categories, the patients were divided into unfavorable, intermediate, and favorable. And if you can believe it, in the favorable categories, they only looked at 4 of these things: smoking or not smoking, BMI more than 30, less than 30, are you exercising at least once per week, and if you're eating a healthy diet, which is more based on fruits, nuts, whole grains, dairy products, and vegetables. So you can see that this is all they looked at, very simple lifestyle categorization. And what they found is, and they then divided the patients into healthy lifestyle factors and gave them a lifestyle score if you had 3 or 4 healthy lifestyle factors, 2 or none. Now they looked at the 10-year coronary event rates in this large patient population according to lifestyle and genetic risk. So stay with me so far. You can see in the ERIC study, or in the ERIC cohort, if you had a low genetic risk, but you had a favorable lifestyle or an unfavorable lifestyle, even with a low genetic risk, you can have a high chance of getting disease, coronary artery disease. Whereas even with a high genetic risk score, if you had a healthy lifestyle, so the blue is the favorable lifestyle, you can see that you reduce your chance of getting a coronary artery event. And the same thing was seen in all the cohorts. Therefore, what they concluded is that if you, in spite of your unfavorable genetic background, having a high risk genetic factor, if you still exercise, if you had even 1 exercise bout per week, you had no smoking, you could lower your overall risk of getting a CAD by 45 to 47%, even in the low risk group, intermediate risk, and especially in the highest risk group who had a healthy lifestyle. So this is very good. This is good data. You can talk to your patients. 45% is a big number. And hence we can say, yes, your DNA is not your destiny, and you can change. You can know your future by doing this certain kind of genetic tests also. So I'm moving on to Susruta, who's not really an allopathic physician, but he really was at the core of all this. And he said, exercise should be taken every day. So how much exercise? But only to half of your capacity. So you need to find the minimal effective dose that works for you and that works for our patients. So we need to tell them something simple. It could be based on what they are doing. So really speaking, at every contact, you need to be asking them while they are sitting in your waiting room. They need to fill a recall form. That's what most of my patients do before they even start their video consultation. They send in what they've done for this past week. On an average, how much did you walk? Or generally, what do you eat for breakfast? What do you eat for lunch? What do you eat for dinner? So here is something looking at different modes of exercise and what happens to glucose control and beyond glucose control in type 2 diabetic patients, a meta-analysis. 27 studies were looked at, and they looked at different exercise protocols. So one was aerobic training, wherein you keep your heart rate low. They looked at resistance training, as well as they looked for combination of aerobic and resistance training. 1,000 type 2 diabetic patients were looked at, and the study durations were anywhere from 5 weeks to 104 weeks. What did they find? The HbA1c, there was a small beneficial reduction of the HbA1c. The combined training was superior to either one alone. Now, even beyond glycemic control, aerobic and combined effects had a clear, small, moderate effects on blood pressure. So aerobic exercise did very well for blood pressure. And with this, and really on cholesterol, we did not see that much of a pronounced effect. So we don't really know if cholesterol is affected so much by exercise. Now I want to show you some of our Indian data. So the Indian Diabetes Prevention Program done by Dr. Ramachandran's group also showed us, if you look at the bottom, so here is that the control group, lifestyle modification, metformin alone, and lifestyle modification plus metformin. And they looked at the incidence of diabetes at 3 years. Now, what we find is that in the lifestyle intervention group, the absolute risk reduction is 15.7, which is greater than metformin alone, which is 14.5%. And the relative risk reduction also is greater in the lifestyle intervention group versus metformin alone and is maintained in the lifestyle plus metformin. So certainly something as simple, and this was not as intensive as the Look Ahead or the US Diabetes Prevention Program. These were simple people from the south of India, part of our country, and they were simply asked to increase the amount they're walking, maybe walk home from work, try to, instead of catching a bus, and that's all they were doing in terms of increased activity. So this is really interesting, very encouraging. Now, here's another study looking at the effectiveness of a structured exercise program in the South Asian population. As I mentioned to you, there is effect not simply on glucose, but also beyond glucose on blood pressure, cholesterol, anthropometrics, balance and functional mobility, and quality and well-being of life. And aerobic exercise and resistance seem to do very, very well. Now we come from a country wherein we are really social people. We like to be in a group environment. Women still find it difficult to make it to the gym in the morning. So this is a study looking at South Asian women with type 2 diabetes in a culturally relevant exercise intervention. This was a randomized control 8-week pilot study looking at Bollywood dancing among South Asian women with type 2 diabetes. And 1-hour Bollywood dance classes were offered twice a week. And the exercise protocol consisted really of 10 minutes of warm up, 30 minutes of Bollywood exercise, 15 minutes of muscle resistance and weight training, and then 5 minutes cool down. And what do we find? Interestingly, there was a small reduction in HbA1c, not much weight loss, some change in weight in kilograms. And this was interesting because at least with such a short intervention, the patients reported an improved quality of life and well-being. There's certainly a change. So we have to make the exercise culturally appropriate and see what your patient likes to do. And last but not the least, of course, we come from the country of yoga. So the effects of yoga among adults with type 2 diabetes have been studied quite a bit. We found a meta-analysis that looks at 23 studies with about 2,500 patients, and compared with the control group, yoga participants had an improvement in their HbA1c, fasting blood sugar, and postprandial glucose. They also reported improvements in their lipid profile, blood pressure, BMI, waist-hip ratio, and in certain studies, cortisol levels as well. So this is good to know that exercise has several effects beyond just glucose lowering, and we need to really look at that. So now let's switch gears and see what the guidelines tell us. So of course, we have our RSSDI guideline and the JAPI guidelines, which still say that aerobic physical activity, such as moderate intensity, must be done at least for 30 minutes daily or at least 5 to 6 days a week. If you have vigorous intensity, then you can do it for a little bit shorter duration. And of course, you must also do the other 2 or 3 days per week, muscle strengthening or resistance weight training, curls, pressures, anti-gravity exercise. So this is all very, very important and also guides you on how you should be doing it. The ADA, the ACE guidelines, they also have several recommendations for exercise in patients with type 2 diabetes. As you can see over here, again, they mention the 150 minutes per week. So that's about 30 minutes, 5 days a week of moderate to vigorous exercise and resistance training similarly. Now, does this work for our patients? Do our patients even do this much? The WHO guidelines, as you know, in 2020, in December 2020, came out and stressed that physical activity for all is very important, especially for children and adolescents. They said you need to increase it up in the whole COVID era and the whole COVID background. There was this new guideline wherein it almost doubled the amount you need to exercise. So the 2020 WHO guidelines for children and adolescents, as well as for adults on physical activity and sedentary behavior are out there. The key highlights or what's new from 2010, it says that we need to get them all moving. And instead of the 75 to 150 minutes, it now recommends that you need to be exercising 150 to 300 minutes of moderate intensity workout. Children and adolescents, at least an average of 60 minutes per day, and muscle strengthening activities for all age groups. And if nothing, reducing sedentary behaviors is highly recommended. So I really like this guideline from the Canadian Academy of Sports and Exercise Medicine, and hence I thought I would spend a minute over here. So what they do is they actually define for you what is sedentary, what is light activity, what is moderate, vigorous, and high. So for example, sedentary activity, if the patient tells you that all he does is sits and reads, watches television, he's driving a car, that means he's never achieving any increase in his heart rate. This is less than 1.6 metabolic equivalents. And we need to really be able to tell him to do a little bit more. So we could ask him to move from sedentary up to light, which could be slow walking, for example, around the house, light work while standing, so cooking, washing dishes, or playing an instrument. So this is how we actually educate. This is how I educate my patients. Okay, how about after every meal you're done, you can walk around the dining table for 5 or 10 minutes, or get up when the doorbell rings and you can try to open the door each time. And that will be something they're doing every hour in India, especially. So if somebody's already doing this, you can tell them moderate. So 3 to 6 METs increase. They might notice a little increase in breathing and sweating, but still able to maintain a conversation. So they could start off with a brisk walk of 15 to 20 minutes. If they're doing well, but they have some arthritis, water aerobics, and finally, depending on where you are, resistance exercises could be included. And so on and so forth for your much, patients who are doing well, jogging or hiking, swimming, playing games. And then, of course, for your most competitive patients, we use training or competing in most competitive sports. So how do we apply this in primary care? We have all these icons. So I really try to say that I know that we look at Bollywood stars or cricketers and sports persona, and we need to use our examples saying they had nothing to train with, but look how far they've come. And really, I think it would be worthwhile if we could get all of these icons to motivate all our people, not just patients, to work well. So this is what I told you is ask about physical activity. These are some practical steps at every consultation. You need to write and help give them a prescription building towards accumulating initially 150 minutes per week. It would just take you 30 seconds to do this. Encourage your patients. There are many smart apps available. You can guide them to use a pedometer, smartphone, record their personal activity, either on paper, even a diary or a journaling, just do your own journal every day is fine, and send it to you. If you have staff who can send them encouraging messages, or if you have a software, that will really help. Refer as appropriate. If you think someone has some limitations, use physiotherapists. We now have experts known as physiologists, kinesiologists, and certified fitness instructors. Follow-up is the most important, and I would not say one monthly. Daily follow-up. We need weekly follow-up with patients to chart progress, set goals. Give them a weekly prescription, call them back, or somehow connect with them in a week's time and see what happens. Set goals, solve problems, identify and use social support. Key messages that exercise may prove to be as effective and you might reduce your medications. It has been shown to do that for diabetes, for stroke, for blood pressure. A 150-minute of moderate to vigorous physical activity can reduce your risk of coronary artery disease, as I've shown you, by 47 to 50% and many other chronic diseases. Even if they do 15 minutes per week, you have at least a 15% risk reduction. So some important key things, messages you can send your patients. In the last minute or two, I just put up these guidelines from Diabetes Care for special scenarios. So if you have patients with diabetes, hypertension, taking medications that can lower their sugar, you need to be careful and make sure your patient is aware that they check their blood glucose or blood pressure, pulse before or after their workouts. Sometimes cholesterol medications can cause muscle cramps. So it's important to be cognizant of this and ask your patient to hydrate well. Then other things such as a patient who has coronary artery disease. Now in this day and age, we ask them to wear a watch which has or a Fitbit that can monitor their heart rate. And we give them guidelines maybe that they need to stay below 60% of maximal heart rate. An easy guide is 180 or 220 minus age, and then kind of remove about 20 or 30 beats per minute from that. If they've had a recent myocardial infarction, we really tell them to restart exercise in a supervised cardiac rehab program. So all of these categories are here. Eye diseases, because they might fall, they're a risk for fall. So you want to be careful and make sure that they know what they're doing. Cataracts, patients with kidney disease, usually in the mild stages, beginning stages, all activities are okay, but vigorous exercises should be avoided. Overt nephropathy and ESRD, we have to be careful that they begin at low intensity and under guidelines. Now, what about if your patient has orthopedic limitations? Again, they should probably see the physiotherapist and get a very guided program for sure. So in conclusion, in individuals with or without type 2 diabetes, exercise will certainly improve the insulin-independent regulation of skeletal muscle glucose transport. So your insulin-dependent pathway is impaired. You can activate GLUT4 transporters, which is a predominant glucose transporter. AMP kinase seems to be the energy sensing enzyme that can have a lot of chronic translational effects. You need to be talking to your patients and customizing the exercise plan and come up with easy things that they can do to initially accumulate about 150 minutes of exercise and gradually, in a graded way, move up to about 20 minutes, 200 minutes, and 300 minutes. I think I'm in time, so I'll stop right here. Thank you very much.
Thank you very much, Rich. It was a great talk. Now can we have the slide for the next speaker? Our next speaker is Meena Chabra. The topic of talk is controversies and consensus of using oils in diabetes and CVD. She's a MBBS MD internal medicine. She's a senior visiting consultant and diabetologist at Sir Gangaram Hospital, New Delhi, chairman RSSDI, Delhi chapter 2021, chairman Innovative Physical Forum, part of the Committee on Joint Consensus Guidelines and Management of Diabetes by RSSDI and ESI 2019, Distinguished Service Award 2018 DMA, received Dr. B.D. Kumar Oration Award 2019 for excellence in the field of cardiology at Indian Medical Association 2019, RSSDI Award for Excellence in Diabetes Care 2019, Diabetes India Center declared among top 40 centers of India for creating awareness about diabetes through various initiatives during the year 2016. Welcome, Dr. Meena Chabra. We are looking forward for your talk.
Thank you so much. I'll just share the screen. Can you see my slides?
Please make them full screen.
Okay, I'm doing that.
Oh, okay, perfect.
Good afternoon, doctors. My topic is controversies to consensus in using oils in diabetes and cardiovascular disease. I'm so sorry, my slides are not moving. Give me 1 second. Yeah.
So, ma'am, just click on your screen once and then just
yeah, I'll do that. Yeah. So the debate is people with diabetes are at increased risk of cardiovascular disease, and the important role of dietary changes is established. But the problem is there is no precise prescription for dietary fatty acids, as there is no precise science to drive it. Low fat diets have been recommended without much attention to the quality of fat. The debate has been fueled by publications of large studies. I'll be talking about 2-3 of them, which report seemingly conflicting results. Now, we all know that fats give us, they are energy giving foods. They're not produced by the body, but our bodies can manufacture fat from nutrients. They are absorbed more slowly than carbs. Now, I would like to talk about the basics for about 1 or 2 minutes. So fats can be saturated, they can be unsaturated, and they can be trans fats. Now, unsaturated fats can be monounsaturated or polyunsaturated, depending on the number of double bonds. So if there's one double bond, then it's a monounsaturated fat. And if there's more than one double bond, then it is called polyunsaturated fat. And depending on the position of the double bond, there is omega-3 and omega-6 fatty acid among the polyunsaturated fatty acids. Now, saturated fatty acids are usually solid at room temperature, while the unsaturated are liquid at room temperature. The trans fats are partially hydrogenated, which converts to liquid to solid at room temperature. Now, sources, we all know saturated fats are solid, so butter, cream, ghee, cheese, meat. Now, there are 2 vegetable oils, which are coconut oil and palm oil, which are rich in saturated fats. So unsaturated fats, I just told you polyunsaturated fat and monounsaturated fat. PUFA is found in soybean oil, sunflower oil, corn oil, fish oils, and MUFA in olive oil, walnuts, and almonds. Trans fat, of course, in baked foods, and vanaspati ghee, which most of us know and don't use, cakes, cookies. Now, talking about PUFA, they are essential fatty acids, essential because our bodies cannot manufacture them and we need them from dietary sources. Now, linoleic acid is the omega-6 fatty acid, and alpha linolenic acid or ALA is the omega-3 fatty acid, which is converted to DHA and EPA, which is eicosapentaenoic acid and docosahexaenoic acid. So PUFA are classified either as omega-3 or omega-6, depending on whether the first double bond is located on the third or the sixth carbon from the terminal methyl group. Now, long-chain omega-3 fatty acids, which are EPA and DHA, they are plentiful in fish and shellfish. Obviously, Indians, even those who are non-vegetarians, take more of chicken and mutton, red meat, and less of fatty fish, and therefore we are deficient in these fatty acids. Now, short-chain omega-3 fatty acids are ALA. They are found in plant sources like flax seeds. Now, what are omega-9 fatty acids? These are monounsaturated fatty acids, and consuming foods rich in omega-9 fatty acids instead of other types may have beneficial health effects. Now, what are trans fats and why are they attractive? Because they have a long shelf life, they are stable during deep frying, and they definitely enhance the palatability of food. Now, what is the problem with trans fats? Trans fats increase the LDL cholesterol and they decrease the HDL cholesterol. Trans fats create inflammation, which may be linked to heart disease, stroke, diabetes. They contribute to insulin resistance, and obviously this will lead to an increase in the development of type 2 diabetes. Remember, friends, even a very small amount of trans fats can harm you tremendously. Even if you get 2% of your calories from trans fats, the risk of heart disease increases by 23%. So these are some of the foods, baked, fried, creamers, which contain trans fats. Now, this is an interesting slide. Fatty acid composition of commonly consumed oils and why is it important? So we have, my topic is to tell you that there is, what is the consensus? There has been controversy because there have been universal guideline decrease saturated fats. And what happened is that the industry then started making polyunsaturated fatty acids. They started marketing sunflower oil, other oils, and this industry rose because oils were expensive, and all over the world we were getting oils imported. And what happened? The fatty acid composition of these commonly consumed oils is important. So it's not what oil you consume, but it is the content of saturated fat, content of monounsaturated fat, content of polyunsaturated fat, and among the polyunsaturated fat, whether the oil has omega-6 or omega-3, and what is the ratio of omega-6 to omega-3. This is very important. So these are some of the commonly used oils. Now we'll be talking about each one of them in the particular studies. Now, all plant oils are zero cholesterol. Goes without saying, so this ad is useless. No plant oil has any cholesterol. So it's a myth. A few plant oils, of course, I'll tell you, coconut oil and palm oil are high in saturated fats, and for nutritional purposes, they should be considered as solid fats. And coconut oil is one of them, which is used tremendously in the southern part of the country. Now, what about fats and why do we need them? Of course, fats are important for absorption of fat-soluble vitamins, essential for blood clotting, muscle movement. Good fats are monounsaturated and polyunsaturated. Bad ones are trans fats. And saturated fats, doctors, at the end of the talk, I like to clarify, they fall in the middle. So eating modest amount of saturated fats is now possible after these studies that I will be discussing. Now, certain terms, what are unrefined oils? Cold pressed oils, you keep listening. Cold pressed oil is an oil which is mechanically extracted by a machine which applies pressure and not heat. This leaves the high flavor and nutrient content in the oil, making them a healthier choice. Examples are extra virgin olive oil, avocado oil. Few examples also are of refined oils are canola oil, rice bran oil, and sunflower oil. Here, heat is used. Now, olive oil is an integral part of the Mediterranean diet, but the main limitation is that olive oil does not have ideal omega-6 to omega-3 ratio. And second, the smoking point of olive oil is not very high, and it may not be very good for people in India who like their tadkas and they want oil to smoke so that they can use it for tadka. Now, this is a very interesting study I'll be discussing about sunflower oil. Now, in this study, this is from the Dr. Mohan's group. it was found, the patients were divided into 3 groups, and it was found that sunflower oil, which is polyunsaturated fatty acid rich, could aggravate the risk of metabolic syndrome, particularly in Asian Indian population. And why does this happen? Because Asian Indians, we habitually consume cereal and mainly refined grains with low intake of ALA. Use of traditional oils such as groundnut oil seems to be a better option than sunflower, as following things are ensured: optimal intake of MUFA, optimal intake of linoleic acid, and optimal ratio of the polyunsaturated fatty acid to the saturated fatty acid. Now, to reduce the LA-ALA ratio, that is the linoleic acid ALA ratio or the omega-6 omega-3 ratio, a single oil may not be adequate. And therefore, blended oils with lower LA-ALA ratio, we need more dietary sources of ALA, EPA, and DHA, along with whole grains, will actually help us to decrease the risk of insulin resistance and metabolic syndrome. Now, we need intervention studies with blended oils, and they are lacking. Now, again, does ghee have omega-3? See, ghee can be used in moderation because ghee is clarified butter. Ghee increases the LDL or the bad cholesterol because it contains saturated fats, but it also contains omega-3 fatty acids and unsaturated fats. The omega-3 are primarily linoleic acid and DHA. Now, if you take small or modest amounts of ghee, the LDL increases and also the HDL increases. So the ratio remains good. And you do need saturated fats also in your diet. So it's important that you can take ghee, but in moderation. Now, this is the content of various fats in ghee. Now, what about nuts and seeds? They contain mixture of fats, including MUFA, PUFA, and omega-3, and they are low in saturated fat. They're free of dietary cholesterol. So again, nuts and seeds are an important source of good fats. Now, what about butter? Traditional butter contains 63% saturated fat, 26% MUFA, and 4% PUFA. Now, what is Neutralite? It's margarine. Margarine is an alternative to traditional butter. It is cholesterol free, does not have hydrogenated trans fat, and it is rich in MUFA and PUFA. We also have peanut butter and almond butter. They're very good substitutes. They are high in monounsaturated fatty acids, and almond butter contains more MUFA than even peanut butter. But like my previous speaker said, we have to know the socioeconomic status of the patient before we write such expensive substitutes. Now, it's important that when saturated fats are replaced with PUFA in the diet, total cholesterol decreases, LDL concentration decreases. But like modest amount of ghee, like I just told you, may increase LDL, but also the good cholesterol, HDL. Now, it's a myth that we should use only one kind of oil. It's definitely important that we rotate the oils. We use 2 to 3 different oils because we need different MUFAs, different PUFAs. We also need some amount of saturated fat. So we can to give an example, one can use a seed oil like mustard oil. You can use a fruit oil like olive oil, and animal fat like ghee or maybe butter by rotation. Now, this is very important that the expert committee of WHO says that zero trans fats by 2023, or at least the calories from trans fats should be less than 1%. Total fat intake, very simple to understand, should be 30% of the total calorie intake, 20% from proteins, and 55% from carbs. So if your total fat intake is 30%, 10% less than 10%, so 7% should come from saturated fats, 13% should come from monounsaturated fatty acids, and 10% from polyunsaturated fatty acids. So it's very simple that you should remember this rule. Now, trans fats less than 1%, and National Institute of Nutrition recommends this same thing, the 20 to 30% of total calories from fats. Now, recent studies have shown that in addition to absolute amount of omega-6 and omega-3, the omega-6 omega-3 ratio plays an important role in increasing the development of obesity. So if we can increase the intake of EPA and DHA, you can actually decrease obesity epidemic. Now, so we have good fats, the bad fats, and the ugly fats. Now, the ugly fats are definitely the trans fats. Now, this is a very interesting trial called the REDUCE-IT. In this, icosapent ethyl was used. It was an interventional trial, and in this, reduction of cardiovascular events was seen when icosapent ethyl. I'd like to tell you that this is an ethyl ester of EPA. So we just told you that EPA is a fatty acid. It is an essential fatty acid, EPA, and icosapent ethyl. So it was used in the dose of 4 grams. The primary endpoint was cardiovascular death, MI, stroke, and coronary revascularization, and unstable angina. The secondary endpoints were cardiovascular death, MI, and stroke, where it was found that giving 4 grams per day significantly reduced cardiovascular events. So this is a very, very interesting trial. But we have another trial called the strength randomized controlled trial. In this trial, the statin treated patients with a very high cardiovascular risk, a high triglyceride and a low HDL, omega-3 fatty acids were added. But this was a negative trial, and when you compared it with corn oil, these findings did not support the use of omega-3 fatty acid formulation to reduce major adverse cardiovascular events in high cardiovascular group patients. Now, this is the pure study. It took the whole world by storm, the prospective urban-rural epidemiological study. This study was conducted in 21 countries across 5 continents, and a questionnaire was used. Underreporting of food intake definitely happens in a questionnaire because it's by recall. Now, what happened? It's important that we always have been told decrease saturated fat, but we have not instructed our patients decrease saturated fat and replace it with what? So probably in this study, high carb intake increased total mortality. It wasn't the high fat intake. It was found that the high fat intake is associated with a lower risk of total mortality and is not associated with the risk of MI or cardiovascular mortality. So the pure trial was exactly opposite what we have been taught for so many years. But is the pure trial to be taken on face value? No, we don't think so. Because if you replace saturated fats or fats, what do you replace it with? If you replace it with polyunsaturated fatty acids, you get better results. But what if you replace it with refined grain? What our poor people do? So this study was in low income, middle income, and high income group. Probably the fats were replaced by refined carbs. Therefore, there was increased mortality. So we must remember that it's important to know what you are replacing the fat with, right? So the big dilemma is replacement nutrient. Therefore, this study did not analyze what you had replaced the SFA with. And important is that you replace the SFA or the saturated fat with polyunsaturated fatty acids, right? So this is important. And now I'll skip this slide. So good 2020 dietary guidelines, what's good, what's bad. This is very important. Benefits of a plant-based diet, cut cholesterol and saturated fat, but you can get some saturated fat if the patient is diabetic or has a high risk of cardiovascular disease or already has established cardiovascular disease. Less than 7% of the total calories should come from saturated fat. You should not eat red and processed meat to protect against type 2 diabetes and heart disease. Now, again, this guideline does not warn against dairy products. And we remember that dairy products are also rich in saturated fat, right? Now, what about a low carb diet? There is increasing consensus now that low carb diet is good. But when you say low carb, what do you mean? Is it a high fat diet and what fats? So you have to replace the carbs, refined carbs, with good fats. So extra virgin olive oil, you can replace it with nuts, with oily fish. There should be moderate intake of cheese for the moderate saturated fat that you get, moderate intake of yogurt, and your diet should be low in sugar. That means foods which are included are high in fiber and low in GI and GL. So this is the diet. So it decreases insulin resistance because it is the excess fructose and refined carbs which are atherogenic. So to decrease systemic inflammation, we must take at least not too much of omega-3. So suboptimal omega-3, too much of omega-6 again will cause inflammation. And therefore, not only saturated fats should be decreased, MUFA should be increased. And the ratio of, in the PUFA, the ratio of omega-6 to omega-3 is very important. So from the pure trial, There is good evidence that reducing saturated fats but replacing them with polyunsaturated fats improves the LDL cholesterol, thereby reducing the risk of cardiovascular disease. There is no evidence that very high intake of saturated fats are beneficial, although from old times we have been listening to our grannies say that ghee is good. So ghee is good in moderation because it will increase both LDL and HDL. Dietary advice to reduce SFA alone is very simplistic. You don't have to tell the patient, just say decrease fats. You have to remember not just the quantity but also the quality of fat. So replacing the saturated fat with unsaturated fat or with complex carbohydrates like whole grains is beneficial. And you should not replace the fat with refined carbs like maida or trans fatty acids. This could be detrimental. So practical advice about SFA is better communicated in the context of food choices. Here comes the role of the diet educator or the nutritionist. So it's not the doctor just handing out a prescription saying decrease saturated fat, but it should be what food choices to make. So make food choices which have a very good proportion of all the fatty acids. Now, dietary patterns that encourage fruit and vegetables, which give you the good carbs, whole grains, again, complex carbs, pulses for the proteins, and nuts, which give you healthy fats, seeds also, which give you healthy fats, oily fish, which will again provide you healthy fat, discourage red and processed meat, high in cholesterol, high calorie fast foods, which are high in trans fats, sugary drinks, and refined carbohydrates are not recommended. So it's important. The take home message is that fats are important. We cannot get away with fats. You can't have a low fat diet and go down on the calories from fat to less than 20%. Fats should provide at least 25 to 30% of the daily energy intake. Then saturated fat should be less than 10%, and people with type 2 diabetes and cardiovascular disease, it should be about 7%. PUFA should be 10%, and PUFA includes both omega-6 and omega-3 fatty acids. Omega-3 or PUFA, ALA, should be about 0.5 to 2%. Adults should consume 250 milligram per day of the long-chain omega-3 fatty acid, that is EPA and DHA. Now, again, this trial, the reduced IT trial, has proved that taking 4 grams of EPA, it's not yet available in India, taking 4 grams, and now there's a study from Japan that even 2 grams of that has led to reduction in cardiovascular mortality. So if we could incorporate EPA and DHA in our diets, these are long-chain omega-3 fatty acids, there can be a reduction in the risk of cardiovascular disease. Now, trans fats should not exceed 1%. They should be less than 1%, because even if they are 2%, the risk of cardiovascular disease increases by 23%. And remainder of the energy should come from the monounsaturated fatty acids, which are definitely present in olive oil. Here, I'd like to reiterate that blending of oils is important. So my take-home message is no one oil has the right amount of all fatty acids. So you should be rotating oil. You need saturated fat. So you need a little amount of desi ghee or butter, but not too much. You need monounsaturated fatty acids, and you do need PUFA and omega-3 and omega-6 in the right ratio. Thank you.
Thank you, Dr. Meena.
Thank you so much.
Interesting insights on oils and fats. As we move on to the next speaker.
Oh.
We have Dr. Arvind Gupta from Jaipur. He is going to speak on immune dysfunction in diabetes and its reference to nutritional management of COVID and diabetes. He's a senior consultant and head Department of Diabetes, Obesity and Metabolic Disorders, Mahavir Jaipuria Rajasthan Hospital, Jaipur. He is a MD, FRCP, FRCP again, and FICP, FACE, FRSSDI, and he has various fellowships to his credit. Fellowship of American College of Endocrinology, Fellowship of Indian College of Physicians, Madras Science Foundation, Diabetes India, Fellowship of RSSDI, Fellowship of the Royal College of Physicians and Surgeons. He has various awards and orations to his credit. RSSDI oration, a gold medal, Hyderabad 2008. Professor Naresh Bu oration, Rajasthan RSSDI Ajmer 2017. KG Nair oration, Indian Society of Hypertension 2017, New Delhi. Outstanding Service Award by Diabetes India 2019. And Dr. C.D. Srinivas oration, KRSSDI Tumkur. Organizing Secretary of the 31st Annual Conference of RSSDI Jaipur, Chairman Scientific Committee Diabetic Foot Society of India, Jaipur, Program Chair Diabetes India 2019 at Jaipur, Member Research Committee National RSSDI Delhi. And he's a member and a visiting faculty of so many institutes. So it's my privilege to welcome Dr. Arvind Gupta.
Thank you, Dr. Rima. Shall I share my screen just now? Do you see my slides?
Not the slides. Yes, yes, we do.
And let me see. Yeah. Thank you, Dr. Rima and chairpersons for the kind introduction. And at the outset, I want to thank Bansi Bhai, Dr. S.R. Arvind, and all the scientific team to invite me and put me in a very, very important lifestyle modification symposium, which I thank Dr. Bansi Sabu from my heart, because I have listened just now at very talented nutritionist of the country, as well as my colleagues Rucha and Meena, regarding the lifestyle, diet, and so many perspectives. Let me talk to some of the little different immune dysfunction in diabetes, its clinical and nutritional perspective. That is very important, because we are living in COVID pandemic for last 1.5 years, and we are suffering a lot. Whole population is suffering a lot. And what we are listening regarding the immunity booster, immune boosters, and since morning and night, through media and papers and everywhere, and through the WhatsApp university. So let me talk to the scientific aspects of the immune dysfunction in diabetes. So that is my purpose today, to talk about this thing. This is my financial disclosures. What Thomas Edison told, doctor of the future will no longer treat the human frame with drugs, but rather will cure and prevent disease with nutrition. This was the Thomas Edison. So I will divide my talk by two major divisions. Once I'll be talking some of the basic scientific aspects of the immune dysfunctions. What are the immune dysfunctions in type 2 diabetes? Why type 2 diabetes patients are suffering with immune dysfunctions? And if there are more addition with the obesity, then the immunity will go down further. And then how to manage these immune dysfunctions? Can we manage? So we know about all these things very well, that once the patients of type 2 diabetes, we have to manage their glycemic control like anything, through nutrition, through exercise, which Rucha has told just now, stress management, sound sleep, and current COVID-19 situation. That is very, very important, my dear friends. What is this is the World Bank and FSSAI in 2016. What this scenario in the India ranks the high in global hidden hunger index. And what is more important, if you see here, the 70% of our population consume less than 50% of the daily recommended micronutrient. Dear friends, we are actually having a deficiency of micronutrients in our daily diet, which all Cheryl and everybody, Kavita, has told just now. And so micronutrient content of our food has decreased to a great extent. Kavita has just explored and given the beautiful aspects of why the micronutrient deficiency is there. And this is one of the NIN fact in 2017. What it says, in last 20 years, if you see the micronutrient content of the different foods, if you see the iron content of tomato, which was in 1989, it was 100%. It is in 2017, it reduced to 35%. Thiamine in banana was 100%, reduced to 20%. Magnesium in the rice, which reduced from 100% to 21%. Thiamine content in egg reduced from 100 to 60%. And apple, the iron content reduced from 100 to 40%. Dear friends, this is the state of affair what the Kavita has told just now, farm to the food, I mean the delivery. So this is how the micronutrient deficiency occurs in general to our population. Now there is an emerging need to change the focus from metabolic practice to the immunometabolic practice. And let us see what is how to deal with this immunometabolism. So there are different ways to deal the immunometabolism and how to boost it. The first and foremost important thing is we have to ensure the 100% recommended dietary allowance of all the micronutrients. That is the first thing. Then, while our nutrition colleagues just told, calorie restricted diet causes reduction in the micronutrient intake. So we must not do like this. We must ensure the micronutrient intake, even if we want to have the calorie restriction. So dear friends, we have to change from metabolic practice to immunometabolic practice. That means the calorie count and macronutrient balance is very important. But along with the macronutrient balance, it is imperative to ensure the micronutrient sufficiency in our diet. We know that micronutrient malnutrition is now going down with the infection. We know about the COVID situation for last 1.5 years, and immunity is going down like anything. So immunometabolism is the hallmark in the clinical practice, is the need of our. Dear friends, how the immune dysfunction occurs in diabetes. We know diabetes is a major cause of immune deficiency all over the world. And chronic augmented inflammatory immunity that increases the risk of whether micro and macrovascular complications in diabetes. Hyperglycemia per se increases the microbial virulence. That's why you see most of the COVID patients, the COVID diabetes patients are more serious than the non-diabetic patients. And that's why their adherent to microbial cells is increased. Hence, hyperglycemia is very dangerous. So dear friends, increased blood sugar levels increases the susceptibility to Staph aureus as surgical site. That may also be, and nowadays we are also may think of the hyperglycemia may be because of the mucormycosis, what we are seeing, the black fungus. So there are different metabolic abnormalities. We know about the advanced glycated end products. They increase with the diabetes duration, diabetes hyperglycemia, activation of protein kinase C, and through the increased flux through the polyol and hexokinase pathways, there is an increase in the microvascular complications. Through the increased production of superoxide dismutase and activation of different inflammatory pathways ultimately leads to alteration in host immune system, whether it is humoral, cellular, or adaptive. That's why you have more of the metabolic abnormalities, more immune dysfunction occurs in diabetes. So there are defects in the humoral innate immunity, that is very, very important, because all the functions of neutrophils in diabetes patients, they are migrated to inflammatory sites. All neutrophil release the lytic processes, increases the phagocytosis, production of reactive oxygen species, and ultimately leads to apoptosis of the infective material. So we know that these inflammatory cytokine, whether TNF alpha or IL-1 beta or IL-8, whether it is a basal state or after stimulation, increases the tissue injury and cell death, increases the susceptibility to invasive microorganisms. So we have the defect in the cellular innate immunity through the polymorph nuclear neutrophils in the type 2 diabetes, because of the low phagocytic capacity, decreases the chemiluminescence, decreases the adherence of PMN to nylon fiber columns, and that's why there is increase with the correction of hyperglycemia. So if you correct the hyperglycemia, you can ameliorate most of the functions of their neutrophils. So dear friends, you have the hyperglycemia, which stimulates the pro-inflammatory cytokines. You have the hyperinsulinemia, which promotes the DC activation and upregulation of scavenger receptors. And you have the changes in TREX. What is TREX? TREX enhances the T effector cell suppression, which subsequently prolongs the recovery and predisposes one to increase in the complications of diabetes. So if I can summarize the immune dysfunctions in diabetes, it is two types basically, either humoral one, or it is cellular one. So if you see the innate is the complement. It is through the complement, it is the humoral one. And you know what is the first line of defense? The first line of defense is innate. The immediately when we are bombarded with the infections or microorganisms or with viruses, our first innate immunity comes for the defense. But if the innate immunity is not sufficient or ineffective, then adaptive immunity comes, that is through the cellular immunity. So we have started with the humoral through the complements, through the cytokines, then cytokines without stimulation and cytokines after the stimulation. Then if not controlled, then the cellular through the nuclear neutrophils, monocytes, macrophages comes to rescue for fighting the infection or microorganisms or viruses. If it is not sufficient, then innate immunity, then the adaptive immunity comes. This is a second line of defense. And now we have a very strong second line of defense in our body through the immunoglobulins. And basically it is the T lymphocytes which come to rescue after the innate immunity. And you know what is the major difference between innate and adaptive immunity? Innate immunity doesn't have the memory, but adaptive immunity has a long memory. So if you have stimulated the adaptive immunity through the immunoglobulins, the memory remains for a longer period of time. Therefore, various factors are causing immune dysfunction. It is not a single factor which is responsible for reducing immunity in type 2 diabetes. First of all, it is the poor nutrition. We have already seen through the micronutrient deficiency and other nutritional deficiency, the immune function comes down. Then through the disease and disorders we have seen in type 2 diabetes, which is a pro-inflammatory disease. Metabolic stress can also lead to immune dysfunction reduction. Infection per se also reduces the immunity. And if patient is having obesity, further patients are going for the reduced immunity. And just a minute about the obesity, type 2 diabetes. Obesity is a chronic inflammatory, a low grade inflammation, and it is characteristics of immune deficiency in both the conditions. Hence, if a person is having type 2 diabetes with obesity, they are more prone for immune dysfunction. And how this dysfunction occurs, it is through the impaired neutrophil function and T cell response is reduced, increased T cell activation marker, and increased number of infections compared to metabolically healthy disease. So these patients are suffering from increased rate of infections, whether it is through the gamma delta cells, whether the T helper cells, whether it regulatory T cells, or whether the B cells. If you have the 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 obesity along with the type 2 diabetes, dear friends, adaptive immunity is not able to protect you from the attack of microorganisms or the viruses. This is how the immune deficiency occurs in type 2 diabetes. Now, the $1 million question: how to manage this immune deficiency or immune dysfunctions in type 2 diabetes? First and foremost, which is more important, that we have already seen the hyperglycemia. If you control the glycemia of the patient, I think that is the first line of management you have done. Then the second thing is the nutrition therapy, which beautifully has told just now my previous nutrition colleagues, whether it is Cheryl and Dr. Meenakshi Bajaj and Kavita, clearly told us about the nutrition therapy. Exercise, by Rucha clearly told us the exercise is very, very important, which increases the immunity and the physical activity. I think that is the most important part and parcel of type 2 diabetes management, not only for the control of sugar, but also for increases the immunity. Then is stress management. Dear friend, this is very important. This is a era of negativity. You always think of negative aspects these days. That's why the stress actually causes your loss of immunity or less of immunity. And then the last and not the least, it is the sound sleep. 6 2 hours of non-rapid eye movement or the rapid eye movement of 15 to 20 minutes is sufficient to induce the immunity or increases the immunity. If you don't have that sound sleep of NREM and REM, you will not be able to sustain the immunity in your day-to-day routine, and especially in type 2 diabetes. Blood sugar management, I need not to tell about all these things because it is already been told before by my previous speakers and all the conferences rotating. Nutrition, I'd also already been told by all the nutrition colleagues about that thing. The only thing I want to reiterate here is, if you have a balanced diet with micronutrients, that is more than sufficient. That is low glycemic index food. By I mean, there's some foods, you have choices of foods, you have limited consumption, which Meena has told just now about the fats, and increased consumption of fruits and vegetables. That is through under the supervision of a qualified dietitian. Then what are the different nutrients which supports the immunity? I now confine myself or focus myself on a different immunity boosters, which is very, very common these days. We hear by on the WhatsApp University. Proteins, antioxidants, especially the A, C, D, and E, glutamine, omega-3 fatty acids, beautifully told by Meena just now. Arginine, also being referred by Kavita. Minerals by iron, copper, and selenium. These are the special nutrients which can increase your immunity, and I'll give the scientific aspects of each and everything. Proteins, very well told by Cheryl in earlier presentation, and the only thing I want to tell you just now is protein metabolism plays an important role in formation of natural and acquired immunity against the infections. So we are already a protein deficient people in India. We are sarcopenic, most of the people. Dr. Anup Mishra's study has clearly told us that 70% people in India are the sarcopenic or protein deficient. Hence, the protein is the hallmark for increase in the immunity. And it is already there, not only for the improves the glucose response and glycosylated hemoglobin, but also improves the immunity. Role of milk protein already been told just now. I want to skip it. Then the arginine, which is referred by Kavita in her presentation. It is an essential nutrient for both innate and adaptive immunity. That is very important, dear friends. Arginine has to be tackled very well during this COVID infection period and also otherwise in type 2 diabetes patient. It actually serves a physiological substrate for the different enzymes. That's why hypoargininemia increases the risk of inflammation. So altered arginine metabolism in macrophages of adipose tissues that switch from M2 phenotype to F1 phenotype, which is more dangerous, overexpression of arginase, it increases the overt I nitric oxide synthase and increases the susceptibility to infection. So arginine is one of the important thing which is important as far as immunity dysfunction in diabetes is concerned. Then role of omega-3 fatty acids, I'll discuss little more because Meena has discussed very well about the omega-3 fatty acids, and it is already been different studies, she has already been quoted that in diabetes it helps like anything. We have done also our own work on omega-3 fatty acids, and it has found very useful in not only the controlling of diabetes, but also decreases the inflammatory markers like TNF alpha, IL-2, and CRP. So if you have a proper omega-3 supplementation or reducing the omega-6, omega-3 ratio in your diet, then you can reduce the TNF alpha inflammatory markers, IL-2, interleukin 2, and CRP markers. So this is one of the important nutritional aspects you can go even this COVID era. Then micronutrient supplementation reduces the infection. That is very, very important. And how they help? They increases the total lymphocytes and CD4, which is very important, the first line defense, and the ratio of CD4 to CD8 plus, which actually fighting with the microorganisms, and thereby decreases the common infections and severity of symptoms during the infections. Vitamin D, recent studies, this is all studies are there, which says that even deficiency of vitamin D can have their more risk of COVID. This is actually, and this is not our study, this is a study done in PGI by Dr. Ashur Rastogi and their colleagues, and they have just published their, the study on the vitamin D, which has a crucial role in COVID era these days. What the vitamin D does? It increases the insulin sensitivity, stimulates the pancreatic beta cell survival, modulates the cytokine and NF-kappa B. It controls the immunostimulatory IL-12 and immunosuppressive IL-10 production, ultimately prevents the excess synthesis of inflammatory cytokines. Hence, daily intake of 1000 international unit of vitamin D is essential with or without extra calcium. You want to give calcium for postmenopausal or the females which is having calcium deficiency, it's okay, but vitamin D 1000 units is actually it should be given, which actually reduces the serum hsCRP, plasma fibrogen, then increases the serum adipokines, which is very important, including adiponectin and RBP, which reduces the cellular secretion of the inflammatory cytokines of IL-6 and IL-1 beta. So low serum vitamin D in type 2 diabetes patients results in mycobacterial activity. This has been studied all over the world. So vitamin E, what is the role of vitamin E in type 2 diabetes patients? Which reduces the serum levels of again inflammatory cytokine interleukins, TNF alpha, PAI1, and CRP. And this is also published. All the studies are published, which says that combined supplementation of vitamin E, vitamin C in 13 elderly patients. This is one of the study with IGF resulted in decreased plasma plastic insulin, glucose, TNF alpha, and isoprostane level. So if you can combine judiciously, I am using the word judiciously, combining all the vitamins, that may reduce the chances of infection in the present era. Then magnesium. Magnesium is also an important part and parcel of your nutritional management. I need not to go into detail. Gut microbiota, beautifully told just by Dr. Meenakshi Bajaj. Exercise by already told about by Rucha very clearly. The only thing is it releases the inflammatory if you have a strengthen of skeletal muscles, releases the anti-inflammatory factor like IL-6, which is reduce TNF and increase IL-1 receptor antagonist, hence helps the patients to fight with the infections these days. So exercise is very important. Exercise in the form of whether it's a walking or the strengthen exercise, it is up to you what you can do in this era. Stress, I told you just now, we are actually having in this 1.5 years too much of stress and negative thoughts are there, which can result into decrease in the splanchnic blood flow, increase intestinal permeability, increase absorption of LPS from the gut, increase portal blood stream of LPS levels, stimulation of Kupffer cell and cytokine release. That's why negative emotions are directly related to immune dysregulation, production of pro-inflammatory cytokines and increased type 2 diabetes. I request all of you, please don't go with the negative emotions. And yoga, which is in a general term, but if you do again proper yoga, which is from our so many like Shushrut and Charak and all, our old ancestors, they were actually doing yoga, and this also enhances the immunity in our patients. It reduces the oxidative stress and blood pressure, betterment in mood, sleep, and quality of life. So yoga is also important if you want to increase your immunity. And in the last, I told you it is the sleep. And I told you there are different, we have already, because of lockdown and so many things, we have a sleep disturbance. People are not having a good sleep. The circadian rhythm disturbance is too much these days. And that's why there is activation of the immune system is there in our body because of the lack of the sleep. There is decrease in the B lymphocytes, helper T lymphocytes, and NK cells, NK activities, and several cytokines in type 2 diabetes. Hence, the sleep is the most important, one of the important thing. Please have a good sleep, at least 6 hours per day, with NREM and REM sleep, that is rapid eye movement and non-rapid eye movement sleep. So we have to manage the patients in the current situation, which is very important. Please control your type 2 diabetes patients. Glycemic control is the foremost things. With your nutritional colleagues, they give good balanced diet with micronutrients, which actually helps and increases the immunity. Demonstrates on instructions on indoor exercises are very important. Evaluation of your anxiety levels is again very important. And I think there must be a research on enhancement of immunity in type 2 diabetes with holistic approach. So my key messages to all of you, my dear colleagues: strong interconnection between immune dysfunction and type 2 diabetes has already been seen, and it is vice versa. Control your sugar, increase the immunity. Obesity further complicates this immune dysfunction in diabetes. Recent studies have highlighted the gut microbiota link in pathogenesis of diabetes and immune dysfunctions already been dealt. Improved glucose control is the key for enhancing immunity. Please reduce, the glycemic control should be optimum. Nutritional therapy is an integral part. Please mind it. Micronutrient deficiency, along with judicious combination of different types of vitamin E, vitamin D, and vitamin C, will help your type 2 diabetes patients to fight with these infections and other microbial infections. Adjunct therapies like exercise, stress management, and the sound sleep can assist in managing hyperglycemia and immune dysfunction. Thank you very much, my colleagues, for giving me this opportunity along with your lifestyle symposium. Thank you
so
very
much,
much,
sir.
and I'm here for the question and answer.
Thank you so much, sir. It was a very nice deliberation. Now, can we have the slide for the next speaker, please? Now, it's my great pleasure to uh, invite Dr. Irina Vlesenko. I hope I'm pronouncing your name right. If I'm not, please correct me. Uh, she will be talking on the topic diabetes support system in developing countries. Irina Vlesenko is board member, International Diabetes Federation Europe Regional from 2015 to 19. Irina Vlesenko, PhD of Pharmacy, is Associate Professor at the National Medical Academy of Postgraduate Education at Ministry of Health of Ukraine. She has research interests are pharmaceutical care for people with diabetes, reform of healthcare, the development technology of new complex action medicine, of treatment, chronic wounds, diabetic foot wounds, for dentistry, the therapeutical education for people with NCDs, ethical aspects of right of patients, including in clinical trial. Dr. Irina Vlesenko is responsible for editor of scientific pharmaceutical journals, editor of Diabetes of Lyme. She has 155 publications. She is member of the National Diabetes Council, member of multidisciplinary working group of draft medical technologies, documents of standardization of medical care on diabetes type 1 and type 2, member of Public Council of Ministry of Health of Ukraine, Deputy Chairman of Public Council of the State Administration of Ukraine on Medical Products 2011 to 2013 edition, if it needed, from 2003. Irina Vlesenko became the active member of the strong team of Professional Ukraine Diabetic Federation. She has big experience in organizing camp, International Youth Camp Forum 2006-7, educational camps for adults 2008 to 2011. She is advisor of Youth Leadership Camps, IDF Europe 2016-17. She is educator, self-management school for people with diabetes since 2008. Director of First International Football Championship for people with diabetes, DIA Euro 2012. Member of International Organizing Committee, DIA Euro International Futsal Championship for people with diabetes 2012-2017. Vlesenko Irina is member of Executive Committee of Association of Football of Invalids in Ukraine. We welcome you, Irina Vlesenko, and please go ahead with your talk.
Thank you so much for kindly introduce me, Dr. Dr. Irina. I'm very happy to be attend this conference, and I'm really honored to be a part of this great symposium about very important things like style of lifestyle. And my thank you and congratulations to Dr. Bansha and Diabetes India team for great event, successful event, and a lot of attending people who got a lot of knowledge in this area. I think that unfortunately our treatment is not only focus. We cannot only focus on treatment and education as professional. Unfortunately, treatment is a big complex, and I'll try show a little bit additional things which we can use for support our diabetes care. I just try to share my screen. It's okay?
Yes, ma'am.
Thank you so much. I think during last 30 years, we can see significant economic growth in development countries. Significant economic growth leads to many things like urbanization, mechanization, increase of multinational food company, increase influence. And this is change to physical activity, greatest push power, fast food, and food choice behavior. I make these slides especially to show how it's big complex and how difficult to influence on every every step. And in this case, diabetes in the developing country is a big problem. And you can see now it's a repeat acceleration of type 2 diabetes. The budget of complication, both macro and microvascular, is substantial. The syndemic of diabetes, which HIV and tuberculosis now are prevalent and predisposed to each other. Screen for diabetes in large population may be not cost effective. The cost of diagnosis and scrutiny on health staff pose handlers in the diagnosis and treatment of patients, lack efforts for patient for prevention of diabetes, and quality of care is largely poor. Most patients do not achieve treatment goals, delay in screening, seeking, and high cost and non-available of drug and insulin. And this is a reality situation. And what we can do, of course, we must change this situation, building political commitment and addressing health system constraints, development public policies in health promotion and disease prevention, creating new services, delivery model, and access to care, having guidelines for prevention and diabetes management. And this is not only creative, we must implement to real life, and we must see in real life outcomes. And I hope that this new documents which now publish and launch the WHO, the Global Diabetes Compact, help to us bring again our diabetes to agenda, political agenda and Ministry of Health agenda. I want to propose some innovative and low-cost approaches which can help to our diabetes care and support. Use mHealth. According to the WHO, there are up to 7 billion mobile phone users in the world. This is 85% of the world population, and 70 of them live in low and middle income country. Use mHealth application because appear to be a cheap and acceptable method for lifestyle modification and prevention of diabetes, improving medication adherence and H1C and self-monitoring on blood glucose and other diabetes-related behaviors. And use the mobile technology which reduce the cost associated with the inaccessibility of medical care and reduce the cost of repeated hospitalization by 55%. Mobile diabetes retinopathy screening and treatment model are cost effective. And I want to show a picture from real life. This is our project, which was organized by and held the Ukrainian Diabetic Federation, which named it To See the World in Color. And this is a great opportunity to check screen eyes in rural area, because you know Ukrainian big territory, and this is some of patients have not good access to care, and especially like specialists, like ophthalmologists, and this is really cost effective and give possibility to help our patient. And another innovative and low-cost approach, it's delivering healthcare to the doorsteps. That you can see a mobile diabetes center project was launched in 2002 in Russia, and it was still continues this project with maybe with new task and new they use for research also, for data collection, for how to improve this. It's many opportunity uses this delivering healthcare to the doorstep. And this case, patient with diabetes can be examined and get consultation from all specialists. Also, patients are invited to diabetes self-management school. This is a good collaboration with a partner, because this is support by Novo Nordisk. Another approach, you can use volunteering. You can use collaboration with your diabetes association. I was invited to one webinar with youth, and I was really impressed with how they explain how they help during COVID time all elderly people with diabetes deliver food, because they cannot go out. And this is a great opportunity use this volunteering movement. This is a slide from my friend from Cuba, Manuel Vera Gonzalez. He was in Ukraine a few years ago, and he told about how they make which main public politic to face the epidemic of diabetes of Cuba. And you see they cover whole country with diabetes center, but also they use media very much and promote health and prevention risk factor, prevention of diabetes complication. They use sports center and recreation area for the practice of physical exercise in population. Incorporate physical trainers to guide the practice of physical exercise in sports center, family medical office, diabetes care center. This is give result. Mortality indicator decreased and decreased the risk of patient amputation with diabetes food and I have all the time promotion this idea, but I think we not enough use many resources which we have. We have very good doctor resource and specialists with another close area like nutrition and dietitian. Now we speak about this, and we used very good nurses, educators, but from my side, we not use enough paramedic pharmacists who is really has good education in this area and can help to us. And I find very good term from our colleagues from China, I think. Innovation care models, task shifting, provision of basic care and assistant care by other health professionals. And we have a lot of publication on this area that intervention by other healthcare professionals is very successful. For example, lifestyle education led by other nurse, pharmacist, dietitian, maybe as effective as that led by a physician for the prevention and management of diabetes. Using non-physical care coordinators on decision support with electronic health record in resource challenges, clinics show improvement in lipid, blood pressure, and glucose level. And of course, a lot of publication which show that great input intervention by pharmacists. What they can do. This is also low-cost approach. What can do pharmacists do in diabetes prevention? They promote awareness about diabetes, screen, test, refer patient, promote lifestyle changing, but my main thing they have a lot of conversation with patient contact, but they help to us achieve these people, and they refer a patient, go to next step, go to doctor if you have some problem. And this is from my practice. With my student, we organize Diabetes Day in Pharmacy. I make this from 2003. I take this initiative from another country, but this is very successful, and it's people now it's looking for this day, but it's not only one day. This is like 1 week, because economical effect for pharmacy also. And this is, I think, is a great opportunity for and low cost approach with nothing cost for spread environments and screening. And I want to say you that now IDF start update our collaboration with International Pharmaceutical Federation. This is big organization for pharmacies. And now IDF was involved in development this nutrition and weight management service. Maybe you will be interested and look on this document as nutrition. And I was happy that I was involved in launch on this document. It is very important for us work together, because sometimes it's like parallel line, doctor and pharmacist, but we must be together and have and take these goals, our goals together, because this is, we have a lot of resource, scientific resource and patient resource, really result of treatment, and that we can help to each other. If we speak, if we speak about prevention, we speak about diets, physical activity. But what one of this innovative and low-cost approaches strategy using legal framework of governmental action, including taxation. And the tax on sugar, sweetness, beverages could reduce the prevalence of overweight and obesity, as well as introduced incident risk of diabetes too. IDF framework for action on sugar. This is IDF support WHO conditional recommendation to reduce recommended sugar intake till 5%. And this is public health campaign to educate people about the health risk association with excess sugar intake. This is big strategy. We speak today about physical activity. And it was extremely great talk about how we can improve this prescribing and motivate people. I think it's also one of low-cost approach that school-based intervention program for nutrition and obesity, because early in life, when eating and physical activity habits are established, and when the long-term regulation of energy balance may be programmed, there is a specifically critical window to prevent obesity and type 2 diabetes. But unfortunately, lifestyle intervention is take time. And you know, it requests provisions of 4 to 6 months, weekly contact during the first several months. And we need support, feedback, and social support. And what we can do? We can use motivation with our diabetic association. And this is why I speak about, you remember, I big fan in football. And I find this great study from University of Copenhagen Nutrition that football can improve the health status of unfit men, reducing the risk of cardiovascular disease and diabetes. And furthermore, they're conducting a specific study that found that playing football great improving the health status of patients with type 2 diabetes. And how we can motivate, how we can please, this is DA Euro. This is football championship. The public events are the effective mechanism for motivating people. And Ukrainian Diabetic Federation 2012 started this project, and now it's spread in Europe. And if from start it was eight team, but now it's 21 team, European team involved in this great event. And this is motivation. This is people try to save condition, because only in great condition people with diabetes have great result in sport. And finally, our diabetes support system, what is innovative and low-cost approach. It's collaboration with other health professionals and Diabetes Association, task shifting, school-based intervention program for nutrition and obesity, health promotion using mobile phone and or digital platform, screening care and care of diabetes-related eye problems using mobile ones, telephone ophthalmology, and using smartphones, diabetes diagnosis and care at those steps using mobile ones, bidirection screening, tuberculosis and HIV and diabetes, integration of diabetes control in communicable disease and also not communicable disease, lifestyle intervention of workplace, taxation on unhealthy food and some oils, and universal health insurance. This is main proposed to support diabetes care. Thank you so much for your attention.
Thank you very much. It was wonderful hearing you. Now,
yeah, thank you, Dr. Irina. And I think we are open for the question answer session. But let me tell you that this lifestyle session was, I think, the fitting finale to the whole conference of 3 days, because if you have attended all the 3 days, the bottom line was, the key message was lifestyle modification and with a special focus on nutrition.
Yes.
So I think a great session. Thank you all the speakers, and thank you, Dr. Banshi Sabu, for having planned this. So now we are open for questions.
Can I ask a question to Meenakshi ji?
Yes, sure, ma'am.
Okay. Meenakshi ji, how long does it take for a prebiotic or a probiotic to work? And if you start taking, how much long time you have to take for getting the results?
Ma'am, if you're talking of commercial pre and probiotic supplements, we still do not have adequate data to tell us that what is the therapeutic dose, what is the duration you're supposed to consume for it to do its job. Though there are several studies from as short as 4 weeks to as high as 12 weeks to tell us that there is an improvement in the metabolic variables, but the study sample size has been very, very small. And there is a lot of variation in the designs. So we still need more long-term trials to give us this information. Okay. That is why we have no choice but to rely back on our prebiotics in the kitchen more than the probiotics. It's the prebiotics which will do their job than the probiotics, because the prebiotics will in turn help synthesize probiotics.
Yeah, we understand, but commercially now they have advertising probiotics so much that what you told. And what are symbiotics? I've been heard
a combination of both pre and probiotic.
So that is a new term which has come up. Thank you so much.
So Meenakshi, what about curds? People keep talking about curds as a probiotic. So do you think that...
Ma'am, there is one research paper, I think I missed showing it in my presentation. There is a paper from CMC Vellore, I think way back in 2014, wherein they showed that already prepared curds, set curds fermented overnight over a period of 12 hours, they have probiotic activity.
Okay.
But I do not know, at least in South, there is a tradition of consuming old fermented, yesterday's rice fermented with curds overnight. So that has some probiotic activity. Recently, there has been a lot of halla on it. But there was this paper from CMC Vellore way back.
Rucha, there was a question from the audience, and they were asking that there are some bodybuilders who have a lot of muscles and who are going to the gym every day, but they are also having they are early age, they are getting diabetes. So what can be the cause and why they are getting it?
Of course, it's multifactorial. As I showed you in the very first slide, is that you cannot change your genetic background. And on top of that, what you do is, your environment and lifestyle. So just a word of caution is that a lot of these bodybuilders, and depending on if it's weightlifting, powerlifting, or bodybuilding, they do abuse anabolic steroids, testosterone, and several other hormones such as growth hormone that they do in a cyclical fashion along with other HCG and other agents to wash out in huge non-physiological doses. So they are over the top. And this is what has we see a lot of. In fact, we've had during the COVID era, they have not fared very well. We've had a lot of deaths. If you know the top contenders in India of power boarding, and we have lost one or two per month. It has been in the news. So this has been secondary to having underlying ventricular hypertrophy, and so they do develop. They go on to develop diabetes, coronary artery disease, if they don't do it the right way or continue doing it without supervision. So, it's a fair enough question. So stay away from, just stay natural.
Rucha, can I add with your answer? Of course, the genetic predisposition is very, very important. But most of the bodybuilders, what we see that once they stop doing the exercise and they are actually more predisposed for these metabolic disorders. Rather than a person who is in the low grade form, they continue with the exercises. They don't develop these type of predisposing with the metabolic disease. So that is the point, one thing. And the protein supplements with testosterone and anabolic steroids are very, very dangerous in producing these metabolic disorders.
I had a question in the chat box on dairy. Since Dr. Anju Virmani has asked me about dairy, but I didn't touch dairy and eggs because my topic was oils. So I would like to hear mention that certain oils like mustard oil is good for, I'm sure all of you know better, mustard oil is good, but the sharp odor. So we can do some genetic modifications, and I think canola oil is mustard oil only, but minus the odor. So you can actually have, but mustard oil is definitely good. And Dr. Anju Virmani asked if low-fat dairy is good. Yes, it will be a rich source of protein, and saturated fat will be low. So I think low-fat dairy is fine. But what is important is that no oil. So the message is clear that not a single oil is the best oil as far as a ratio of omega-3 to omega-6 is concerned, and we should be consuming everything in the right proportion. So that is the message from the various oils. Still, there's no consensus. Even coconut oil has saturated fats. If you take small amount of coconut oil, it is not bad. But if you take huge amounts of coconut oil, then that may result in increase in saturated fats through coconut oil.
Yeah, but it's very trendy to have extra virgin coconut oil every day. That's what
test coconut oil.
Yeah. So
Madam, we are talking about the total fats. That is very important. We are not talking only about the cooking oil. Dr. Meena has clearly told it is the cooking oil you can rotate, but there are some invisible oils in most of the other foods.
Yeah.
That is very, very important. So it is the total fat which is important as far as the disease is concerned.
No, yes, and that is why we must again reiterate, because a lot of patients have come with the pure trial.
A lot of
patients, and they are saying that they read the pure trial, and the pure trial categorically says saturated fats did not increase overall mortality, did not increase cardiovascular mortality. In fact, it decreased stroke. So, but that is not true. It's not true because it wasn't, they did not increase, sorry. But fats, they do increase. So we can't say they did not. It's important to know that in a poor country like India, if we say low fat, they might replace it with white rice, with with refined carbs. That is important. You have to replace the saturated fat with polyunsaturated fatty acids and MUFA, but not with the the carbs which are refined, or with multigrain, complex carbs high in fiber and fruits and vegetables. So that is the and the MUFA also has been interpreted as if only carbs are bad, and
we only have 4 minutes, otherwise we have to go to L4.
Can I just get 1 minute out of those 4 minutes?
Sure. Sure.
A couple of points. What I was talking about, Meena, was that you had made a point that some people criticize that the recommendations by saying it did not highlight the evil of saturated fat in milk. And if we have low fat milk, we should not look at milk as a bad source, because for us vegetarians, it's a very important source. Dr. Arvind Gupta made a very, very important point, which I think the stars of the show were the three dietitian talks. They were simply the best talks we had. But a lot of dietitians do not focus on total fats, which Dr. Arvind Gupta just emphasized. We don't take this history. We say, "Aap tel kitna use karte ho?" And they'll tell us the tail, forgetting about the mustard oil, the olive oil, the ghee, the butter, the full cream milk, and all of that. It's the total fat which matters. The total fat in most Indian kitchens is a complete disaster. And we'll end up with 2 to 3 kilos of fat per person per month, something which is never even asked in the history. And I would appeal to anybody who's looking after anybody in this country to take that history. आपके घर में कितने लोग हैं? How much oil do they use? How much mustard oil? How much butter? How much ghee? How much full cream milk? And then come to the conclusion that they should give some advice. My other appeal was in light of what was talked about by Dr. Gupta as well as by all the speakers, including for exercise, is that we as doctors should be requesting the government to open the parks and use the COVID crisis to say, please get out and exercise to increase your immunity. Instead, our politicians have locked us up and told us to have more screen time. And I think that's a crying need that as diabetologists, we should be asking the government to say, please give us access to the parks. Please tell us to exercise more. Thank you.
Yeah, with certain restriction of people at one go.
Absolutely. Stay away from crowds. But
Kavita, I have a question for you. Oh, sorry.
No, can I just add
Yes,
about
Yes.
because we can use now diabetes World Diabetes Compact WHO, that is very important new document, and then you can show it is like agenda in the world. Thank you.
Okay, thank you.
Anju ma'am, I would just like to add that for every patient we do take how we take a 24-night recall, we also take a recall of the amount of the oil what they are using. So how many people are they in the family and how much of oil or ghee or the fried foods what they are taking. So that is also like we calculate per day.
Half liter per person per month. But Kavita, she has a point. They will not tell us all the hidden fats. So the number of biscuits, cookies, cakes, they miss that. They tell us the oil that is used or the desi ghee, but they use margarine, butter, cookies, biscuits, cakes, and eat out, even creamers and coffee. You know, you go to coffee cafe day and all, and you eat all those, coffees. They have creamers. So these are all fats, hidden fats, or fats which the patient doesn't mention. So,
Ma'am, if you take a detailed food frequency questionnaire, I think you get all these details. So it depends on if you're going to spend at least half an hour to 40 minutes with each patient, especially it's a newly diagnosed type 2 DM or a pre-DM, I think you can do wonders with it.
We want you guys to help because now with virtual consultation, it's become easier for the nutritionists to be involved in management.
Questionnaire actually works and it helps us to give a clear picture of the consumption of the.
There is always underreporting in the questionnaire. Even in the pure trial, there's been this dilemma that underreporting of eating out, underreporting of how much you eat.
Meena, I am the part of pure study. I know the things very well, and we have done a lot of work for 6 years, follow up of this pure in the rural areas also and the urban areas also. I know the intricacies of that. But of course, there is a little controversy regarding in the pure study conclusion, which you have already properly told. But we should not go with that controversy. The message is very clear and loud that it is the total fat which matters a lot, and omega-6 omega-3 ratio which should be less than 4 if possible, but if it is possible less than 10 at least. So we should rotate the oils. You have actually clearly told about the intricacies of how the fats. So fats are not always enemies. They can be your friends also.
Yes, dairy, there is a lot of confusion. We have a cardiologist in my hospital, Gangaram, who just doesn't allow. He says milk is only for the infant and he stops. But I don't know what will happen to the bones because calcium, I don't know. So is dairy that bad? The dietitians are here. We can give milk fat.
Oh, yes, surely, ma'am. You can go in for skimmed. If you're not choosing on ghee butter, then probably 1 serving of whole fat milk. If you're not taking ghee or invisible sources of unhealthy fat, but that's very rare. So we usually tell our patients, whatever milk you're consuming, you buy it, boil it, keep it overnight in the fridge, remove the layer of cream in the morning, and then choose it if you cannot afford to buy skimmed milk.
Thank you.
I think we should come to an end, and it's already 5:30, and we have to shift to Alpha Hall. So thank you so much.
Thank you, ma'am.
Thank you very much.
Thank you so much.
Bye bye from
Thank
you.
you. Thank you. It was a wonderful symposium. Wonderful.
Thank you so much.
so much,
Great to be part of this
Great
section.
session. Absolutely.
Chairpersons
you
are
arrange
excellent.
an exercise
Chairpersons
guide?
are
We are
excellent.
available.
Excellent moderation.
Thank you, sir.
Thank you, ma'am.
Thank you, Dr. Rima
Thank you
and
so
Rekha.
much.
Yeah, thank you. Thank you.
Thank you for moderator.